예, 시간이 돼서 시작을 해야 될 것 같습니다. 오늘 토요일 스폰서 심포지움은 GSK 협찬으로 하게 됐습니다. 제목이 좀 저도 잘 몰랐었는데 이 제목이 이게 헬페스 조스타 예방하는 예방주사라고 합니다. 굉장히 비쌉니다만 마저 드시는 게 좋을 것 같습니다. 오늘 강의를 해주실 분은 용인 세브란스 병원 심장내과의 배성아 교수님입니다. 전남대학을 졸업하시고 전남대학에서 석사를 하시고 전자컴퓨터공학부 학사를 하셨습니다. 용인 세브란스 병원에 쭉 근무를 하시고 전남대학에서 봉사상을 받으신 적도 있습니다. 현재 용인 세브란스 병원 내과 조교수로 근무하고 계십니다. 배성아 선생님께서 강의해 주실 내용은 The Importance of Shingles Prevention in Cardiovascular Patient. 배성아 교수 준비됐으면 시작하십시오.
네, 소개 말씀 감사드립니다. 저 용인 세브란스 병원 심장내과 심장 초음파 심부전 파트로 일하고 있는 배성아라고 합니다. 사실 오전부터 이렇게 조찬 이렇게 심포지엄을 하는 게 쉽지 않은데 아마 많은 선생님들께서도 사실 오늘 이 스폰서 세션에서 이야기할 주제 이 싱글엑스에 대해서 이야기할 텐데요. 제가 사실 이 처음에 제목을 받아들고 이 싱글엑스를 잘못 작성했나 하면서 이제 싱글스라는 단어를 제가 잘 몰랐거든요. 그래서 찾아보니까 진짜 이 대상포진을 그냥 싱글스라고 하고 이 싱글엑스라고 하는 건 이 뒤에다가 이제 릭스를 붙인 거라고 그러더라고요. 그래서 이거 강의를 준비하면서 이 싱글스라는 저는 싱글릭스라는 단어만 알고 있었습니다. 그만큼 사실 저희 이제 카디올로지스트 관점에서는 조금 생소할 수 있는 부분이지만 또 굉장히 이 카드베스쿨 페이션트에서 이런 이 대상포진을 예방하는 게 얼마나 중요한지에 대해서 한번 강의해봤으면 좋겠습니다. 목차는 그렇고요. 진료 보다 보면 이제 뭐 이런 경우가 되게 많습니다. 그래가지고 환자분들이 이제 뭐 75세 여성분들 그렇게 어르신들인데 이런 뭐 하이퍼텐션, 당뇨, 뭐 고지혈증으로 이제 저한테 약을 받고 있는 그런 분들인데요. 보통 이제 남편이 이제 대상포진 걸려서 이제 고생한 거 보고 가슴이 철렁했다고 하면서 자기는 이제 뭐 전에 대상포진 백신 맞은 적이 없다고 해서 이제 이 옆에 사람이 이제 고생한 거 보고 자기도 백신 받고 싶다고 해서 왔는데 사실 이때 이제 뭐 의료진들이나 다른 가족분들이 고민하죠. 이제 꼭 백신을 맞아야 되나 아니면 안 맞아도 되지 않나 뭐 이렇게 고민하는 경우가 있습니다. 그래서 에비던스 과연 이 심혈관 질환자의 감염 질환 예방의 중요성을 좀 더 알아보면요. 사실 많은 우리 지금까지 인류를 구한 여러 가지 의학적 혁신들이 있죠. 뭐 마취제라든가 뭐 소독, 그 다음에 항생제라든가 이런 항암제, 항바이러스 이런 것들도 있지만 제일 중요한 게 또 하나 이제 제일 중요한 게 백신이죠. 다들 알고 계시겠지만 그래서 백신 자체가 이 전 세계 보건이라든가 경제적 이익에 뭐 예를 들어서 이 거의 1억 명 가까운 사망을 예방하고 뭐 유아 사망률 뭐 40% 감소 여러 가지 이 사회적 혜택이 굉장히 좋다는 거는 아마 많은 책에서나 이런 거 많이 경험을 하셨을 겁니다. 그런데 문제는 이 감염성 질환에 걸릴 위험들이 더 높은 환자들이 결국 만성 질환자거든요. 그래서 이런 특정 감염성 질환이 이제 감염으로 인해서 합병증 가능성이 높이고 이러한 것들이 또 만성 질환을 악하기 때문에 이게 어떻게 보면 원인이자 결과로서의 이 매개체가 또 감염성 질환이기 때문에 어떻게 보면은 이렇게 고령인자라든지 만성 질환이 있으신 분들은 관리가 무조건 중요하겠습니다. 그래서 사실 저도 이제 심부전 환자들이나 뭐 당뇨 환자들도 보게 되지만 제일 중요한 거는 질환이 악화되는 경우도 이제 이런 사망률 하지만 또 감염으로 인한 것들이 또 심부전을 악화를 시키고요. 당뇨 자체도 이제 어떻게 보면은 이 감염 자체가 합병증 증상을 시키고 또 이런 것들이 당뇨 조절이 잘 안 되기 때문에 질환이 악화되는 이런 악순환에 빠지게 될 수 있기 때문에 관리가 좀 중요합니다. 그래서 이런 우리가 이제 급성 심부전 원인이 굉장히 많죠. 그래서 우리가 흔히 말하는 이제 코로나리 그 신드롬이라고 어큐트 코로나리 신드롬, 우리가 MI 같은 이런 원인이나 아니면 뭐 에이픽 같은 이런 부정맥도 이런 심부전의 원인이지만 세 번째로 가장 어떻게 보면은 흔한 원인 중에 하나가 감염입니다. 그래서 감염과 동반해서 어떻게 보면은 사망을 할 수 있기 때문에 어떻게 보면 이 심부전의 첫 번째 원인, 세 번째인 가장 중요한 이 감염 관리를 잘하는 게 좀 중요합니다. 그래서 특히나 이제 감염 이렇게 환자들은 감염성 여러 가지 질환으로 인해서 여러 가지 심혈관 사건이라든가 허혈성 뇌졸중부터 해서 여러 가지 심근경색을 유발할 가능성이 굉장히 높습니다. 제가 이제 그때 아주 안타까운 사건이었죠. 가지고 어떻게 보면은 이 코로나 시국 때 이제 경북대에서 어떻게 보면은 이 의료진이 한 분이 이제 59세 정말 어떻게 보면은 지금 나이로 보면 굉장히 젊은 축에 속하는 이런 의료진이신데 이때 이제 코로나 의심 증상 보인 후에 이제 확진 판정 받았는데 결국에는 심근경색으로 스텐트 삽입도 받고 했다가 결국에는 사망하신 첫 사례인데요. 실제로 이제 코로나 시대 때 보면은 굉장히 이렇게 스파이크를 탁 치는 대유행을 하는 경우가 여러 번 있었죠. 그런데 그때 이제 제일 유행을 코로나 확산 주도한 게 젊은 층이었습니다. 그래서 젊은 층은 항상 말을 안 듣죠. 저도 밑에 분들 이야기해 보면 잘 말을 안 듣습니다. 그만큼 이제 뭐 건강을 이제 굉장히 과신하는 경우가 있는데 제가 이제 예전에 코로나로 논문을 썼을 때에도 이런 카드베스큘라 디지즈가 있을 때 젊은 사람들 당연히 프리밸런스가 낮지만 이런 분들이 결국에는 젊다 하더라도 이런 카드베스큘라 디지즈가 있는 군들은 시비어 코비드라든가 데스 사망할 확률이 굉장히 높다. 한 7배 정도 높다는 것을 보여줘서 젊다 하더라도 이런 질환이 기저질환이 있는 분들은 굉장히 위험하다라는 것을 페이퍼에 썼었는데요. 그만큼 이제 기저질환이 있는 분들이 굉장히 취약하다는 것을 보여주는 페이퍼겠습니다. 또한 이제 뭐 염증 수치 다들 중요하시겠지만 이런 여러 가지 염증 수치를 쿼타일로 봤을 때 이 여러 가지 이 LDL 콜레스테롤도 당연히 이제 LDL 콜레스테롤 높으면 높을수록 예후가 안 좋다는 걸 볼 수 있지만 중요한 건 기울기입니다. 여기 보시면 CRP 이런 레벨이 이게 거의 가장 높은 군이 거의 15, 18%를 예측을 하거든요. 이 사망이라든지 여러 가지 메이스 예측을 더 높기 때문에 다른 바이오마커 중에서도 이런 CRP라든가 이런 레벨들이 염증 수치가 이런 여러 가지 심혈관 위험증과 연관성이 굉장히 높다는 걸 볼 수가 있습니다. 실제로 케이스 이제 뭐 논문에 나왔던 케이스인데요. 이게 뭐 기저질환이 있던 뭐 이렇게 61세 환자가 복통으로 왔는데 알고 봤더니 이제 복부에서 이제 내장의 파종성 어떻게 보면 대상포진이 진단이 돼서 항바이러스 치료를 해서 이렇게 회복된 케이스인 것처럼 이렇게 기저질환이 있는 부분들이 이제 다양한 이제 이런 감염으로 인해서 악화되는 케이스를 볼 수 있겠습니다. 실제로 이제 이런 여러 가지 이렇게 기저질환이 있을 때 권장 백신들이 이제 여러 가지 인플루엔자, 폐렴국은 다들 이제 언급을 하고 계시겠지만 그 중에 또 강조를 하는 게 대상포진이겠습니다. 고위험군 이게 다들 알고 계시지만 뭐 고령이 되면 될수록 면역 체계가 노화되면서 아무래도 면역이 조금씩 떨어지고 또 이제 자체적으로 또 면역이 저하된 여러 가지 이식 환자라든가 이런 것들도 있고 또 만성 질환들이 많이 가지고 계시는 분들이 많을 텐데 이러한 것들이 또 어떻게 보면은 면역적으로 떨어지기 때문에 대상포진 발생 위험이 드라마틱하게 증가하는데요. 대개는 이런 심혈관 질환 자체를 가지고 있는 분들이 위험도가 뭐 예를 들어서 당뇨 환자들의 위험도가 3배 정도 증가한다 하고요. 이런 심혈관 질환이 있는 분들은 대상포진 걸릴 가능성이 또 1.3배에서 신부전 2배, 고혈압 위험도도 2배, 굉장히 드라마틱하게 올라가는 걸 볼 수가 있습니다. 그래서 당뇨가 이제 동반 질환이 있을 때 더욱이 드라마틱하게 올라가죠. 4배 이상 올라가기 때문에 이런 카드베스큘라 디지즈가 있는 군에서는 이런 감염성 질환, 특히 대상포진 같은 이런 질환들을 예방하는 게 굉장히 중요하고 이러한 또 이상지질증이라든가 당뇨, 고혈압 이런 아까 제가 말씀드린 케이스처럼 이런 세 가지 쓰리고를 이제 가지고 계신 분들 같은 경우에는 대상포진이 또 이후에 재발할 가능성도 굉장히 올라가기 때문에 어떻게 보면 반드시 관리를 잘 해야 되고요. 그 대상포진의 신경통이라고 하죠. 대개는 이제 대상포진 진단 후에 이 신경통이라는 게 30일이 있고 또 90일, 어떻게 보면은 또 150일이 있을 수 있는데요. 그 부분에 대해서도 이제 기저질환이 있을 때 이제 신경통 발생률이 더 증가한다. 특히 80세 이상에서는 거의 3배 가까이 증가하기 때문에 관리가 굉장히 중요하겠습니다. 우리나라 이제 데이터에서도 이런 심혈관 질환이 있을 때 대상포진 발병률이 높아간다는 걸 데이터를 보이고 있습니다. 그래서 사실 대상포진 저도 이제 가끔 환자분들이 이렇게 피부 질환이 있고 하고 저도 이제 전공의 때 한 우리 전공의 선생님이 한 분이 후배 선생님인데 여기 얼굴에 이제 이렇게 대상포진 크게 와가지고 되게 고생한 적이 있습니다. 그래서 되게 뭐 대상포진 중에 신경통만 있다고 하는데 대개는 통증이 좀 양상이 뭐 불에 타는 듯하고 욱신욱신한 통증이 있고 닿기만 해도 이제 쓰라린 통증이 있다고 피부 딱 보면은 알죠. 이렇게 조금 굉장히 이렇게 부풀어 오르는 이렇게 래시가 보이지만 굉장히 이렇게 피부 발진을 보고 아, 이 대상포진이겠구나라고 하는데 이러한 부분들이 이제 대상포진 환자의 이후에 신경통으로 발전하는 질환이 한 5에서 30% 정도라고 하고요. 아까 말씀드린 안부 대상포진, 눈을이나 이제 이 얼굴의 한쪽을 이렇게 침범하는 게 한 이제 10에서 15%라고 이야기를 합니다. 그리고 이 안구 쪽에 이제 대상포진의 한 30에서 78%가 이 눈으로 이제 침범을 하기 때문에 눈과 관련된 합병증이 발생을 하고요. 또 이제 뭐 1% 미만이지만 뇌에도 침범을 합니다. 그래서 여러 뇌경색이라든가 수막염을 또 일으킬 수가 있고 그 외에도 이제 뇌졸중이라든가 심근경색 같은 심혈관계 질환을 이제 일으키게 되죠. 그래서 우리가 이제 이 헤르페스 조스터 자체가 CV 위험도가 올라가는 이유 중에 하나가 이 혈전 혈발성, 이 자가 면역 항체를 형성하기 때문에 이런 것들이 결국에는 혈전을 잘 형성합니다. 이게 굉장히 덩어리가 크고 베스큘러 리모델링이 오는데 베스큘러 패시와 함께 인플라메이션이 되기 때문에 덩어리를 잘 만드는 거죠. 그렇기 때문에 이런 혈관 부조도 변하고 어떻게 보면은 여러 가지 자가 면역의 위험도가 올라가는 거고 그러다 보니까 이제 머리도 막히고 심장도 막히고 여러 가지 위험도가 올라가는 것을 알려져 있습니다. 그래서 이런 대상포진 자체가 또 위험증 아까 말씀드린 덩어리로 올라가기 때문에 어떻게 보면 발생 후 시기부터 해서 12개월이 지나더라도 이런 리스크가 계속 잔존해서 남아 있기 때문에 대상포진 발진 후에 어떻게 보면 괜찮네 하고 그냥 가만히 있다 했는데 5개월 후에 이렇게 스트로크가 오는 경우가 많기 때문에 결코 안심할 수 없는 그런 상태라는 것을 어떻게 보면 알고 계시는 게 중요하겠습니다. 특히나 또 심방세동 위험도 47% 정도 올라간다 하고요. 그 외에 또 뭐 2년 이내에 특히나 한 위험이 거의 한 100배가 넘게 증가하기 때문에 어떻게 보면 헤르페스 조스터 자체가 굉장한 카디오바스큘러 리스크를 올린다는 거고 이런 후유증이 있을 때 중증 대상포진 걸릴 때 단기 사망률이 거의 2배 가까이 올라가기 때문에 굉장히 좀 관리가 좀 중요하겠습니다. 그래서 지금도 이제 뭐 이런 디지즈에 따라서 이런 리스크가 다 올라간다라는 걸 보여주는 데이터고 결과적으로는 심근경색 위험도도 대상포진이 있을 때 어떻게 보면은 1.3배 정도 증가해서 정리해 보면 뭐 스트로크, MI 발생률 50%, 코로나 디지즈 2.9배부터 해서 사망률이 이렇게 거의 2배 가까이 증가하기 때문에 이런 우리가 지금 심혈관 질환에서 이런 대상포진이 발병을 했을 때 굉장히 예후가 안 좋아질 수 있겠구나. 라고 꼭 환자분들이나 인지를 하고 계시는 게 중요하겠습니다. 오늘 이제 말씀드린 이 싱그렉스에 대해서 개발 배경을 보면은 이제 사실 그 전에 이제 치료나 급성대증 치료 같은 경우 항바이러스를 72시간 내에 투여하는 게 굉장히 중요하고요. 또 하나 이제 뭐 관리, 뭐 진통제라든지 이런 여러 가지 그 피부의 발진 치료도 중요하지만 그 다음에 이제 예방이 또 중요하죠. 그래서 이전만 하더라도 약독화 이제 이 생백신이 있었는데 이제 유전자 재조합 대상포진이 이제 싱그렉스가 나와서 굉장히 도움이 많이 되줍니다. 이전에 이제 생백신이라고 해도 이 약독화이기 때문에 그래도 생백신입니다. 그래서 굉장히 어떻게 보면은 리스크가 조금 있는 상태이고 가장 중요한 게 예방 효과가 예전만 하더라도 60%에서 고령 같은 경우에는 40에서 18%밖에 이제 그 보호가 안 되기 때문에 예방 효과가 거의 많이 없다고 이렇게 알려져 있었고 많은 선생님들도 이거 물음표가 좀 있었었는데 요새 나온 이 싱그렉스 같은 경우에는 예방 효과가 97%로 굉장히 높습니다. 그래서 고령 80세 하더라도 90%가 넘고 그 신경통 예방 효과가 젊은 분들은 100%입니다. 100%. 70세 이상도 90% 가까이 되고 하니까 이런 대상포진 신경통이라든가 이런 대상포진 자체를 예방하는 게 90% 이런 약들은 굉장히 어떻게 보면 도움이 많이 되는 거죠. 그래서 국내 허가 사항으로는 50세 이상의 성인의 이런 면역저하자라든지 이런 것들에서 허가 사항으로 안내되어 있습니다. 이런 이유 중에 하나가 기존에 이제 면역 반응에 있어서 항원을 당연히 넣지만 여기다 면역 증강제를 넣기 때문에 이 기본에 이제 우리가 면역 반응만은 항원만 제공하는 것보다 면역 증강을 해서 좀 더 광범위한 면역 반응을 하기 때문에 장기로 이렇게 잘 이동을 해서 오랫동안 이 싱그렉스 자체의 효과를 계속적으로 장기 면역 반응을 유도하는 게 특징이겠습니다. 그래서 접종 연령에 대해서 기존에 있는 연구들을 보면은 16,000명, 14,000명 둘 다 NEJM에 실렸고요. 한국인도 포함되어 있는데 50세 이상과 70세 이상의 유효성을 봤는데 보시면 97%를 어마어마하게 예방 효과를 유효성을 입증을 한 백신입니다. 그리고 이런 기저질환에 따라서도 뭐 특별하게 더 떨어지지 않습니다. 특히 관상동맥 질환이 있을 때 이런 예방 효과가 97%로 굉장히 드라마틱하게 효과를 예방 효과를 보여주고 있고요. 특히나 이제 기저질환의 뭐 수를 굉장히 많은 6개까지도 가지고 있는 이렇게 굉장히 많은 질환을 가지고 있지만 이런 분들도 90% 이상 예방을 하기 때문에 굉장한 예방 효과를 가지고 있는 백신이라고 볼 수가 있고 위약군에게 있어서 뭐 특별하게 심각한 부작용을 일으키는 이러한 부작용도 없었기 때문에 안전하게 사용할 수 있을 거라 생각합니다. 특히 이제 접종하고 나서 그러면 좀 언제까지 이게 효과가 좀 지속될 건지에 대해서 물음표가 있을 텐데 11년까지 추적 관찰한 데이터가 연구가 있었는데요. 보시면 11년간 추적했을 때에도 87%나 유효성이 계속 남아있다는 거죠. 어마어마하게 거의 10년 넘게 이 효과를 입증을 한 거기 때문에 어떻게 보면은 장기간 한 번 맞고 나면은 잊고 계시다가 특히나 이제 한 70대, 80대 분들 같은 경우에는 평생 동안에 한 번 맞으면 거의 좀 효과를 계속적으로 좀 유지를 할 수 있지 않을까 생각이 들고요. 통계학적으로도 예를 들어서 뭐 백신 맞고 나서 한 30세 이제 통계학적으로 분석을 한 건데 한 50% 정도까지 이렇게 떨어진 게 거의 한 30년 정도 지나거든요. 그렇기 때문에 50세 정도 접속했을 때는 한 50년 정도 지나면 이제 백신 효과가 소실될 거기 때문에 아마 계시는 이제 그 고령 지내면서 이제 생활할 때 이거 한 번 맞으면 어느 정도 효과가 굉장히 계속 잘 유지하는 게 특징이겠습니다. 이제 뭐 많이 처방해 보신 분들도 계시고 또 처방을 한 번도 안 해보신 분들도 계실 텐데 이제 이거는 그 우리 다 백신 우리 일반적인 주사 맞듯이 이제 삼각근 주사를 해야 되고 총 2회 맞아야 됩니다. 그래서 첫 번째 맞고 나서 2개월에서 6개월 사이에 할 수 있기 때문에 그리고 이제 아무래도 이제 뭐 짧은 간격이 이로운 경우 예를 들어서 면역이 좀 저하되어 있거나 억제돼 이런 부분 쉬운 부분들 같은 경우에는 1, 2개월에 할 수도 있지만 대개는 한 2개월에서 6개월 해서 저도 이제 한번 처방을 하고 그 다음에 한 기록을 한 다음에 3개월 정도 후에 외래 와서 또 한번 맞고 가시라고 말씀을 드리거든요. 그래서 그리고 이제 다른 부위 예를 들어 인플루엔자라든지 폐렴구군이라든가 다른 백신에 대해서도 서로 다른 부위 동일한 날짜에 투여를 할 수가 있기 때문에 인플루엔자랑 같이 맞아도 되냐라고 하면은 괜찮다라고 설명하시면 됩니다. 특히 이제 이런 고민하는 경우가 있습니다. 그 예전에 대상포진 걸렸는데 대상포진 백신을 다시 맞아도 되는가? 되게 걸렸으니까 안 맞아도 되지 않나?라고 생각할 수 있지만 대한감염학회에서는 급성기를 지난 환자들이 있어서 어느 정도 백신 접종이 가능한 컨디션이 이제 좀 회복이 되고 괜찮으면은 다시 이제 대상포진 백신을 접종할 수 있다라고 알겠습니다. 그래서 여기서는 이제 조기에 이제 백신을 접종하기보다는 한 1년 정도 좀 후에 회복이 정확하게 된 후에 이제 접종을 고려한 것이 바람직하다라고 이야기했는데요. 그만큼 대상포진이 걸렸던 사람들도 맞을 수 있다라는 게 이제 이야기를 해주시면 되고 또 이제 예전에 생백신 맞았던 분들도 이제 다시 또 이 지금 싱그렉스를 맞아도 됩니다. 그렇기 때문에 이런 연령이 증가할수록 그 아까 보면 한 70대, 80대 그 생백신 맞은 분들 예방효과 10% 나오거든요. 그렇기 때문에 이런 부분들에 있어서 예전에 맞았던 분들도 또 맞았다. 그래서 예전에 생백신을 접종했든 아니했든 대상포진을 알았던 관계없든 무조건 맞으시면 되겠습니다. 또 이제 진료실 현장에서 설명할 때 부작용 없는지 이제 쭉 설명을 해야 됩니다. 왜냐하면 또 맞고 나서 또 이게 어떤 부작용인지 모르고 계셨다가 환자분들이 또 컴플레인하는 경우가 있거든요. 아이고 막 아프다고 해서 이런 분들인데 과연 그럼 맞고 나서 부작용을 뭘로 설명하면 될까? 일단은 기존에 있는 데이터를 보시면 기존에 이제 그 최대 7일까지 국소 이상 반응이 대부분 이제 경증으로 보고 있는데 통증이 이제 맞은 부위 통증이 조금 있었다고 해서 그게 한 1일에서 3일 정도 해갖고 그 외에 이제 레드니스라든가 스웰링이 좀 이렇게 좀 드물게 좀 보고하고 있기 때문에 조금 맞은 부위가 좀 통증이 한 하루 이틀 정도는 갈 수가 있는데 한 3일 내에는 소실이 되기 때문에 저 같은 경우에는 이런 통증이나 혹시나 있으면 타이레놀을 한 이틀 정도 드시면 됩니다 하고 처방을 따로 좀 해드리긴 합니다. 그러면 환자분들도 특별하게 컴플레인 없이 잘 맞고 가시는 걸로 알려져 있습니다. 그리고 전신 이상 반응, 예를 들어서 퍼티그라든가 다시 뭐 맞고 나서 피버라든가 헤데이크, 뭐 마이알지아, 시버링 같은 리스크는 거의 한 30%, 50% 미만으로 보고는 하고 있지만 제일 중요한 게 이런 플라시보에서도 조금 보이는 게 봤을 때는 제가 봤을 때는 퍼티그는 이 정도만 조금 약간 하루 이틀 정도는 너무 무리한 활동을 하지 마시고 좀 쉬시라고 이렇게 언급만 하시면 크게 문제는 없을 거라고 생각이 듭니다. 그래서 대개는 뭐 백신에 대해서 다 알고 계시겠지만 맞고 나서 뭐 이상 반응이 있는지 보고 그 다음에 접종 당일에 조금 너무 무리하지 않게 하고 2, 3일간은 너무 무리하지 마라라고 이야기를 하고 만약에 이제 너무 이렇게 심각한 증상이 있으면 뭐 병원 진료 받으라고 하지만 대개는 뭐 타이레놀 정도로 대부분 다 컨트롤이 되기 때문에 너무 걱정은 안 하셔도 될 것 같습니다. 그래서 이런 감염학회 가이드라인에서도 생백신 말고 대상포진 제조합 대상포진 백신을 우선 공고를 하고 있고요. 면역자에서도 이렇게 대상포진을 이제 예방 접종을 할 것을 공고하고 있고, 미국 심장학회에서도 공고를 하고 있고요. 특히나 이제 심장 질환 환자에서 이런 예방에 대해서 잘 모르는 경우가 많습니다. 그리고 환자분들이 어떤 또 주변에서 알고 오는 경우인데 또 의료진이 굳이 맞아야 되나 이렇게 고민하는 경우가 있는데 저희도 이제 잘 알고 있어야 되고 환자분한테도 이게 얼마나 이 맞는 게 중요하다는 거를 설명을 하는 게 굉장히 좀 중요합니다. 우리나라 이제 당뇨병 진료 지침에서도 이러한 대상포진 백신에 대해서 꼭 맞을 것을 공고를 하고 있고요. ADA 미국 학회에서도 이전에 맞던 것에서 그 우리 싱글엑스 맞을 것을 공고를 하는 것처럼 대부분 가이드라인에서 이제 이 지금 싱글엑스 맞을 것을 다 권장을 하고 있는 게 특징이고, 이 백신이 굉장히 지금 59개국에서 허가되고 16개에서 단독 사용할 정도로 어떻게 보면 굉장히 핫한 백신입니다. 그렇기 때문에 굉장히 중요한 백신이고 우리나라에서도 뭐 이렇게 국내 시장 점유율 98%라고 하는 것처럼 굉장히 드라마틱하게 지금 런칭이 되고 있습니다. 그래서 특히나 이제 뭐 환자분들이 이런 예상복 백신에 대해서 중요성을 그냥 언급을 안 하고 아니면 그냥 가만히 있는 거라 배너라든가 질환 안내서라든가 이런 거 한마디라도 이야기했을 때 백신을 거의 한 43배 잘 맞춥니다. 그래서 의료진들에서의 권고 이거 맞아도 되냐 하면은 이거 맞으면 좋다라고 한마디만 하는 것도 환자분들이 더 잘 맞게 되는 계정입니다. 물론 이제 비용이 좀 있을 수 있겠죠. 알고 계시겠지만 뭐 20만 원대라고 하지만 저는 환자분들한테 이거 그 대상포진 걸려서 고생하는 것보다는 이거 2번 맞아가지고 예방하는 게 한 95% 이상 예방 효과가 있기 때문에 맞으시면 진짜 좋습니다라고 설명을 꼭 드리거든요. 그래서 저희 장인어른, 장모님도 다 맞춰드렸습니다. 네, 그만큼 또 신보전학회에서 이제 감염 예방 교육 자료도 쓸 수 있기 때문에 이런 것들 활용하시면 되겠습니다. 마지막 슬라이드고요. 대상포진 아까도 말씀드렸듯이 심혈관 발생 위험 유효하게 증가시키고요. 뇌졸중, 심근경색, 심방세동 여러 가지 이벤트를 발생시키고 또한 이 심혈관 질환에서 이런 대상포진이 자체가 또 혈전 형성하기 때문에 여러 가지 카드바스큘러 이벤트로 올라가는데요. 이런 싱글엑스 자체가 이런 최대 97%로 거의 어마어마한 예방 효과. 특히 이제 그 대상포진 걸리고 나서의 신경통은 거의 100% 가까이 효과를 보이는 거기 때문에 꼭 맞는 게 중요하고 많은 가이드라인에서도 이런 싱글엑스에 대해서 이제 가이드라인에서 꼭 맞을 것을 공고를 하기 때문에 의료진들에서도 이러한 것들에서 잘 알고 계시고 환자분들한테 공고를 해주시면 좋을 것 같습니다. 네, 경청해 주셔서 감사합니다.
네, 수고하셨습니다. 아침 강의를 가볍게 들을까 생각했었는데 이게 고혈압, 당뇨, 심부전에서 리스크 레이시오가 1.2 내지 1.3 이상이라면 좀 심각하게 생각해야 될 것 같습니다. 회사에서 많이 나오셨는데 혹시 추가하실 거 있으면 하시죠. 없어요? 이거 50년씩이나 가면은 한 번 맞으면 그다음에 다시 안 팔릴 거 아니에요. 한 10년만 가게 만들었는 게 좋지 않았을까요? 아니 50년이면 한 번 1,000만 명이 한 번 맞으면 그 다음에 다시 안 맞잖아요. 50년 동안.
그렇죠.
농담입니다. 예, 수고하셨습니다.
감사합니다.
Whatever you want, whatever it is. in Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
계속 이제 눌러야 될 거예요. 그쪽이 이제 더 커진다.
Good morning, ladies and gentlemen. Welcome to this session. The topic of this session is hypertension in older adult, common and difficult problems. My name is Jae-Yong Park from Chungnam National University, and my co-chair is Kwang-il Kim from Seoul National University. I will introduce two topics, and he will introduce another two topics and panel discussion. The first speaker is Athanasios Benetus from France. His topic is specificities of hypertension in older adult. Professor Athanasios Benetus graduated from the medical school of the University of Athens in 1980 and obtained his PhD at the University of Paris 6 in 1994. Professor Benetus is qualified in cardiology and geriatric medicine, and he has authored more than 454 papers published in peer-reviewed scientific journal, and his Google Scholar H-index is more than 100. Professor Benetus, please.
Thank you very much, Mr. Chairman. Ladies and gentlemen, dear colleagues. Yes, I will speak this morning. This first lecture is on the specificities of hypertension in older adults. And I would like to start with a very old slide, actually, published almost, as you can see here, almost 50 years ago. Data from the Framingham study in Boston, in the Boston area. And this is about the evolution of blood pressure during aging. And as you can see here, what we see clearly, and for that time, of course, now we know that very well, but this was one of the first times this issue has been, let's say, shown clearly, that both systolic and diastolic blood pressure go up during our life from birth to about 60 years old. They concomitantly increase, mainly due to increase in peripheral resistance. And after that, after the age of 60, 65, systolic blood pressure still goes up with age, but diastolic blood pressure goes down. And I will show you now, I will come back to this slide, of course, later, but I will show you another slide of a study we published more than 25 years ago. And this is data, epidemiological data from two distinct cohorts. We analyzed separately, we published together. And in both cohorts, we evaluated the mortality for a period of 20 years after observing the evolution of blood pressure during 7 years. And what we have seen in both these cohorts is that the highest mortality, which means here in these two curves, the lowest survival in yellow, okay, in both cohorts was those patients who, during the follow-up period of 7 years, the observation, they increase systolic and they decrease diastolic blood pressure. Okay, and you can see as compared to all other evolutions of systolic or diastolic, this profile, increasing systolic, decreasing diastolic, was the most powerfully associated with higher mortality and cardiovascular mortality. So, which means that what we have seen here, when this phenomenon of increased systolic and decrease in diastolic after the age of 60, 65, the more pronounced increase of this delta, which what we call pulse pressure, the delta between the systolic and diastolic, this is associated with highest cardiovascular mortality. And we know, you see, this is, let's say, the profile, if you see schematically curves of blood pressure, let's say in a person 45 years and a person of 80, it is something we see every day in our clinical practice. And people, so with time, systolic blood pressure goes up and diastolic blood pressure will go down. So the differential or pulse pressure increases a lot, as you can see here. So this clearly is due not to peripheral resistance increase, no. These changes after the age of 65, it's mainly related to the increase of large artery stiffness. So in young people with low stiffness, elastic arteries, when you have the contraction of the heart, systolic period, most of the blood actually it's blocked, let's say, not blocked, but it's due to the distension of the aorta, remains in the aorta during the systolic period. So only about 40% will go towards to the periphery, and then the rest is restituted during the diastolic period and goes towards the periphery in diastolic period. So this is why, since the elasticity is big here, we can have a rather not very important increase in systolic blood pressure here and a high diastolic flow and pressure during the diastolic period. And this is very important because you transform a discontinued, exclusively systolic flow and pressure from heart, because the heart sends blood to the periphery only during the systolic period, to a continuous flow to the tissues, what our tissues need. So this is important, but with aging, and some people with very high age-related stiffness, arteries are not so elastic, so much more blood flow will go towards the periphery during the systolic period. We have an increase in systolic blood pressure, and then since the distension of the aorta was not important, during the diastolic period is very few flow going to the diastolic period in the periphery, and you see this important decrease in diastolic blood pressure, especially protodiastolic, initial diastolic period, which is the period also that coronary arteries are perfused. So you see this is the typical change after 60, 65 years of old, different in each person, of course. And so this stiffness, we can measure it directly, mainly with the pulse wave velocity. I will not enter the details of these measurements, but it's a non-invasive, very common now. In your country, there are many centers doing that. And of course, the highest the pulse wave velocity, the highest the mortality, and so on. But also indirectly, we can measure that in people, especially after 60, with high pulse pressure, high differential pressure. What's important to know here, it's this arterial stiffness, as I said, is responsible for an increase in systolic blood pressure and concomitant decrease in diastolic blood pressure. So the difference, which is the pulse pressure, the difference between systolic and diastolic goes up, increases. But it's not the only change in blood pressure regulation, the hemodynamics, due to stiffness. And very schematically, we can say that this high pulse wave velocity is also related to what we call early wave reflections, and that come back towards the reflected waves towards the aorta during, again, the systolic period. And this is what we call induces a left ventricle aorta dismatching that makes that aorta has an extra charge when it's still, the aortic valves are still open during the systolic period. But also the other important alteration related to arterial stiffness, it's an impaired circulatory homeostasis. And as you can see, all these changes at the hemodynamic level have very important clinical consequences in the heart and the total cardiovascular system. Pulsatile stress will increase, of what I said here. Left ventricle will increase after load because of the increased pulsatile stress, but because also these wave reflections come back, as I said, very early, and this is an important increase of left ventricle after load. Oxygen consumption, the heart needs more blood, but we give the heart less blood because, as I said, during the initial diastolic period, when especially the coronary arteries are perfused, diastolic blood pressure goes down with stiffness. So the oxygen consumption, the consumption increase, the needs of the heart in blood increase, but the tissue perfusion is lower. And also this impaired circulatory homeostasis is responsible of an important blood pressure variability. So we are not talking about how aging influences blood pressure. It's not only the increased systolic blood pressure, it's all that. And it's all that is very deleterious for the heart. So this is something important to have in mind when we see an older person. But And yeah, one more slide. Of course, I will not again go to the details, but we know now many factors and many conditions that are responsible for an accelerated arterial aging, accelerated increase during aging of the arterial stiffness, which is, for instance, the diabetes plus microalbuminuria is maybe the most important factor that can accelerate as compared to a person, let's say, of 65 years old without any additional risk factors. Those patients with the same age, but diabetes plus microalbuminia, they have about 15 years added arterial age. Diabetes alone, 10 years. Metabolic syndrome, same thing. A permanent high blood pressure, 20 millimeters of mercury, will more or less correspond to the same problem, as well as 20 beats per minute of heart rate constantly. We have done longitudinal studies back in the 90s on that, and we have found also an important role of permanently increased heart rate. Obesity without metabolic factors is less important, and of course, high salt diet, especially when this high salt diet is administered early in life. You know, the kids that eat food very salty, and so on, fast food, this is factors also that can accelerate the age-related increase in stiffness. So now, I show you this slide back in this of 78, 50 years ago, and you see when we are talking about age evolution, at that time, around 75, we stopped. Because at that time, this was what we called old people. And people, now that's much more older people, and also those people who are 80, 85, 90 and more, they want to improve things, and we want to improve them things. So we are now interested also what happens after that age, because 71, 75, it's not really very old. So if we want to extend, of course, this is not this study, the data, but if we see what happens today, I mean, if we go further up to 100, what you can see that due to other factors, it's not the arterial stiffness this year, but it's mainly the comorbidities, frailty, polypharmacy, that make that blood pressure, both systolic and diastolic blood pressure, diastolic still already decreases due to the stiffness, but now, due to these other factors I present here, we will have a concomitant decrease progressively to the systolic and the diastolic blood pressure. And this is also another important issue we have to take into account when we measure blood pressure. And this can explain many observations. I give you just two studies. There are many, many observational studies. Several years ago, more than 10 years, we published that in a cohort, an observational study, showing that those in nursing homes, so very frail people, with low systolic blood pressure and several medications, especially at least 2 antihypertensive drugs, have a much higher mortality as compared to all other residents, according to blood pressure and medication treatment. You see here, and also this is very important study published 3 years ago, showing on the left here in blue, you have the relationship in old people, very after 80, in old people, the relationship between levels of blood pressure and cardiovascular events. What we can see in cardiovascular mortality. What do we see here? It's more or less what we see in let's say, mid-age people. About 140, 45 starts an increase in the risk according to the higher systolic blood pressure. But if you take the frail persons of the same age in this analysis, if you add the frail, you see that for the frail people, it's very different. Because the highest, the lowest the blood pressures, the highest the risk. So this is why I said these are observational data. In the very old people with frailty, with polypharmacy, you have to understand what does it mean low blood pressure. And this can explain also what we know in the literature. For instance, we say that there is no doubt about that. Hypertension, uncontrolled hypertension, high blood pressure is very important risk factor for dementia, for cognitive decline, even for Alzheimer's disease, which is a neurodegenerative disease, but it's also a vascular component. So, but the key word here is midlife hypertension. It's the hypertension we have early in age. And if we see some other studies, more recent, look at that. The incidence of dementia according to blood pressure levels, the highest profile, the worst profile for having dementia, what it is? It is when in middle age we have hypertension, and in old age, very old, we have hypotension. So this evolution, the reduction in blood pressure, is very deleterious. So you see the role of hypertension will change according to the age of the person. And of course, the most, let's say, the best profile is when we are well regulated without either hypertension younger or hypotension in older age. So my take-home messages for this last minute I have is when we measure pressure, we have to understand that people less than 60, but it's very schematic, maybe simplistic. I did that just for the purpose of this presentation and other presentations because I think it makes the same main messages. So what we have in less than 60 globally, it's increase high systolic and high diastolic are related to increase in peripheral resistance, first of all. And the relationship are positive for both systolic and diastolic blood pressure. And the youngest the patients, the most important the role of diastolic. And we're getting older, the systolic. When we go to the age 60 to 80, we will have an increased decreased diastolic due to stiffness, a large artery. I talked about that. So the relationship with systolic blood pressure remain positive of the risk, but with diastolic, it's either no relationship or even for coronary disease, most of the times, negative relationship. And if you go to very old people, and here you have start decreasing both pressures for the reasons I said. So in these patients, if you have diastolic, it's still meaningless most of the time. They don't add information than systolic. And systolic, if the person is robust, may be still positive, the relation, but in patients very frail, this relationship between risk and systolic blood pressure is absent or negative. And so I think it's important. The blood pressure regulation values are very important in older people. So measuring blood pressure is very important. But respecting rules for blood pressure measuring is even more important, because there is a big variability, changes from one minute to the other, from one position to the other, from one environment. So multiple respecting the rules of blood pressure measurement. And what is most important of all of them is try to understand, to interpret what these blood pressure levels say to us as a physician. And this is complicated, but reality is complicated. We have to understand the reality and not to try to oversimplify it. Thank you very much.
Thank you, Professor Panetos. I will introduce the next speaker. Next speaker is Professor Kwang-il Kim from Seoul National University. Professor Kim graduated from the Seoul National University in 1994. He is also qualified in cardiology and geriatric medicine. He is the president-elect in the Korean Society of Hypertension next 2 years. Professor Kim, please. His topic is orthostatic hypertension and hypertension in older adult, clinical significance and management strategies. Professor Kim, please.
Thank you, Mr. Chairman, and good morning, everybody. Today's my topic is the orthostatic hypo and hypertension, and I would like to focusing on the clinical significance and the management strategy. After standing, there is substantial shift of the central blood volume to the lower extremity, and it caused the decrease in the stroke volume and the cardiac output. And this change can be detected by the baroreceptor at the carotid sinus and aortic arch, and by way of the counter-regulatory system, activation of the sympathetic tone, the heart rate increase and the vasoconstriction, and this mechanism can restore the decrease of the blood pressure after standings. So in this slide, you can see that after standing, there are some decrease in blood pressure, but the increase of the heart rate and the vasoconstriction, the blood pressure restore immediately. But in some patients, usually older patient or patient with autonomic dysregulation problem, this decrease in blood pressure maintained throughout the period, so the patient complain of the hypotension-related symptoms such as syncope and falls. Actually, this phenomenon has been reported quite a long time ago, but in 1996, a consensus conference was held, and they decided to define a definition of the orthostatic hypertension as a decrease of systolic blood pressure more than 20 millimeter of mercury, and the decrease of diastolic blood pressure more than 10 millimeter of mercury within 3 minutes of standing. However, in this slide, you can see that many academic society propose a different definition of orthostatic hypertension, especially at the time I measured the blood pressure change and the position change from spine to standing or sitting to standing. There is quite a heterogeneous definition, so you should be very cautious when read the article regarding the orthostatic hypotensions. Although there is some confusion, but it is very clear that orthostatic hypotension is associated with poor prognosis. And this slide shows the result of the Honolulu Heart Program, which includes more than 3,500 Japanese Americans aged over 70 years old. And they reported that the prevalence of orthostatic hypertension increased as people get older, and the prevalence is about 10% in elderly people aged over 85 years old. And in this slide, you can see that there is a linear relationship between the decrease in systolic blood pressure after standing and the increased risk of the mortality. Also, the hypertension is a problem of the middle-aged adults as well as the older adults. And this data from ARIC study show that the orthostatic hypertension among the middle-aged adult is associated with increased mortality risk, and the hazard ratio is 2.4. Orthostatic hypertension is also related with other medical conditions, such as the fall. And as you know, fall is related with the fracture and the functional disability among the elderly people, so that is very important problem. And you can see here that the multiple episodes of orthostatic hypertension increase the risk of the all-cause risk of the falls. And interestingly, recent data suggests that the orthostatic hypertension is also a risk of cognitive decline or the development of dementia. This slide from the Swedish National Study on Aging and Care, and they enrolled about 2,500 older adults aged over 60 years, and they measured the blood pressure change after standing, and they reported that the orthostatic hypotension increased the risk of dementia when they follow up for 12 years. They reported that the orthostatic hypotension increased about 40% risk of the dementia development. And also they reported that the orthostatic hypertension increased the risk for the progression of cognitive decline from the MCI to the dementia. So when in clinical scenario, if the patient complains of any symptom related to the orthostatic hypertension, the first thing is to check the blood pressure accurately, especially measuring the blood pressure standing, spine, sitting, and standing position. And actually, there are lots of etiologic factors associated with the orthostatic hypertension, and so the next step is to identify what is the underlying cause of orthostatic hypertension. And in many cases, especially the older patient taking multiple drug, there is some causative drug show. The first step is to eliminate the drug. And other factors like the cardiovascular and the neurologic orthostatic hypertension should be assessed and excluded. There are very effective non-pharmacologic intervention for the patient who are having the orthostatic hypertension, and it includes eliminating the offending drugs such as alpha blocker and diuretics, and increase the fluid and the salt intake, and avoid getting up quickly and standing motionlessly, and applying some abdominal binder or something like that. And if this non-pharmacologic intervention is not effective, then we can prescribe some medication such as the increased intravascular volume or the sympathomimetic drug to increase the blood pressure after standing. Interestingly, recent meta-analysis data showed that the intensive blood pressure management can reduce the risk of the orthostatic hypertension. And they analyzed lots of randomized clinical trial, and they showed that the intensive blood pressure lowering can reduce the risk of the development of orthostatic hypertension about 7%, and this issue can be discussed further later in these sessions. And this slide also showed that in the postdoc analysis of the CIST-EURO trial, there is no change in the effect of the intensity of antihypertensive treatment for the development of orthostatic hypertension, although the prevalence of orthostatic hypertension is quite different according to the position change. The next topic is orthostatic hypertension, and I'm afraid that maybe you did not hear about the orthostatic hypertension, but in about 5 to 10% of elderly people complaining showed this phenomenon. So in contrast to orthostatic hypertension, some patients saw increase of blood pressure after standing, and if the blood pressure increased more than 20 millimeter of mercury, it is defined as the orthostatic hypertension. And previous study showed that orthostatic hypertension is also a risk factor of cardiovascular disease and increased mortality. And this slide, as Benito showed, this part is the quote, and this slide showed that comparing the normal response, the orthostatic hypotension as well as the orthostatic hypertension is associated with the increased risk of future cardiovascular events. And recent meta-analysis assessing the effect of the association of orthostatic hypertension and the future major adverse cardiac event, and they showed that the orthostatic hypertension is related with the 20% increase of all-cause mortality, and as well as the orthostatic hypertension is associated with the increase of the risk of stroke, about 2 times higher risk of development of strokes. And also the same the researcher, Professor Jurasek, analyzed the effect of the intensity of blood pressure treatment on the development of orthostatic hypertension, and the result is quite similar. So the intensive blood pressure lowering also decreased the development, the incidence of orthostatic hypertension as well, and the effect size is quite similar, and 7 points decrease in the risk of the development. And this slide summarizes the blood pressure trajectory change as people get older, As the Professor Benetton showed that as people get older and frail and the patient have any problem in maintaining the activity of their living, and in that point the blood pressure decreases. But the blood pressure variability increase in those frail and dependent patients, so the risk of developing the orthostatic hypotension or the hypertension increase. So in those very vulnerable patients, we have to be very cautious to treat and to modify the intensification of the antihypertensive treatment. And also, although the orthostatic hypo and hypertension is quite a different direction, the change of blood pressure after standing, but some researchers suggest that they have a very common risk factor, and the factor is the increased blood pressure variability. And as you know, the increased blood pressure variability is associated with the increased arterial stiffness. And this Rotterdam study showed that the orthostatic hypertension is related with the increased pulse wave velocity. So the frail elderly patients have increased arterial stiffness, and those factors are related with the increased blood variability and the position change blood pressure, position change related to the blood pressure change. Let me briefly introduce our previous result. The first one is Health Respect BP trial, and in this study we gathered blood pressure data from 6 long-term care facilities and about 400 patients during 1 year, and we analyzed the total amount of 150,000 blood pressure measurement, and you can see here that the mean blood pressure level is a little bit lower in physically frail and cognitive impaired patient, but the blood pressure variability is a little bit increased in those patients. So we can see that what is the most important and independent factor associated with the blood pressure variability, and we can see that the physical frailty is independent factor associated with the increased blood pressure variability in those very susceptible and vulnerable patients. And the second study is ongoing clinical trial, Howard BP trial, and in this study we enrolled more than 2,000 older hypertensive patients from 12 university hospitals in Korea. And the inclusion criteria is older patients having hypertension, but in maintaining the independent ADL. And in this study, we measured the blood pressure change after standing, and we defined the orthostatic hypertension as the decrease of the systolic blood pressure and 20 millimeter mercury, and the diastolic blood pressure more than 10 millimeter mercury. And also we defined the orthostatic hypertension as the increase of the 20 millimeter mercury after standing, and the final blood pressure is greater than 140 millimeter mercury. And we also measured the physical frailty, such as the questionnaire and gait speed and the hand grip test, and also we assessed the cognitive function using the MOCA tool and measured the health-related QOL. And the result that we found is that the orthostatic hypertension is more commonly observed in frail elderly patient by measuring the questionnaire, and also the orthostatic hypertension is more common in physically frail elderly people who have both the slow gait speed and weak grip strength. So we wanted to know that the independent effect of this physical frailty and cognitive function, and we can confirm that the frailty status is associated with the orthostatic hypertension. So my conclusion is that orthostatic blood pressure change is one of the clinical presentation of increased blood pressure variability, and that they have some common problems, such as the increased the arterial stiffness, but we have to investigate this topic further. So this is my summary, and both orthostatic hypo and hypertension is relatively common in older adults and have a very significant future cardiovascular risk. So the proper diagnosis, measuring the blood pressure accurately, and understanding the underlying cause and the effective management strategies, including the pharmacology and non-pharmacology intervention, are very important for the improvement of future prognosis. And it is important to individualize to the antihypertensive treatment, especially for the frail or dependent elderly people, because they are very vulnerable and they have very increased blood pressure variability. Thank you for your attention.
Thank you, Professor Kim.
Okay, I will introduce the next speaker. And next speaker is Masaki Mogi from Japan. Professor Mogi graduated Osaka University and received a PhD at Osaka University. And he was a postdoc fellow at Tufts University, and currently he is a professor in the Department of Pharmacology in Eime University. His topic today is the hypertension and dementia, preventing the next crisis in Asia. Professor Mogi, would you please start?
Thank you, Chairman. So, good morning. So today I'd like to talk about hypertension and dementias. So UC Berkeley and the Max Planck Institute showed an interesting result that half of the babies born in 2007 will survive more than 100 years. In South Korea also, average life expectancy will be over 90 by 2030, reported by BBC. And France and Japan is also up to 90s. So 100 years has come. But all older people is not healthy. So this is the causes of caregiving in the Japanese long-term care insurance systems, indicating that dementia is one of the most overcoming targets. And also this is a global problem. So you see 55 million people with is suffering from dementias. And by 2050s, maybe 3 times increase in dementias, especially in the region of Southeast Asia, Americas, and Africas. So therefore, we should make a strategy to prevent dementia as soon as possible. But we have new fundamental drugs against Alzheimer's disease, such as lecanemab and donanemab and so on. However, these drugs have expensive cost, applied only for patients in the early stages of Alzheimer's disease, and have some serious side effects, such as ARIA and even death. So the prevention is the most important things to overcome dementias. So here is famous figures published in the Lancet. So midlife hypertension and also another lifestyle disease is a risk for dementias. So if hypertension is eliminated, a 2% reduction in the incidence of dementia will be observed. So why hypertension induced dementias? So here are some mechanisms. So hypertension induced vascular degeneration, such as vascular remodeling, hypertrophy, atherosclerosis, induced the reduction of cerebral blood flow. The reduction of cerebral blood flow reduced the energy supply to neurons, resulting in impairment of neurovascular units. Therefore, hypertension-induced vascular degeneration induced neurodegenerative diseases. Of course, there are more mechanisms in hypertension-induced dementias. So, recently, the statement of the Japanese Society of Hypertension has been released from very recently. So title is Current Update on Latest Basic Research of Scientific Relevance in Hypertensive Dementias. So we insist in this statement, we use the new terms, hypertensive dementias. So in hypertension-induced dementias, so renin-angiotensin system plays an important role. So you see angiotensin 2 induced AT1 receptor activation and induced reactive oxygen species inflammation resulting in endothelial dysfunctions. And moreover, protective armor of the renin-angiotensin system, such as AT2 mass AT4 receptor, prevents dementia by the prevention of neuronal damages. However, there is many kinds of mechanism in the basically. So as shown this here. For example, microvascular dysfunction from atherosclerosis, endothelial dysfunction, and some impairment of channels in endothelial cells. And oxidative stress, so induced by not only angiotensin 2, but also NOx. And also neuroinflammation, which induced blood barrier disruption and the activation of perivascular macrophages and the microglia. So you can see the hypertension induced some amyloid beta dependent mechanisms. So interestingly, in the basic research show that hypertension impaired cerebral blood flow by angiotensin 2 only observed in Alzheimer's disease model. So this indicating that some association between hypertension and the amyloid betas. So moreover, very interesting, the results show that hypertension induced beta amyloid converting enzyme 1, base 1. So base 1, increase in the base 1 expression induced the reduction of eNOS activity and resulting in cognitive impairment. But there are two mechanisms there. So base 1 increased the amyloid precursor protein cleavage. This is more likely in Western Europe peoples. And another one is increasing the occluding cleavage. So this is very more likely observed in Asian people. So anyway, so base 1 expression is a very important thing. So I now it's a very important thing is to prevent the the total life course of vascular burden by hypertension. So we need to care about the total course of blood pressure burden may be reduced the age-related dementias. So does antihypertensive treatment prevent dementias? But probably yes. So this is a report published in the JAMA Network Open show that antihypertensive use was associated with decreased dementia risk compared with an untreated hypertensive patient through all ages in late life. Moreover, systematic review showed from the large clinical studies such as Progress, HiBET-COG, On Target, Sprint Mind, and so on show that blood pressure lowering has been expected to be effective to prevent the incidence of dementias. However, these are not interventional studies investigating dementia as a primary outcome. Moreover, long-term intervention trials are difficult. Therefore, actual beneficial effects are inconclusive. So how about the intensive treatment to prevent dementias? So here is a sprint memory and cognition in decreased hypertension, sprint mind studies. So these studies show that intensive blood pressure treatment significantly reduced the risk of mild cognitive impairment, MCI, but not probable dementias. However, intensive blood pressure treatment especially reduced the risk of amnestic and multi-domain subtypes of MCI, which have more risk of progression of dementias. So indicating that the intensive treatment of hypertension may prevent the first step of cognitive impairment. So this is a publication from Nature Medicine recently. So the China Rural Hypertension Control Project Phase 3 trial showed that intensive blood pressure treatment prevent not only a reduction of cardiovascular disease, cardiovascular events, but also 50% reduced risk of dementias. So indicating that intensive treatment of blood pressure may prevent dementias. Interestingly, intensive blood pressure treatment was associated with increased cerebral perfusion from sprint mind secondary analysis. So, however, intensive blood pressure control increased the risk of probable dementia in patients with atrial fibrillations. Moreover, orthostatic hypotension is a risk factor for dementia from the HYBET cohort studies. And recent publication in hypertension, sudden drop in blood pressure upon standing within 1 minute may serve as an early risk marker for dementia onset. Therefore, we need to use the antihypertensive drugs with low risk of orthostatic hypotension as shown in this slide. So finally, we showed some tips to see older hypertensive patients. So here is a cherry studies performed from the Osaka universities. So they observed the hypertensive patients in outpatient clinics without prior diagnosis of cognitive impairment. So they observed that 35% of older hypertensive patients showed a cognitive impairment, and 7.7% older hypertensive patients showed the dementias. So older hypertensive patients are at a high risk of masked cognitive declines, even if they are functionally independent. So we should care older hypertensive patients considering they have a cognitive impairment. Therefore, a brief cognitive function test should be administered to hypertensive patients aged more than 65. So here is a graphical abstract of my presentation. So in midlife hypertension should be intensively treated because they induce the vascular burden, they increase the vascular burden, such as the endothelial cell dysfunction and atherosclerosis and the cerebral blood flow autoregulations. So these vascular burdens reduce the blood supply and impairment of neurovascular unit and induce the neuronal loss. In contrast, in later life hypertension is carefully treated and is considering to avoid excessive blood pressure drop and blood pressure variabilities. So these efforts prevent the brain volume reduction and resulting in cognitive impairment and dementia preventions. So here is the summary of my presentations. Hypertension plays an important role in incidence of dementias. To prevent dementia explosion, management of hypertension in the middle age is important to prevent vascular burden during the life course. Intensive hypertensive treatment may prevent dementia. However, the evidence is less, and we have a caution of orthostatic hypotension. We need to always consider that older hypertensive people may have cognitive decline and should detect it earlier as soon as possible. These efforts may save the dementia crisis in AGS. Thank you for your attention.
Thank you, Professor Mugi. And I would like to introduce the last speaker. And last speaker is Jung-Yeon Che from Seoul National University. And she graduated Seoul National University, and currently she is working as the assistant professor at the Seoul National University, Bundang Hospital. Her topic today is the home blood pressure monitoring in older adults, when and how to use it effectively. Would you please start?
Thank you for the introduction. It's an honor to present this session with distinguished speakers who are leading experts in the field. As I introduced, the topic of this presentation is home blood pressure monitoring in older adults, when and how to use it effectively. The contents of today's presentation is as follows. First, the characteristics of older adults with hypertension that make home blood pressure monitoring more necessary will be presented. As for the introduction, in July 2024, the older population surpassed 10 million in Korea, and Korea enters to the Super Age Society previous year. The prevalence of hypertension continuously increased with age. So therefore, due to the population aging and the characteristics of hypertension, the number of older hypertensive patients is expected to keep rising. Older hypertensive patients have several special characteristics. As mentioned in previous lectures, they have many other chronic and acute diseases other than hypertension, so they take many kind of medications. Because of aging processes, older people suffer functional decline in multiple domains, which consequences to the frailty. Because of an aging and previous chronic diseases, the functions of various organs like kidney decreases. So the decreased kidney function can affect drug clearance and effect of antihypertensive medication, and it makes difficult to use antihypertensive medication or reducing their effectiveness and making more side effects. As people age, the diversity in health status widens, so that's why we have to evaluate this kind of various health conditions like frailty, sarcopenia, or cognitive decline. So after that, we can do the personalized setting the goal to treat hypertension. With population aging, the prevalence of sustained hypertension is increasing. However, among older adults, the prevalence of white coat hypertension is about 20%, and masked hypertension is about 10%. That means nearly 1/3 of older adults cannot be adequately assessed by clinic blood pressure measurement alone. And longitudinal observational studies have already shown that even when such masked or white coat hypertension appears well controlled, there remains differences in 10-year mortality compared to the well-controlled hypertensive individuals or the normotensive individuals. As we age, blood pressure becomes more variable due to the arterial stiffness, autonomic changes, and multiple medications, that making clinic blood pressure reading less reliable. Home blood pressure monitoring allows us to capture these fluctuations and assess even they are truly controlled. In fact, about 1/3 of older adults are white coat or masked hypertension, which cannot be identified without home blood pressure measurement. So large cohort studies have shown that home blood pressure is stronger predictor of cardiovascular events and mortality that clinic BP, especially among older, compared to the clinic BP, especially among the older peoples. Therefore, home blood pressure monitoring is essential for accurate assessment, safer treatment adjustment, and truly individualized hypertensive management among the older hypertensive patient. Next, we will identify indications of home BP monitoring among older patient. According to 2025 AHA guideline for prevention, detection, evaluation, and management for high blood pressure in adults, home blood pressure monitoring or the ambulatory BP monitoring highly recommended when patient is suspected to have hypertension to confirm the diagnosis. High quality evidence supports the use of home BP monitoring in combination with co-interventions such as patient education, telehealth or telemonitoring, and medication titration using pre-specified algorithms for the longitudinal management of blood pressure. As you can see the right side, the 2024 ESC hypertension guidelines also describe this in the similar way. These guidelines also provide detailed recommendations on how to properly measure home blood pressure monitoring, like including the device, preparation, positioning, and measurement. The Korean Society of Hypertension also released the position statement on home blood pressure monitoring in 2022. It recommends home blood pressure monitoring to detect stress-induced transient BP elevation, insufficient BP control, and BP variability. The statement emphasizes that home BP monitoring not only improves self-awareness and treatment compliance, but also has a superior predictive value for cardiovascular morbidity or mortality compared with the office BP monitorings. According to the poll on the home BP monitoring among older patients, about 62% reported being advised by the healthcare provider to check BP outside the clinic. When healthcare providers recommend home BP monitoring, patients were more likely to actually measure their BP at home. Older adults, especially those aged 65 to 80, were more likely to measure blood pressure at home compared to the middle-aged group, the younger group. And patients who also who have good mental health also more likely measure home blood pressure. For the main reason why aged like 50 to 80 older patient monitoring their BP at home, the most common reason was to be as healthy as possible. About half of them told that their doctor suggested to do it. Other aims to reducing the risk of stroke, heart disease, kidney disease, and cognitive dysfunction. Overall, these findings highlight that both physicians advised to do that or the personal motivation play the key roles in promoting home BP monitoring. Next, I will talk about the using home BP monitoring effectively. As for the effectiveness of home BP, the RCT was conducted in France. Participants aged 73 to 97 years and intervention groups were performed home BP monitoring every 3 months for 24 months. The intervention group showed a statistically significant reduction in both systolic and diastolic blood pressure, measured at home and measured at home and in the office. In the subgroup analysis, the blood lowering effect was more pronounced among the older patients, women, and those already receiving antihypertensive treatment. We can use home BP monitoring in many ways to diagnose, titrate, and manage the hypertension. Out-of-office BP measurement is essential for diagnosing white coat or masked hypertension, but the ambulatory blood pressure monitoring, the conventional method, is really hard to do that, to apply to patient. So home BP monitoring can serve as a feasible alternative. Greater BP variabilities influences by dehydration, seasonal variation, and emotional stress is one of the characteristics of older patients. And this pattern further exacerbated among hypertensive patients who takes medications like ARB, AC inhibitor, or the diuretics. Therefore, home BP monitoring allows to identify overtreatment and undertreatment and helps long-term medication titration. By measuring blood pressure at home, patients become more self-aware and capable of managing their hypertension. So this promotes better self-management behavior and also sharing BP results with their physicians also improved both adherence to home BP monitoring and overall blood pressure control. As for physician's view, it is more easy to determine how to treat that patient if that patient bring their home BP monitoring results. So it is important to review patient home BP readings together and incorporate this home BP data into the treatment decision. Since the COVID-19 era, the development and adoption of digital medicine have rapidly advanced, and similar efforts have been made in the field of hypertension. Ultimately, the digital medicine systems that requires remote data input, so the home BP monitoring served as an essential source of blood pressure data among the digital health field. In particular, with the recent adoption of wearable BP monitoring devices for home and ambulatory measurement, the amount of recorded BP data has increased substantially. This allows for a more accurate assessment for the BP variability, leading to the improved prognostic prediction and more personalized hypertension medications like chronotherapy or others. Moreover, this concept can be expanded beyond the patient's mobile application to include a doctor's console, enable patient-doctor interaction. Through this integration platform, both can share target BP goals and track or guide lifestyle improvements, thereby expanding the approach into the field of digital therapeutics. With patient mobile application, doctor's console, and virtual health professional educate and counseling could be provided, and patient practice specific behavioral goals and monitoring their home BP. Through this series repetition, this leads to habituation and help patient establish sustainable, healthy habits for hypertension. For the conclusion, as the population ages, hypertension has become increasingly prevalent. Older patients often have multiple comorbidity, functional decline, and marked BP variability, making clinic measurement alone insufficient to determine. So home BP monitoring provides a more accurate picture of daily blood pressure, helps identify white coat and masked hypertension, and better prediction for the cardiovascular outcomes. It also helps prevent both overtreatment and undertreatment, ensuring safer and more individualized strategy. Sharing home BP results with physician improve patient adherence, self-management, and blood pressure control. Home BP monitoring also support lifestyle educations, helping patient engaging in exercise and dietary changes more effectively. With the growing use of digital health technology, home BP data can now serve as both an input source and the monitoring tool, enabling more connected and data-driven hypertensive care. This is the end of my presentation. Thank you for your attention.
Yeah, thank you, Professor Choi. And for the discussion, we invited the three distinguished panelists, and Hyuk-sung Kwon from Hanyang University, and Yong-hyun Park from Busan National University, and Jin-kyung Oh from Chungnam National University. Would you please start if you're ready? Yeah.
My name is Hyuk-sung Kwon, a nurse from Hanyang University. Thank you for a very excellent and easy to understand lecture. I have one question to Professor Kwang-il Kim and one question to Masaki Mogi. I think everyone is waiting for this question. It was very interesting that targeting very low blood pressure reduce the risk of the orthostatic hypertension. It was very interesting that we usually decrease the antihypertensive medication when the patient demonstrate the orthostatic hypertension. I was thinking about two possible hypotheses about that. One is that lowering blood pressure can improve the vascular function and improve the autoregulation. That can lead to the reduce the orthostatic hypertension. And one possible reason can be as the baseline blood pressure is low, so it makes a little bit hard to meet the diagnostic criteria for the orthostatic hypertension. So I want to ask you that, your opinion, and do we have to increase the blood pressure medication for the patient with orthostatic hypertension?
Thank you for your question, and actually that is very difficult to answer that question. So actually I have also have that question, and when you look at the data, I think that there are a couple of different answers to the question. And first one is that they measured the absolute change of blood pressure after standing. So when you imagine that, which one, which difference is more big, uncontrolled hypertension and controlled hypertension. So if the blood pressure is very high, in that case, the standing blood pressure changes substantially. The absolute value is quite huge. But if the blood pressure control around 120 or 30, there is very little change after standing. So I think that one of the reason supporting the beneficial effect of intense antihypertensive treatment is that we just measure the absolute change of the blood pressure after standing, not evaluating the change of the blood flow to the CNS. But actually, the Professor Mogi showed that intensive blood pressure can also increase the cerebral blood pressure. It's quite interesting to know. And the second question is that, second answer is that the intensification of antihypertension treatment can reduce the blood pressure variability, and also is very beneficial for the reducing the arterial stiffness. So in the long term, more intense antihypertensive treatment can improve the blood pressure variability, and so in those mechanisms there is more beneficial effect of the intensification of antihypertensive treatment for the orthostatic blood pressure change. But actually there is no solid data supporting those hypotheses, so we need more study to answer the question. Professor Mogi?
Yeah, so Dr. Kim showed everything. So the intensive blood pressure treatment may reduce the very good control to the blood and prevent the blood pressure variability also reduced. And maybe so this is a very preventive effect for vascular blood pressure, blood vessels. However, I show that and the patient with atrial fibrillation is a very different conditions. So it's a very variable blood pressure. So it's very carefully to treat intensively in the maybe older people. And the younger people is intensively is very good, but the older people is very carefully to know the very low level of hypertension as observed. Yeah, so I think totally agree.
Then you mentioned that it's very difficult to. There are very complicated pathological linkage between dementia and hypertension. Then, which blood pressure medication do you prefer for the patient with dementia and old age?
Yeah, so in Japanese Society of Hypertension also recommend the level of the older peoples with in the dementia, and the caregiving persons should be cared about, not so intensive treatment, around 150 or 160. So depend on the condition of the older peoples.
Thank you for the excellent lectures. I'm Dr. Bak from Busan National University Yangsana Hospital. I also have one question for Dr. Mogi. Hypertension is associated with dementia and cognitive decline, and also stroke. Do you think the mechanism for the association of hypertension with dementia and cognitive decline and stroke is different or the same mechanism?
Yeah, I think so. There are the several same things to increase the vascular damage, especially in the small vessels. Is important to induce the dementias, but we cannot see the infarction of small vessels in the MRI or something. So like white matter disease may induce teach us about small vessel disease in ischemias, but it's difficult to know about small vessels. So it's the same thing to induce the dementia. But in Alzheimer's disease, so also the neurovascular unit plays an important role, and so to the blood, the energy supply to the neurons. So the blood vessel is a key point to induce the dementias. But but another type, so I showed amyloid beta dependent pathways is a very interesting point. So maybe, and now we are going to the experiment in the basic research may prove the mechanisms. Thank you very much.
Yes, please, Benethos.
May I add something? I agree.
Mike?
I fully agree. I would like just to add something yet mentioned at the end. From experimental studies, there is increasing evidence now, the last at least 15 years, that in hypertension and in models with high pulsatile stress and high stress, generally vascular stress, we have an activation of beta secretase, so an activation of the synthesis of beta 42 amyloid, which is the most, let's say, negative for the brain. And also these last years, there's a couple of studies showing we have an activation also of the tau phosphorylation pathway, which is, let's say, the other known pathway. So maybe there are some specific, this is why we don't have only the association with what's expected, the vascular dementia, but also as of course, not the only factor, but a factor that adds on the neurodegenerative process due to this possible activation of these two pathways by vascular factors. It's maybe something, and the endothelial dysfunction also plays a role on these pathways. This is at least one of the hypotheses. There are some others about cleaning also when hypotension comes, which is more frequent in hypertensive hypotension, the cleaning, let's say, of these substances from the brain is less. But I don't know this second hypothesis, how solid it is. Thank you.
Professor Benetto, I have one question. As you mentioned, I think tailoring blood pressure target is important for elderly patients, especially with frailty. So I wonder how you apply this concept in your daily clinic practice, and could you share any practical tip to any practical tips for determining blood pressure target in these elderly patients with frailty and considering their functional status?
Well, I propose you be here at 11:50 for my second lecture, so we save some time. But if you are not here, I can answer you. But this is exactly the topic we will discuss in the next. It's very important, so I prefer not to take more time. Thank you for the question.
Professor Benethos, could you please tell us about actually now the frailty assessment is very important, but the problem is that many non-geriatric doctors are not familiar with the frailty assessment tool. So would you recommend any very simple and effective screening tool for assessing the frailty in clinical practice?
Yeah, this is a crucial issue. The thing is that the geriatricians cannot be behind each old patient. So the objective is how to make other physicians from other specialties, but not only physicians actually, other health professionals to be able to have this kind of first screening. And I think we have to, there are many tools. And my personal opinion is that the problem is not to find the perfect tool. Perfect tool to detect that in 10 minutes does not exist. But in order to have the first line, we don't have to have a perfect tool. We have to have something that we do systematically, not more than 10 minutes, let's say, just. And in this respect, not only from physicians, but also other professionals. And just to give two examples, I think, and if possible, multidimensional, not only the physical frailty. So with these three criteria, I can see two, but there are others, I repeat. The clinical frailty scale of Rockwood, not the score with the 70, whatever, it's, with the small images, because it's easy also. We can better understand between Koreans, French, Italians, and I don't know, Chinese and Japanese, and what else, with the small images of this test, the clinical frailty scale, it's much, I think, more convenient, one. And the second one is the approach of WHO, which is the program, you know, the ICO program, which is initially it's not for frailty but for endogenous capacity, but it makes also it can be that it is less than 10 minutes. So this, and now we have a big project, a European project in the European Geriatric Medicine Society, initiated by us, by the society, but it's a large European cost action called programming. Go to internet, check programming, like this is the cost action programming, and this is the objective, how to learn other non-geriatricians and other professionals all over Europe and the other countries to do this kind of tests. We need something short, valid, not perfect, but we know to do. And if one does with one method, another one with another, that's fine. The thing is to do something in order to make understand also everybody that it is important to do.
Thank you. And for your information, we'll include the Korean version of clinical frailty scale in the upcoming new hypertension guideline. And Professor Choro Kim, would you have any comment or question for this session?
I think the final stage of human must be dementia or frailty or sarcopenia. But I think it is related to the small vessel disease of the brain. And it is the end result of the moderate, uncontrolled hypertension in middle life. So we must make effort to reduce the burden of small vessel disease from middle age, not in senior stage. It is the most important implication in public health. I think so. No evidence for it.
Thank you. And because of the time limitation, we have to close this interesting session. And finally, I would like to thank to all the speaker and panelists and audience for participating in this session. Thank you.
Thank you.
Whatever you want, whatever it is. In Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압 관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
Good morning, everyone. Welcome all of you to the session entitled Deep Dive into Hypertension Disorder of Pregnancy. I'm Myung-ha Kim from Jeju National University Hospital, and the co-chair is Professor Jinok Jung from Chungnam National University. She is the president of the Korean Society of Hypertension. It's my honor to chair this session with her. As you may have guessed from the title of the session, pregnancy-related hypertensive disease is an important medical issue for both maternal and fetal health. We have 4 excellent speakers in this session. I will introduce the first speaker, Dr. In-jung Cho from Ewha Women's University. She graduated from the Ewha Women's University. Now, she is the Associate Professor, Department of Cardiology, Ewha Women's University, Seoul Hospital. Her topic is prediction and prevention of hypertensive disorder from pregnancy. Dr. Cho, please.
Thank you, Chairman, for the kind introduction. Good morning, everyone. I'll talk about prevention and prediction of hypertensive disorders of pregnancy. Hypertensive disorders of pregnancy are classified into several categories. First, chronic hypertension, which refers to hypertension known before pregnancy or diagnosed before 10 weeks of gestation. Second, a gestational hypertension, which develops de novo at or after 10 weeks. Preeclampsia, which may be occurred de novo or be superimposed on pre-existing chronic hypertension. We also recognize white coat hypertension as distinct diagnostic considerations. Preeclampsia is defined as hypertension accompanied by proteinuria, or in the absence of proteinuria by the presence of one or more signs of organ damage, including thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, or neurologic symptom. Hypertensive disorders are among the leading causes of maternal and fetal morbidity and mortality worldwide. They contribute substantially to maternal deaths, particularly in developed countries. Among the maternal complications associated with hypertensive disorders, the incidence of myocardial infarction, stroke, and peripartum cardiomyopathy, and even mortalities increases significantly. Even when only chronic hypertension is present, the risk of myocardial infarction, stroke, and peripartum cardiomyopathy increases 2 to 4 times. Key factors for hypertensive disorders include overweight, obesity, diabetics, and hypertension. Women with a history of hypertensive disorders have a higher long-term risk of developing cardiovascular disease and hypertension. And even after 10 years, they are at higher risk for coronary artery disease, stroke, and heart failure, and even higher mortality. So hypertensive disorders should be viewed as a major determinant of women's cardiovascular health, emphasizing the importance of prevention. This figure is from the 2025 Korean Hypertension Fact Sheet, which was just released 2 days ago. As you can see, although the numbers of births in Korea has been decreasing through 2023, the prevalence of hypertensive disorders of pregnancy continues to rise. A concerning trend is that hypertensive disorders have increased sharply since 2016, accounting for 13.2% in 2023 of all pregnancies. Among these, chronic hypertension represented 7.2%, making up more than half of all cases. To understand why hypertension in pregnancy is risky, we first need to look at the normal physiology of pregnancy. Pregnancy includes major physiologic adaptations. There's an upregulation of RAS mediated by ovarian and placenta hormones to accommodate increased plasma volume. Despite the activation of the RAS, systemic vascular resistance decreases, result in physiological fall in blood pressure during early gestation. During pregnancy, cardiac output increases, but the peripheral resistance decreases, leading to an approximately 10% reduction in blood pressure by the second trimester. Blood pressure decrease most notably in early pregnancy, around 6 to 8 weeks of gestational age, and gradually returns to pre-pregnancy level in the third trimester. The most widely recognized cause of preeclampsia has been placenta pathology. Normal placenta development requires proper trophoblast invasion and remodeling of maternal spiral artery. In preeclampsia, defective implantation and poor spiral artery remodeling leads to placental ischemia and release of anti-angiogenetic factors like soluble F31 and endoglin. This diagram compares blood flow in normal and pathological pregnancies. In normal pregnancies, the distal spiral arteries are well dilated, slowing the blood flow, so oxygen exchange occurs efficiently. In preeclampsia, however, the arteries remain narrow, and maternal blood enters in the villus space as high velocity jet. This turbulent flow damages the villi and can lead to ischemia, perfusion, injury, and placenta dysfunction. Circulating placental growth factor concentrations gradually increases during pregnancy to reach a peak at approximately 30 weeks of gestation. coinciding with non-branching angiogenesis of fetal placenta vessels and maturation of the uteroplacental circulation. In women who go on to develop a preeclampsia, placental growth factor levels remain lower than in normal pregnancies throughout the course of gestation. In contrast, levels of soluble FLT1, this is an anti-angiogenic factor, which is elevated in women who later had preeclampsia. So, based on these findings, measuring placenta growth factor levels or using the soluble FLT1 to placenta growth factor ratio has been suggested as a way to predict the risk of preeclampsia. The value over 38 considered to be at risk of developing preeclampsia within 1 to 4 weeks. In Korea, measuring the soluble FLT1 to placenta growth factor ratio, a marker of placenta dysfunction, is also used as a screening method for preeclampsia, as you can see in this figure. However, besides placenta factors, the mother's baseline characteristics are also important predictors of preeclampsia. Preeclampsia can be classified into early onset before 34 weeks and late onset forms. Early onset preeclampsia is typically placental in origin and associated with fetal growth restriction, while late onset is more related to maternal metabolic factors such as obesity and diabetics. The pathogenesis of hypertensive disorders involves complex interaction between abnormal placentation, immune dysregulation, and impaired maternal cardiovascular adaptation. So, models like this cardiovascular adaptation have also been proposed. This diagram illustrates how preeclampsia can be resolved from an imbalance between cardiovascular reserve and hemodynamic load of pregnancy. In normal pregnancy, the cardiovascular system adapts well, though mild subclinical dysfunction may occur near term. However, in women with a higher risk, such as advanced age or obesity, poor cardiovascular adaptation can develop depending on the degree of load and reservoir imbalance. Different phenotype of preeclampsia may appear early or late onset. Most current guidelines identify high-risk mothers mainly according to their baseline characteristics like a previous pregnancy history, chronic hypertension, diabetes, renal disease, and multiple gestation. Risk-free prediction models has developed, such as the Fetal Medicine Foundation algorithm, incorporate various maternal factors to estimate preeclampsia risk in the first trimester. In addition, they also show that using the FMF triple test allows for the high accuracy in predicting the occurrence of preeclampsia. The FMF triple test combines maternal factors, mean arterial pressure, and uterine artery Doppler to predict preeclampsia risk in early pregnancy. Then, how can you prevent preeclampsia in population at risk? This study shows in a randomized trial over 1,700 high-risk women, aspirin 150 milligram daily from 11 to 14 weeks until 36 weeks reduced the instance of preterm preeclampsia by nearly 60%. Meta-analysis also confirmed that initiating low-dose aspirin beginning as early as the second trimester provides maximal benefit and no harms were identified. So, according to American College of Obstetrics and Gynecologists, aspirin prophylaxis is recommended for high-risk women initiating between 12 and 28 weeks of gestation, optimally before 16 weeks, and continue until delivery. Because preeclampsia is linked to maternal endothelial dysfunction, some studies have explored using statins as a possible treatment option. Since pravastatin is hydrophilic and a substance of the P-glycoprotein efflux pump, its passage across the placenta is theoretically limited. In this animal model, pravastatin lowered blood pressure, decreased the soluble L31, and increased placenta growth factor in a pregnancy animal model. However, in a large RCT, including over 1,000 women, pravastatin 20 milligram daily from 35 to 36 weeks until delivery or 41 weeks failed to reduce the incidence of preeclampsia. But the treatment period was only about a month. There's still room for debate regarding the results. Maintaining a healthy body weight before conception is crucial. Higher pre-pregnancy BMI is strongly associated with increased blood pressure throughout the pregnancy and elevated risk for gestational hypertension and preeclampsia. Interestingly, this study found that not only a pre-pregnancy body weight, but also an increased weight trend before conception was linked to higher risk for preeclampsia, suggesting the importance of maintaining a healthy weight before pregnancy. Weight optimization and lifestyle counseling should therefore be emphasized during preconception care. The relationship between salt and potassium intake and the risk of preeclampsia remain controversial because some studies have reported paradoxical findings between salt intake and preeclampsia. Salt restriction is generally not recommended during pregnancy. To summarize, hypertensive disorders of pregnancy are major causes of maternal morbidity and mortality, and multiple factors, maternal comorbidities, placental pathology, and genetic and immune mechanisms contributes to disease development. Currently, no definite preventive therapy exists, but a low-dose aspirin initiated before 16 weeks shows a clear benefit. Thank you for your attention.
Thank you, Dr. Cho, for very informative lecture, including physiologic changes during pregnancy, pathophysiology, and risk factors, and also several ways of prevention. We'll move to the next topic. The next speaker is Dr. So-young Lee from Catholic University. She graduated from Catholic University School of Medicine. Now she is a clinical assistant professor of cardiology of Catholic University and St. Mary Hospital. Her topic is management of hypertensive disorder of pregnancy. Dr. Lee, please.
Thank you for the kind introduction. I'm So-young Lee from Seoul St. Mary's Hospital. Today I'll talk about management of hypertensive disorder of pregnancy. Monitoring blood pressure during pregnancy is typically done at antenatal visits. Manual oscillation is gold standard for blood pressure measurement in pregnancy. Automated devices tend to under-record blood pressure and are unreliable in severe preeclampsia. Only devices validated specifically for pregnancy should be used. Home BP monitoring didn't affect the timing of diagnosis or blood pressure control in pregnancy in the BUMP 1 and 2 trials. However, these studies didn't incorporate active clinical monitoring or outreach by healthcare providers. Home BP monitoring and office BP measurement can be used alternatively or complementarily for the diagnosis and control of hypertension. Home BP monitoring and ambulatory BP monitoring should be considered to exclude white coat and masked hypertension, which are common in pregnancy. Beijing laboratory investigations include urinalysis, complete blood count, hematocrit, liver enzymes, serum creatinine, and serum uric acid. Serum uric acid levels are elevated in preeclampsia and help identify women at increased risk of adverse maternal and fetal outcomes. All pregnant women should be assessed for proteinuria in early pregnancy. Because of concerns about pregnant patients being a vulnerable population for research, they have been underrepresented in RCT. There is little evidence from trials examining the treatment of hypertensive disorder of pregnancy. As a result, national and international guidelines differ in their recommendations. The goals of antihypertensive treatment is to prevent severe hypertension and preeclampsia and to optimize maternal and fetal neonatal clinical outcomes. Untreated hypertension is contributor to the increase in maternal risk. However, concerns exist regarding impaired uteroplacental blood flow with excessive blood pressure lowering. So antihypertensive therapy requires attention to balance the risk and benefits for both mother and fetus. CHIP trial was RCT that included women with non-proteinuric pre-existing or gestational hypertension. The study compared tight blood pressure control versus less tight control. The study demonstrated that tight control significantly reduced the incidence of severe maternal hypertension. There was no significant differences in maternal, fetal, or neonatal complications or pregnancy loss. CHOP trial randomized 2,408 women with chronic hypertension to receive antihypertensive medication targeting blood pressure less than 140/90 compared with only treating severe hypertension. Targeting blood pressure less than 140/90 reduced the risk of preeclampsia with severe pictures, preterm birth, placental abruption, and fetal neonatal death. No adverse effects on fetal growth were observed. There is a debate over whether trial data from chronic hypertension can be applied to the treatment of gestational hypertension and preeclampsia. United States guidelines have not extended this recommendation to gestational hypertension or preeclampsia. Nevertheless, most other international guidelines recommend lowering blood pressure to below 140/90 in gestational hypertension. Oral labetalol and extended release nifedipine and methyldopa is preferred first-line antihypertensive agent in mild hypertension. Labetalol is non-selective beta blocker and is dosed 2 to 3 times daily, and it should be avoided in patients with asthma, decompensated cardiac function, heart block, and bradycardia. Nifedipine is dihydropyridine CCB and is dosed once daily, which may improve adherence. It is contraindicated in heart failure, and flushing, headache, tachycardia, edema are common. Methyldopa is alpha-2 agonist with central sympatholytic action with long-term information on infant outcomes. Its use is still common in low and middle-income countries. Methyldopa can be poorly tolerated due to their side effects such as peripheral edema, dry mouth, lightheadedness, drowsiness, and effects on mood. There was no difference in maternal or neonatal outcomes between labetalol and nifedipine. Beta blocker and CCB were more effective than methyldopa for the prevention of severe hypertension. They are second-line agents including amlodipine, hydrochlorothiazide, furosemide, hydralazine, carvedilol, bisoprolol. Furosemide is not routinely used in pregnancy due to the risk of reduced intravascular volume and uteroplacental perfusion, but it may be necessary in cases of pulmonary edema, heart failure, or volume overload. AC inhibitor, ARB, and direct renin inhibitors should be avoided in pregnancy. They are petotoxic due to their effects on the developing renal system, leading to oligohydramnios and AKI. Spironolactone may cause feminization of a male fetus or growth restriction, so it should be avoided. And nitroprusside crosses placenta and may lead to fetal cyanide toxicity. And atenolol should not be used due to the risk of fetal growth restriction. In mild hypertension, the guideline recommends monitoring blood pressure once or twice a week, and it recommends screening for proteinuria once or twice a week, and blood tests including full blood count, liver function, renal function should be performed once a week. And the physician should check symptoms related to preeclampsia. Severe range hypertension is defined as blood pressure greater than or equal to 160/110 and is confirmed by a repeat measurement within 15 minutes. Treatment should be initiated within 30 to 60 minutes to reduce blood pressure below 160/110. And it can indicate hypertensive emergency, and immediate hospitalization should be considered. Severe range hypertension is associated with adverse maternal and perinatal outcomes independent of preeclampsia, and it should be managed with the same approach as those with preeclampsia, highlighting the overlap in risks. There is difference in American and European guidelines regarding first-line agents in severe range hypertension. In American guideline, first-line agents include intravenous labetalol or hydralazine and oral immediate release nifedipine. In European guideline, first-line agents include intravenous labetalol, nicabitipine, or oral short-acting nifedipine or methyldopa. IV hydralazine is second-line agent because hydralazine is less effective and associated with perinatal adverse events than other drugs. Intravenous nitroglycerin can be used when complicated by pulmonary edema. And nifedipine showed lower rates of neonatal complications than labetalol. In severe range hypertension, the guideline recommends monitoring blood pressure every 15 to 30 minutes, and it recommends screening for proteinuria daily. And blood tests should be performed once a week. Next is management of preeclampsia. Preeclampsia may require hospital admission, but not all women will require ongoing hospitalization, and care should be individualized. In women with preeclampsia and severe hypertension, immediately reducing blood pressure to less than 160/105 using intravenous labetalol or nicardipine. The object of treatment is to lower blood pressure within 150 to 180 minutes. If blood pressure control is not achieved by 6 hours, then ICU stabilization possibilities are considered. The routine use of diuretics is unclear in preeclampsia, and when associated with pulmonary edema, intravenous nitroglycerin is recommended. Eclampsia or preeclampsia with severe picture should be managed with intravenous magnesium sulfate to prevent eclampsia or seizure prophylaxis. And definitive treatment of preeclampsia is to deliver the fetus. In women with preeclampsia without severe pictures, delivery is recommended at 37 weeks. In women with preeclampsia with severe pictures, delivery is recommended if presentation is greater than 34 weeks of gestation. Next is non-pharmacologic interventions. Low to moderate intensity exercise decrease the incidence of gestational hypertension. All pregnant women should participate in physical activity unless contraindicated. In addition, smoking cessation, healthy diet, and control of body weight are important. And it is reasonable for women with pre-existing hypertension to continue with a low sodium diet. Obese women are advised to avoid an increase in weight of more than 7 kilograms. 10% of pregnant women with chronic hypertension had secondary hypertension and is associated with increased risk of adverse outcome. The most common cause of secondary hypertension is CKD, and other primary aldosteronism and pheochromocytoma has to be considered. This is summary. Antihypertensive therapy in pregnant individuals require the attention to balance the risk and benefits for both mother and fetus. Most guidelines recommend lowering blood pressure to below 140/90 in gestational hypertension and chronic hypertension. Contraindicated drugs include AC inhibitor, ARB, direct renin inhibitors, spironolactone, nitroprusside, and atenolol. In mild hypertension, first-line agents include oral labetalol, extended-release nifedipine, and metidopa. Second-line agents include amlodipine, hydrochlorothiazide, furosemide, hydralazine, carvedilol, and bisoprolol. In severe range hypertension, hospitalization should be considered. It is different on guidelines in American and European. First-line agents include intravenous labetalol or hydralazine and oral immediate release nifedipine in American guideline, and intravenous labetalol, nicardipine, or oral short-acting nifedipine or metidopa is recommended in European guideline. IV hydralazine is recommended as second-line agent in European guideline. In preeclampsia, immediately reducing blood pressure to less than 160/105 using IV labetalol or nicardipine is recommended. Eclampsia or preeclampsia with severe picture should be managed with intravenous magnesium sulfate. The decision to deliver depends on the gestational age and presence of severe pictures and other clinical settings. Exercise, smoking cessation, and a healthy diet and controllable body weight are important. Thank you for your attention.
Thank you, Dr. Lee. Thanks to her nice lecture, now we improved our knowledge of the management of hypertensive disorder of pregnancy. Thank you.
Yeah, let's move on to the next topic. Next speaker is Kyung-hee Lim from Donghua University. She graduated at Donghua University and trained in Samsung Medical Center, and now she is an associate professor of Donghua University Hospital. She'll give us a talk about postpartum management of hypertensive disorder of pregnancy. Dr. Lim, please.
Thank you for introducing. I'm Kyung-hee Lim from Donghua University Hospital. Hypertensive disorder, or HDP, is a significant clinical condition that can impact both mother and fetal health. In today's lecture, I will discuss postpartum management of hypertensive disorder of pregnancy. First, let me briefly discuss hypertensive disorder pregnancy. After delivery, blood pressure usually drops during the first 45 hours, then rise again between days 3 and 6 postpartum. This elevation may persist for several weeks after delivery. Postpartum hypertension occurs in approximately 5 to 12% of women. The most common form is persistence of pre-existing hypertension. However, there is also the novel type, where blood pressure rise for the first time after delivery in patients who maintain normal blood pressure throughout pregnancy. Within the first 6 weeks after delivery, several factors can cause postpartum hypertension. These include physiologic change, medication, pain, or new onset postpartum preeclampsia. In case other than pre-existing hypertension, up to 80% of postpartum hypertension episodes resolved spontaneously with 7 days after delivery. About 1 in 5 women with hypertension during pregnancy continue to have elevated BP 6 weeks after delivery. And in some cases, antihypertensive medication may be required to control it. Persistent or chronic hypertension is more likely to occur in women with have elevated BP earlier and higher in pregnancy, or who have a high BMI. It can also be observed in women with coexisting renal, endocrine, or neurologic disorder. Based on the major clinical guideline, I would like to present current recommendations for the diagnosis and management of postpartum hypertension. Current BP guidelines from the ACC, ACH, 그리고 ESC and ACOG do not specify the BP goal in the postpartum period. According to 2024 ESC guideline for management of hypertension, there is a strong emphasis on regular BP monitoring and comprehensive risk management after delivery. However, in 2024 AHA scientific statement, an ideal goal was suggested. Individuals with persistent hypertension after delivery should be treated in accordance with current ACC AHA guideline. These patients should receive intensive lifestyle counseling and close monitoring. Also, evaluate cardiovascular risk and determine the need for medication initiation. Next, I will talk about the NICE guideline. The NICE guideline recommends maintaining postpartum blood pressure under 140/90 millimeters of mercury. Every woman should have her blood pressure checked at least once between days 3 and 5 postpartum. For chronic or gestational hypertension, blood pressure should be monitored daily for the first 2 days. If the patient discharged on antihypertensive medication, follow-up is recommended in 2 weeks. If not, a reassessment at 6 to 8 weeks postpartum is advised. For patients with preeclampsia, blood pressure should be measured at least 4 times a day during hospitalization. We also need to check the associated symptoms such as headache or abdominal pain. Blood test should be performed to confirm that platelet count and liver and kidney function have returned to normal. If these results are stable, routine follow-up is not required. But if proteinuria persisted, reevaluation at 3 months is recommended. In patients with preeclampsia, antihypertensive therapy is recommended when blood pressure reaches 150/100. For those who were already on antihypertensive therapy, the same medication should be continued after delivery. When treating women with high blood pressure who wish to breastfeed, some simple education is important. A small amount of medicine may pass into breast milk, but it's too little to cause any problem for the baby. Still, we should check the baby's blood pressure, especially if the baby is born early. Also, mothers should watch if the baby looks so sleepy, weak, or pale. According to the NICE guideline, an ACE inhibitor is recommended as the first-line treatment after delivery. Among them, enalapril is preferred. If blood pressure is not well controlled with enalapril alone, difedipine or amlodipine can be added. As a second-line option, beta blockers such as atenolol or labetalol may also be used. During breastfeeding, diuretics, ARB are generally not recommended. If the woman is not breastfeeding, antihypertensive therapy can follow the same approach as in non-pregnant adult. After treating postpartum hypertension, it is important to educate patients about the risk of recurrence and the long-term risk of cardiovascular disease. About 1 in 5 women with HDP experience recurrence in future pregnancy. Next, I will discuss the 2021 ISSHP guideline on hypertension in pregnancy. The ISSH guidelines are largely similar to the NICE recommendation. Also, breastfeeding is encouraged even in women with HDP because it has been shown to reduce maternal cardiovascular risk. The ISSH guideline recommend a diastolic BP target of 85 millimeters of mercury, similar to the CHIP trial. Both the ISSHP and the ESC guidelines similarly emphasize that these women should have long-term annual BP monitoring and cardiovascular risk assessment. This reflects the understanding that HDP increases the risk of long-term cardiovascular risk. Recently, several studies have been conducted to evaluate the benefit of tight BP control in postpartum hypertension. The most recent MOB trial compared the standard versus tight BP control in patients with HDP. At 6 weeks postpartum, the tight control group showed a greater reduction in blood pressure. Tight BP control during the first 6 weeks after delivery significantly reduced the emergency room visit and hospitalization related to hypertensive disorder. Based on this finding, future guidelines may recommend lower BP target for patients with postpartum hypertension. When treating postpartum hypertension, it is important to check whether the patient is breastfeeding. In Korea, both birth rate and the breastfeeding rate have declined. At 6 months postpartum, about 15% of women practice exclusive breastfeeding and about half of mixed feeding. So 1 in 2 women with postpartum hypertension need a prescription that consider breastfeeding. According to AHA guideline, the recommended first-line medications for postpartum hypertension is enalapril, difedipine, amlodipine, and labetalol. Drug safety during breastfeeding is evaluated by the relative infant dose. A value below 10% is generally considered safe. Thiazide, furosemide, spironolactone are also relatively safe during breastfeeding, but diuretics may reduce milk production. Hydralazine and verapamil can also be considered as alternative option during breastfeeding. Among beta blockers, carvedilol is mentioned as relatively safe, although current evidence remains limited. Because of the concern about pregnant patients being a vulnerable population for research, there is little evidence from trials examining the treatment of hypertension in pregnancy and postpartum individuals. The PEAK trial it was evaluated whether postnatal enalapril improve cardiovascular function in preterm preeclampsia patients. Enalapril significantly reduced the total vascular resistance and improved E of E prime and LV mass index. This pilot study compared lisinopril combined with hydrochlorothiazide to nifedipine in women with postpartum hypertension. This combination therapy achieved a better short-term blood pressure control than nifedipine alone, and both treatments showed minimal impact on breastfeeding. Although diuretics are often avoided during breastfeeding, in women with HDP, a short-term course of low-dose furosemide after delivery reduced persistent hypertension by nearly 6% within a week. Breastfeeding outcome and adverse events were similar, or even better in the furosemide group. Meta-analysis of 14 RCT was conducted to identify the optimal antihypertensive treatment for postpartum hypertension. No significant medication could be recommended based on current evidence. However, some studies suggest that furosemide may help improve blood pressure control in women with preeclampsia. So, in postpartum hypertension with volume overload, a brief low-dose furosemide can be a reasonable option. Most studies in postpartum hypertension focused on beta blocker and calcium channel blockers. Recent trials show similar blood pressure control between labetalol and nifedipine. In a retrospective study of 217 women with peripartum hypertension, discharge prescriptions include labetalol, nifedipine, or combination therapy. Labetalol monotherapy was associated with a higher risk of postpartum readmission due to hypertensive complications. In postpartum hypertension, amlodipine lowered blood pressure faster than labetalol, yet the continuation at discharge rate was lower with labetalol. Overall, neither drug showed clear superiority. This is the final study. All women should have their blood pressure checked at least once between postpartum days 3 and 5, and more frequently if hypertensive disorder was diagnosed during pregnancy. The target postpartum blood pressure is below 140/90 millimeters of mercury according to 2023 NICE guideline, but recent data, including mock trial, showed that tighter BP control after delivery reduce ER visit and hospitalization. So guidelines target attending role. Also, always confirm the breastfeeding state as antihypertensive agent can be transferred through breast milk. The first-line drug for postpartum hypertension is enalapril combined with nifedipine or amlodipine may be considered. Beta blockers such as atenolol, labetalol, or carvedilol are acceptable alternatives to calcium channel blockers. ARB and diuretics should be avoided in breastfeeding women. However, short-term low-dose furosemide may be added early BP control in women with preeclampsia. Thank you for listening.
Yeah, thank you, Dr. Lim. Very informative and practical lecture of postpartum management of hypertension. We'll have a Q&A and discussion after all presentations are completed. Let's move to the next topic. Next topic is long-term outcomes of hypertensive disorder of pregnancy. The speaker is Sori Kim from Korean University. She graduated to Wongang University and trained in Samsung Medical Center, and now she is affiliated Korea University of Annam Hospital. Dr. Kim, please, would you start your talk, please?
Thank you, Chairman, for your kind introduction. I have nothing to disclose, and actually my topic is partly covered by previous speakers. Pregnancy is like a cardiac stress test. So cardiovascular adaptations during pregnancy are similar to exercise-induced physiological hypertrophy. And full cardiac recovery is attained by 1 year postpartum. So what is the risk of previous preeclampsia, it can develop premature cardiovascular disease. So in this study, blood pressure is measured 6 months postpartum, and as you can see here, in patients with previous preeclampsia, the blood pressure is higher than patients with normotensive pregnancies. Preeclampsia can develop hypertension, coronary artery disease, and stroke. Using Rochester Epidemiology Project medical record linkage system involving 9,000 pregnancies, including 700 HDP, patients with HDP showed increased risk of hypertension, coronary artery disease, and stroke. Also, in study with UK Biobank involving over 200,000 women, including 2,000 prior HDP, coronary artery disease, risk of coronary artery disease, heart failure, and valvular heart disease, including aortic stenosis and mitral regurgitation, are increased. So, what's the cause? Cardiovascular risk after HDP is largely mediated by development of chronic hypertension. So in causal mediation analysis, chronic hypertension explained 64% of HDP's association with CAD and 49% of HDP's association with heart failure. So it's mainly mediated by a chronic hypertension, but not fully mediated by it. So postpartum individuals should check blood pressure annually, even if their blood pressure becomes normalized and they stop medication. I'd like to show the data from meta-analysis. In prospective and retrospective core studies involving more than 3 million women, including around 200,000 preeclampsia patients. Preeclampsia was associated with higher risk of hypertension, and the relative risk was 3.7 after 14 years follow-up. And the relative risk for ischemic heart disease was 2.2 after 11 years follow-up. And for stroke, it was 1.8, and for venous thromboembolism, it was 1.2. In this study, they evaluate the risk of any cancer, and fortunately, there was no increase in risk of any cancer in patients with preeclampsia. However, as previous speakers taught, preeclampsia was associated with increased all-cause mortality, and the relative risk was 1.5 after 14 years follow-up. So how about neurological disorder? HDP was associated with new onset neurological disorder. This is the recent study from Swedish Medical Birth Register involving more than 600,000 women, premiparatus women, and with singleton pregnancies without chronic hypertension or pre-pregnancy neurologic disorder. And as you can see here, HDP was associated with increased risk of composite of neurologic disorders, including new onset migraine, headache, epilepsy, sleep disorder, or mental fatigue. And as you can see here, women who experienced eclampsia during their first pregnancy were at the highest risk of developing future neurologic disorder, with the highest cumulative event rate in the first 4 years after giving birth. So first 4 years is at risk. And the relative risk adjusted hazard ratio was 1.2 for gestational hypertension, 1.3 for preeclampsia, and 1.7 for eclampsia. And for epilepsy, the risk of epilepsy was more than 5 times for eclampsia patients. And regarding early versus late onset preeclampsia, both type can increase the risk of developing cardiovascular outcomes, adverse cardiovascular outcomes. However, earlier onset of preeclampsia leads to more severe conditions and a higher risk of developing subsequent cardiovascular disease. And preeclampsia also changed the cardiac structure. This was a prospective longitudinal case control study of 64 subjects with preeclampsia and 78 matched controls. As you can see here, LV concentric remodeling and hypertrophy persistently exist following preterm preeclampsia. So, yeah, in light black. And also, LV diastolic function was impaired in patients with preeclampsia. And global longitudinal strain was reduced, and left ventricular wall thickness was increased in patients with preeclampsia. How about the effect to vascular structure? Preeclampsia can result in an increase in size of aorta and increase in the thickness of a carotid in IMT. So what is the pathophysiology of this change? The pre-existing family genetic background can be a background, and epigenetic changes in pregnancy can exacerbate it, and abnormalities of placenta development can lead to endothelial dysfunction. And most of the contents of pathophysiology are referred to this review. In this review, there was very beautiful picture. And regarding genetics and epigenetics, single nucleotide polymorphisms and microRNAs and abnormalities in DNA methylation was involved, resulting in smooth muscle contraction, increase in sensitivity of vasoconstrictor, and decreased NO bioavailability and increased inflammation. So, and finally, resulting in endothelial dysfunction, which bridge between preeclampsia and cardiovascular alterations. And how about offspring? For babies from hypertensive mother, they have higher blood pressure, like systolic blood pressure more than 5 and diastolic blood pressure more than 4 when their blood pressure were checked during childhood or young adulthood. And in a huge study involving more than 8 million births from Denmark, Finland, Sweden, in these offspring, 2.2% were exposed to maternal preeclampsia, and they were followed up for 19 years. And as you can see here, ischemic heart disease and stroke risks were increased in offspring from maternal offspring from mother with preeclampsia. However, these associations were largely independent of preterm or small for gestational age. So it was not from preterm or small SGA. Some studies were done to evaluate the pathophysiology of these. And in this study, neonates of preeclampsia showed smaller umbilical vein area, like here, and smaller wall thickness of umbilical vein. And when their heart was evaluated, offspring of preeclampsia showed increased relative wall thickness and decreased LV and diastolic volume. So in previous review, there was also beautiful picture like this. But for offspring, the evidence was mostly based on animal data from animal studies, so there was no clinical correlation. Anyway, offspring's involvement was mainly based on developmental programming involving ROC2 or microRNA or hypermethylation of DNA, and there was male predominance. So I'd like to finish my talk with this beautiful image. So HDP can affect mother and her baby together. And for mother, there can be postpartum cardiac structure and functional change and postpartum vascular structure change. And it can affect to increase in arterial stiffness and endothelial dysfunction. And finally, the risk of hypertension and ischemic heart disease was increased. For babies, neonates cardiovascular structure and adolescent cardiovascular structure were changed, resulting in increased blood pressure, and it might increase their susceptibility of developing cardiovascular disease. Thank you for your listening.
Thank you for your impressive lectures. As you know, our theme of this conference is a healthy BP and healthier life. Her talk reminded me healthy mother, healthier baby. Yeah, we have a panel discussion. We have invited 4 excellent panelists: Kyung Go, Jiyeon Kim, Yuran An, Hee-jung Lee. Who will start? Dr. Go, please.
Thank you for your wonderful lectures for the 4 professors. I'm Kyung Ko from Incheon University. I have a question to the Professor Seoul Kim, because you presented the long-term outcomes of the hypertensive disorders of the pregnant. My question is that was there any recommendation regarding on when we can stop the antihypertensive medication with the pregnant? Because everybody agree with the antihypertensive medication is important for the also the fetal health and the maternal health, but they want to know when I can stop the medication and want to know the specific criteria like the systolic blood pressure 100 or the 120. So is there any data when you prepared the presentation?
Thank you for your nice question. Actually, I have no data for that. I think that question is referred to Professor Lim, maybe. But anyway, when in clinical practice, I usually try to stop the antihypertensive medication if the patient's blood pressure is in normal range with antihypertensive medication, like other patients with hypertension. And the mothers are too busy, and they are too busy to come to hospital, and they really want to stop the medication if they, if it's de novo hypertension. So yeah, I really tried hard to stop the medication, actually. Yeah, but I want to hear from other experts' opinion.
Actually, patients wanted to stop antihypertension medication, but doctor doesn't want to stop medication. Anyway, the first step is necessary of ARB or ACE inhibitor before pregnancy. And usually I want to recommend the CCB medication for the before pregnancy, and then usually recommend the home BP monitoring, and then the dosing is changing. Okay. Jiyeon Kim.
I have a similar question like Dr. Go, Professor Goria. Whenever I met the preeclampsia patient who fully recovered preeclamptic crisis, I have several concerns to discontinue my prescription, including ARNI or SGLT2 inhibitor after delivery. I wonder. Initially, I wanted to find the clue or tip after safe delivery for preeclamptic patient or preeclamptic woman after safe delivery. But I until now I don't know when is the most appropriate time to discontinue medicine. Someone relieved their symptom and their BNP level was totally normal, but someone shows normal EF but decreased absolute value of strain value. When I met some vague or residual risk, I usually keep my medicine till the patients fully recover, but I don't know what or when is the most appropriate time. Do you have any answer of Dr. Soli Kim or Dr. In Jung-jo?
Well, it's not an easy question. Usually, hypertensive disorders pregnancy are defined until hypertension continues after 12 weeks later pregnancy. So I usually see the patient until 12 weeks. We see whether your blood pressure comes to normal. Then I think this might be gestational hypertension. But if it continues after 12 weeks, then you have chronic hypertension. So we have to take care of it. And another question might be peripartum cardiomyopathy, but I don't know. And I think no one knows about that. How long should we continue the drugs? But it's important question to be answered, I think. Thank you.
If the patient have a postpartum cardiomyopathy with low EF, you should keep the medication and then recommend do not pregnancy again. So it is not, it is clear. And ARNI or SGLT2 is no reference about during the pregnancy or post-pregnancy. So it is, nobody knows. How about Yuranan?
I have a short question to Professor In Jung-jo. I've learned and reminded that there was a early onset preeclampsia and late onset preeclampsia through your nice presentation. I wonder, is there some relative contribution of pure gestational hypertension and chronic hypertension to both late onset or early onset preeclampsia? Relative distribution data? Is there maybe the gestational hypertension tends to more appear at early onset preeclampsia?
Well, actually, there is a debate regarding whether the transient gestational hypertension is the same as to preeclampsia, because as you can see, gestational hypertension, which appears after pregnancy and disappear after delivery, it usually shows benign prognosis in some cases, but some cases shows the adverse event. So whether this transient gestational hypertension is the same disease as the hypertensive disorders pregnancy, we usually think. So well, the question might be, so first, preeclampsia is not, current concept is that preeclampsia is not the one disease and it's very complex disease with multiple pathogenesis. As I said, first we noticed that there was a placental pathophysiology was first discovered by pathologists, and we find that this must be the reason for the preeclampsia. But later, people found that there are another pathomechanisms because some pregnancies showed preeclampsia with normal placenta, and some showed preeclampsia, normal delivery with pathologic placenta. So there might be another maternal factors might be involved, we also think, and there are also another factor with uterine artery. So there might be some problems. So it's not a one disease because this is classified as preeclampsia because pregnancy woman with hypertension and proteinuria was defined preeclampsia, but it's not the same entity, and it is composed of multiple pathogenesis and multiple diseases. This is the current definition for preeclampsia.
Thank you.
Okay.
Hi, I'm Hee Jung-lee from Gaming University, and thanks all the speakers for the wonderful lecture. I have a question, one question for Professor Kyung-hee Lim. Professor, recently our center experienced a case of a mother who suffered from respiratory arrest due to pulmonary congestion combined with hypertensive emergency immediately after delivery. Initially, we assessed her with preeclampsia with severe hypertension and treated, but there was no improvement. Then we chose the plasma exchange performed for the possibility of TTP, and the patient improved and survived. I had a lot of trouble with this case, and when preeclampsia and HELP syndrome looks like similar to TTP in this clinical presentation, which test or clinical feature do you rely on most of differentiated between them in real practice, or how many cases like this patients with critical hypertension emergency after delivery?
Thank you for interesting case, but I have nearly experienced that kind of patient, so I barely give recommendation for you. But I think in patient with volume or overload, we should prescribe the diuretics, especially furosemide. But in some case, some postpartum patient did not recover from the furosemide. Then we have to consider other disease like TTP, and that times we have to more aggressive routine blood test, so distinguish the patient characteristics. Yes. Thank you.
Yeah, Dr. Lim, I have also a short question about you. Usually we thought ARB or ACE inhibitor is the same drug, but you recommend the postpartum hypertension medication. ARB is not contraindication, and ACE inhibitor is good. So what is the main reason? Is it just the database? Or?
Usually the database, but some reports suggest the ARB may induce the baby's kidney function, reduced kidney function, and pulmonary edema and poor lung menstruation. So ARB is not recommended in the breastfeeding patient. Thank you.
Okay. Is there any comment or questions? I have two comments. Dr. Go? Yes.
I have one more question. I wonder which guideline we should follow, the domestic or international guideline, because our current guideline recommend the target BP is less than the 150 and 100 millimeters mercury, but the international guideline they recommend the stricter the targets. So I want to know the practical tip or the recommendations.
Wow. I usually follow the domestic guideline first because it's the environmental factor, and it might be indicated after guideline revision, I think. I also one question, recommendation for one comment for Marfan syndrome. Young Marfan syndrome patient wanted to pregnant. We usually prescribe atenolol or losartan like ARB. At the time, I stopped the ARB but continue at atenolol. So atenolol also has a problem with or low birth weight, but usually in Marfan case, we should keep going on atenolol. So, is there no comment or questions? So I'd like to close this session. I would like to thank all the speakers for their presentations and the panelists for the active discussion and everyone who participated. Thank you.
Thank you.
Whatever you want, whatever it is. In Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
Can I see you a minute, please?
I know it sounds silly, dear, but do it for me, please.
It is time to begin the session. I'm delighted to welcome all of you to this session. This is a special lecture session. I'm very happy to introduce Dr. Athanasios Benetos from France. He affiliated University of Lorraine, Nancy, France. He is a very famous expert of geriatric medicine, rehabilitation, and palliative care. Actually, he gave us a talk on hypertension in elderly patients earlier this morning. In this session, we'll provide a more detailed lecture on the pharmacology treatment for elderly patients. Title is Decrease of Antihypertensive Treatment in Older Frail Adults, the result of the Retreat Frail clinical trials. Dr. Benetos, please.
Thank you. Thank you very much for this introduction. Dear colleagues, dear friends, I think by its time it's 30, not 20, is that right? It's 30 minutes, yeah.
20 minutes.
It's 20 minutes?
20 minutes.
No, it's 30, I think.
30, sorry.
Okay, good. Just, if I'm wrong, thank you. Okay, so yes, we will discuss now the, let's say, the results and the lessons from the Retreat Frail controlled clinical trial. But okay, let's talk about the treatment of people over 80. If we can fix the limit of 80 for talking about older people. Actually, this treatment is based in the evidence of the benefits has been established following the Hypertension study, published about 17 years ago, and showing that versus placebo, an active treatment was clearly beneficial for people over 80. And of course, if we deal, something important is that if we deal with this group of age, over 80, we know that first is the most growing part of the population all over the world, and also is the most heterogeneous population in terms of functionality. There are people that are very good physical status and many people that are altered. So this is why we use this limit of 80. It's not because there is something magic over the limit of threshold of 80. It's just because globally, currently, in our societies, these limits defines the people above which the big heterogeneity exists in terms of physical status, functionality, and frailty. And so the question is whether the results of the Hypertension study can be transposable, let's say, to the majority of these people. So this is an important question, and we have to, the people who did the study, Hypertension study, tried to answer that question, and they said if we fix criteria of frailty in patients who were included in Hypertension, those who with frailty or without frailty, they didn't have any difference. So the benefits can be transposable from most fit to less fit patients. So this is in Hypertension. And also the SPRINT study, it was not versus placebo SPRINT, but it compared a more aggressive and less aggressive strategy, and they had a subgroup of over 75, and they showed also that in this subgroup over 75, these benefits of the more aggressive strategy was beneficial. And again, in this, they didn't find an important influence of the level of frailty in the obtained results, which means that this, but I show you these two studies here, they said independently of the frailty level, benefits exist either versus placebo or one more aggressive versus one less aggressive strategy. Always, when we have to deal with that, it's important for us physicians to see which are the criteria, which is the population that has been included in this study. So it's important. I will show you the inclusion and exclusion criteria of HIVET study and SPRINT study. So you can see here the exclusion criteria of HIVET study, where any patient living in a nursing home, having a limited autonomy, or having some degree of clinical dementia, or having a heart failure needing converting enzyme inhibitors, diuretics, or antagonists of the AT1 receptors, an orthostatic hypotension, a renal failure, and any patient over 80, because this whole population was over 80 in IVET. I was one of the investigators of the IVET, actually. And any patient that presenting a high probability of having major health problems during the 5 years following the inclusion. So you can see that from the beginning, they excluded all patients with, let's say, a certain level of frailty. Very mild frailty were inside, but all others were outside. So any analysis post hoc in those who had been included, by definition, do not deal with very frail people, because those were from the beginning excluded. And it's exactly the same thing, even more severe with SPRINT study, where in addition to this criteria, there is history of stroke, symptomatic heart failure within the last 6 months, and as you can see, all the other criteria with orthostatic hypotension, with loss of autonomy, and so on. So this does not mean that these studies are not good studies. They are very nice studies, very interesting and important studies, but they deal with people that are over a certain age, but mainly fit people, because all the others have been excluded from the beginning. So this is a very important thing to know for any study, and this is particular for this study. So far, we treat these people, all the people over 80, based on the criteria of these studies, especially HIVET study. So we extrapolate that the same benefits can be also valid for the very frail people. However, in a recent paper, this paper is interesting because the authors took the criteria of SPRINT study. In the left part of the study, of the slide, the blue one, you have the people that have been included in the SPRINT study, and in the other part, we have the people that have been excluded from the study. And you can see here how different is the relationship between blood pressure and in observational, it is an observational study. You can see that the relationship between blood pressure and the events, the cardiovascular morbidity and mortality, was rather the same as in younger people for the non-frail persons, but it was completely different for the frail person. So it makes some difference. But these are observational studies. We don't know what's exactly the difference. We know also that people that have, I showed that this morning as well, this is an older study we have performed in nursing homes, observational study, and we have seen also that people with low blood pressure, under at least 2 antihypertensive medications, have over 80, all, have a double mortality as compared to people without these criteria. I mean, without low systolic blood pressure less than 130 under antihypertensive treatment. So these are observation data. Again, it's not high evidence, but means something, that all these people, again, over 80, it's not something homogeneous. And maybe this heterogeneity in functional status, in frailty, on risk for having side effects may be important. Example, this study conducted by the group of James Shepherd in Oxford, we showed that letters are small, but just let's focus in the red part of the slide here. And you can see here you have groups of frailty. Here you have the fit, mild frail, moderate frail, severe frailty. Again, the same thing with several different side effects, adverse effects after antihypertensive treatment. And we can see here, after adjustment for age, this is very important. It's not a question of age here. It's for a given age, older people will have many of these side effects were related, directly related to the level of frailty, like falls, like kidney injury, like electrolytic abnormalities, like gout, and so on. So it's important, but all that I repeat, these are observational data. And the latest guidelines, European guidelines, for instance, the ESH guidelines 2 years ago, point out that we have to take into account the frailty level in strategies. Okay, but I don't go to the details of that, but it is important to, let's say, separate people according to the fitness or the frailty level, not to not treat the ones or the others, but to adapt therapy, okay? And so following that, the ESH 2023 said very quickly that those who are fit, more or less, will have to have the same attitude as people of middle age, just to go a little bit slower because things can change. But globally, and the objectives and the strategies can be very close to the people, let's say, of 60, 65, 70, or whatever, which means, but just to start with monotherapy. But when we go towards the most frail and the very frail people, you can see here the columns, we progressively will be less aggressive. And you can see, for instance, in those who are severely dependent, we will consider, sometimes we will not treat. It depends on what's the prioritization. It depends how many other medications they exist. And also we will treat people when they are over 160 and not 140. We will have target treatments for, less ambitious to avoid side effects. And we can also think about reducing deprescribing if blood pressure is very low or orthostatic hypotension. And this group in the middle, it's in between the two, which means sometimes we can be a little bit less aggressive, but globally we will treat, okay. And also in the ESC 2024 guidelines, even it's not so precise, there is the same spirit. As you can see this from the ESC 2024 guidelines, and you can see here, they say taking this, again, this classification, we call that clinical frailty scale with the small images, you can see here. And they say the clinical frailty scale 1 to 5, which means the most, let's say, robust or mildy, with a mild frailty. We can have an attitude which is rather close to the younger cohorts, okay, but going more slowly, whereas when we are clinical frailty scale more and more, as you can see the images also here, important, we will be more aggressive, and we will also consider here, also we're talking for the first time for deprescribing medication, as you can see, under some conditions. I will not enter the details, it's not the aim, but just the spirit is what it's interesting, is that for the very first time, this concept enter in the guidelines, especially in the European guidelines, much less in the 2025 American guidelines. So, but these same guidelines say that all these, let's say, changes are based on very few evidence. Why? Because so far we didn't have studies in these very frail people. So, for instance, ESH 2023 guidelines, they said we need, for the very old and frail people, we need more solid data to specify our strategies. And there are many unexplored questions in this very old. For instance, can we decrease mortality rates among patients with low blood pressure and several antihypertensive drugs? As I show you, they have an over-mortality, the frail ones. If we reduce the number of antihypertensive drugs, it's an open question. Which are the risks and the benefits and the balance between risk and benefits by prescribing antihypertensive medications? Can we do it? And does the frailty level in this, because among frail people we have several degrees of frailty as well, does the frailty level modify this balance between benefit risk? We are physicians, and the most difficult thing we have to do in our practice, clinical practice, one of the most difficult, it's always to evaluate this balance between benefits and risk. This is medicine. And so if we cannot do that, we don't play our role as physician. And this is what we tried to do, or attempted to do with the Retreat Frail multi-center randomized controlled trial conducted in nursing homes. And we took patients over 80 with the characteristics I'll show you: low blood pressure, systolic blood pressure, and under at least 2 antihypertensive medications. Because in our observation study, this was the subgroup with over mortality. And so we randomized in two groups, parallel groups, one intervention group with a step down, progressive decrease, and organized, I will show you how, yes, step down of antihypertensive treatment, and the control group, which was the usual care. The primary endpoint was all-cause mortality. This paper, the results of this study have been very recently, 2 months ago, published in the New England Journal of Medicine. And I will show you some characteristics of this study, because it's important, not only the results, but also the methodological. First of all, we chose the primary endpoint, the all-cause mortality, even if for these patients, maybe all-cause mortality is not, let's say, the most important. It's important, of course, death is, or life is very important. But I mean, if we choose as a primary, it was because, first of all, from the methodological point of view, it's much easier to define the number of patients we need in order to find difference or not find difference and so on. But also because in this group, as I told you, there is an over-mortality, and the main question was whether we can reduce this mortality. But we also fixed ad hoc, before the study, the results, several pre-specified secondary endpoints you can see here in order to define this ratio between benefits and risks of reducing the antihypertensive treatment. A very important issue here, of course, concerning also what I said before, is that we wanted and we included people, all people that had the main criteria, low systolic, over 80, low systolic blood pressure less than 130, and at least 2 antihypertensive medications. Almost no exclusion criteria except people that we could not stop any medication because they have many other compelling indications, and we could not stop any antihypertensive medication, and people that were really at the very end of their life. Otherwise, we include no matter the level of autonomy, no matter the level of cognitive. We wanted not to exclude the most frail in order to avoid what I criticized at the beginning, which is we give treatment to the people that never participate in studies, in clinical studies. We choose to study a new strategy with less medication, and we don't want again. So we spent many time to convince the ethical committee to allow, when the patient were not able to consent, to have the informed consent by family, relatives of confidence persons, and we obtained that. But it was not easy. And so this is something important I wanted to point out. Now, methodological point 2 is how you fix which medications you can stop. We all know that most of the medication, antihypertensive medication, have other cardiovascular indications, heart failure, coronary heart disease, atrial fibrillation, and so on. So from the beginning, in each patient, from both groups, intervention or usual care, we fixed for each patient which were the drugs that could be stopped, because we call that list 1, that they didn't have for the given patient a compelling other indication, and we fix it for this medication in order from the less, let's say, what we believe useful central agents to the most, let's say, useful for older people, which is converting enzyme inhibitors, thiazides, and CCBs. Okay, so this is list 1 that could be stopped. And then list 2, medication that due to compelling indication for the given patient could not be stopped. So we didn't touch those. So this is the second methodological point that's important if you want to deprescribe. The third one is that these patients in the nursing homes have, for the research groups and the local personnel in the nursing homes, a very strict control, not exams multiple, but clinical follow-up at the beginning every month for the first 6 months, and then every 2 months for a follow-up was up to 3 years and more than 3 years in nursing homes. So, and you can see during these evaluations, we have every month or every 2 months evolution of treatment, blood pressure measurements, adverse events, and every 3 months at the beginning, and then every 6 months, a complete clinical and geriatric assessment with all the functional assessment, so every time during this follow-up period. As expected, this population had some characteristics. First of all, you can see here it's a population of 90 years old at baseline, because we did exclude the older people. As it's, IVET was over 80, and the mean age was 83, I think. So means that very old were not included. Okay, so this is 90 years old. This is the two groups. You see very, very balanced, the two groups. And of course, it's a population. You can see here the different classes of the clinical frailty scale. 38% have severe frailty, 22 moderate frailty, 29 mildy, and only less than 10% were fit patients based on the criteria of the clinical frailty scale. This population was not only a very old, mainly female, because in the nursing homes, 80% are women, in France at least, and more generally, this is the numbers. So I was saying not only a very old and very frail globally population, but also at very high cardiovascular risk. And this is important to know if we can stop treatments, cardiovascular treatments in this very high risk. Why very high risk? You can see almost 40% atrial fibrillation, more than 23% heart failure, coronary heart disease 19%, stroke history 19%, diabetes more than 23%, and of course dementia about 40%, 45%. And this is the number of drugs following in the two groups. So the follow-up in the different visits was identical in the two groups. The only thing that changed is in the group of usual care, we didn't touch. We said the physicians, the GPs that follow the patients, you manage the treatment as you want. And the other one, we reduce the treatment of the least one medication, you manage the rest. So this is the only difference between the two groups. The visits and the follow-up for the rest was the same. So there was a slight also decrease in the medications in the usual care, probably because physicians influenced, let's say, by the meaning of the study, because they knew the study, had the trend to reduce somehow the treatment, but there was a clear, more important decrease. The difference between the two groups, it's 0.7 medications less in the antihypertensive. The blood pressure levels, the difference was about significantly higher in the prescription group, as we can here, step down, not too much, 4.1 millimeters, but all over the follow-up of the study. There was no any difference in the primary endpoint was total mortality. The total mortality, as you can see here, the hazard ratio, it's 102, which is almost identical, with narrow confidence limits. And you can see here the median survival was 26.6 in the control group and 27 months in the group of intervention similar. We found an interesting trend. It's not significant, but we put that in the paper, and I would like to point out on that. As you can see, when we divided the population, this is pre-specified criterion. So we divided the population according to the classes of clinical frailty scale, and we have here the efficacy, the interest of the strategy, the intervention strategy versus usual care in the 4 different groups of frailty. Here you have the most fit patients, and here you have the most frail patients, which was the much larger group. And you can see the interaction, it's 0.08, which means that the step down, the decrease of the treatment strategy, has the trend to do better in the most frail, and the usual care to do better, trying to do better in the fittest patients, who were less than 10%, but the trend, as you can see, it's continuum. So this is something interesting and confirms the idea and the hypothesis that the level of frailty may influence the interest of such strategies. So clearly here, in the most frail people, we can say that there is no harm, let's say, for decreasing, and these groups, no harm for decreasing. So a couple of still slides in the results before the conclusions. We have here all the primary and secondary endpoints. We can see that we don't have difference in major cardiovascular events. We don't have differences in mortality, non-cardiovascular mortality, deaths from any cause here. Deaths from non-cardiovascular causes identical, as you can see here, 53%, 53%. And the only difference we have is the number of deaths from COVID was not very high, the number, because most of the people were included in the follow-up after the vaccination for COVID, which is January 2021 in France. And we can see here that the usual care had 3 times higher mortality rates than the decrease in treatment. And another study have shown that, but observational study. So that's interesting. Of course, it's not at all the main, let's say, the main objective, but it was something that the authorities asked us from the beginning to study, particularly because this study took place during the COVID pandemic. So we have a benefit in terms of that for step-down strategy. We don't have differences in the evolution of the different functional capacities of the people in the 2 groups. And we have here the changes in cognitive function, ADL, which is autonomy, gait and speed, muscle force, and quality of life. There are no any differences between the 2 groups. There are no difference either inside serious adverse events. You can see in the 2 strategies, we have exactly the same total numbers in percentages, and we have no differences in the different adverse events. So, in summary, Retreat Frail is the first randomized controlled trial to evaluate the long-term, I repeat, 3 years, 38.4 follow-up, mean follow-up, which is extremely long for this population. So first clinical trial to evaluate the long-term effects of antihypertensive treatment reduction on mortality and secondary morbidity and several geriatric parameters in a large population. So it's 1,048 residents randomized in 2 groups, mainly female, frail patients with low blood pressure and a combination hypertensive therapy. The step-down strategy did not reduce all-cause mortality of the follow-up period of 3 years, more than 3 years. The step-down strategy led to a long-term reduction of antihypertensive medications, so it's possible. I mean, what you say, of course, if you stop your reduction, yes, but I mean, the physicians had the right, if they believed so, to put again the treatment, or if pressure went up, in our protocol, we have reintroduction of the treatment in case of important increase of the blood pressure. So this did not happen, very unusual, and globally the step down over the entire follow-up was led to a less important number of medications, about 1 medication less in the intervention treatment. And the Retreat Frail showed that an antihypertensive medication step-down strategy does not have a clinical relevant effect on all-cause mortality, does not increase, does not decrease either, and has no apparent effect on functional capacities, neither in major adverse cardiovascular events or other serious adverse events. So let's say the clinical translation in the contribution of Retreat Frail of this thematic, I developed from the beginning, is that the prescribing of the antihypertensive treatment can be considered in very old subjects with these characteristics: low blood pressure, less than 130, more than 1 antihypertensive medication, and especially in the frailest, because as I show you in this subgroup, it seems that there are more interesting results of the prescription, and in this group in which polypharmacy is always a major problem. I didn't say that, but the mean number of total medications, chronic medication, different medication, the mean number at baseline in both groups was 9.3 medication, all groups, okay? And the last comment here is that, in my opinion, the prescription has to be considered as exactly the same as any other prescription. No way to do the prescription because these are old people anyway. They will die, so I don't care. I save money. That's not the objective. The objective is to treat better patients. And to treat patients better, when we prescribe a medication, we have to know the patient, we have to know the indications, the counterindications, the clinical stats, and we have to follow how pressure evaluates, which are the side effects, if any, and so on. So it sounds more complicated, but as for any other prescription, the prescription needs to be done by respecting medicine, ethical and medical rules. Thank you for your attention.
Yeah, thank you for the informative and practical lecture about the decreasing antihypertensive medication in older frail adults, because Korean society is very aging society. Dr. Lee?
May I take one examination?
Okay.
Thank you very much for your wonderful lecture. I absolutely agree with the step-down therapy in frail patients, but I also think minimal amount of antihypertension medication might have some protecting power rather than totally stopping the older medication. So what is your opinion, the low limitation of step-down therapy, some leaving minimal dose, in my case, half dose calcium channel blocker, or it is no difference between leaving minimal dose or stopping older medication?
This is a very good question. In the protocol, we said at inclusion, those who were randomized in the intervention group, okay, we removed one medication. In few cases, it was predefined the protocol when they had furosemide at high doses, but furosemide could be in the list one. I mean, no retention, heart failure, and so on. But some people were treated with furosemide. When furosemide was at high doses, or when there are beta blockers, at the beginning, we stopped half dose. But a month later, we stopped completely. Okay, one medication. Now, if in the next visit, 6 months later, not every month, but every 6 months, if blood pressure remains systolic less than 130, we stop the second medication. So we stopped as far as SBP remained lower than 130. So if in some patients, we stopped all the list one medications. The question is, does it make a difference? Invite me please next year, because now we do the additional. I mean, the analysis we did and we published in the New England was only the analysis that were in the SAP, Statistical Analysis Plan, and predefined criteria. Everything, you know how these journals, everything which is post hoc, no. But now we analyzing that, and in few months we will publish, maybe before the next Congress, these results, and this is a very important question. And also how people responded in terms of blood pressure in this decrease or interruption. Some increased blood pressure, some mildly, and some they didn't. So does it make a difference? I cannot tell you now.
Yeah, very important issue. Actually, this session is a special lecture session. There will be no Q&A or discussion for this session. So I would like to close this session.
Thank you.
We would like to present you with the flag in the recognition of our deepest appreciation.
Athanasius Benetus, in deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2025, in conjunction with the 63rd Scientific Meeting of the KSHE, November 8, 2025.
whatever you want, whatever it is. In Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압 관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
Good afternoon. It's time to start the luncheon symposium. And this symposium is sponsored by the Novartis Korea. I'm Kwang-il Kim from Seoul National University, and I will introduce the speaker of this session. Actually, it is a great honor for our society to have the Ji-Gang Wang, because he is so famous, so do not need any introduction, but I would like to introduce briefly. He is currently the director of Shanghai Institute of Hypertension, and he is a professor of cardiovascular medicine in Regin Hospital. And his talk today is the emerging role of RNA in hypertension management beyond heart failure. Professor Wang, would you please start?
Okay, thank you very much. I should thank the organizers of the Korean Society of Hypertension meeting 2025 and Novartis Korea for the kind invitation for me to attend this very internationally influential meeting. So I'm going to present actually more than 15 years journey that I worked with Ani Sakubacho Valsartan since the very beginning. Actually, Korea did very well in the management of hypertension if you compare with many other countries in Asia and in the world. But nevertheless, if you look at the control rate, there is still room for improvement. So if you treat hypertension early and properly with right drug or drug combinations and sufficiently in the target, then you can really prevent the disease progression and, of course, cardiovascular events and mortality. But otherwise, if you don't treat sufficiently, you probably would have to treat those late stage or end stage diseases, such as heart failure. These days, we have very efficacious therapies, such as this Sakubacho Valsartan, a representative drug of Ani. It has been shown very efficacious in treating heart failure with reduced ejection fraction and with preserved ejection fraction. So you see the drug is very effective and changed the treatment of heart failure. But this drug is quite unique. Actually, it is a antihypertensive agent since the very beginning. This is a very novel compound, including actually two molecules in one chemical compound, Sakubacho Valsartan. It is not a mixture of two drugs. It is a single compound with a novel crystalline supramolecular complex. So this drug has a very special mechanisms of action, including several therapeutic targets, the natriuretic peptide system, sympathetic nervous system, and renin-angiotensin system. So it is really a multi-target drug for blood pressure lowering and for the treatment of cardiovascular diseases, especially heart failure. As I said, it has been actually developed as an antihypertensive agent in the very beginning. You see this phase 2 trial in European populations. It showed very clearly the drug is more efficacious than valsartan, even at a very high dosage, 320 milligrams per day. So if you look at the difference in systolic and diastolic blood pressure, actually it was quite large, meaning that the drug is a very efficacious blood pressure lowering agent in the treatment of hypertension in European patients. That's because it has a multi-target therapeutic mechanisms, as we have seen in one of the previous slides. Actually, it works almost against all the current therapeutic targets, so it is superior to all the other classes of drugs, because all the other drugs normally or usually work only on a single target, either vasodilation, natriuresis, or the inhibition of renin-angiotensin system or sympathetic nervous system. So in the past years, the drug has been tested in the treatment of hypertension in many clinical trials. Actually, I was involved in the very early studies in Asia. And we tried very hard to bring this drug into the management of hypertension since the very beginning, before it was approved for the treatment of heart failure. So here you see the trial showed various dosages of sacubitril of valsartan was very efficacious in reducing blood pressure against placebo, and has a very significant dose-independent effects. So you see here on the left hand, sitting systolic, diastolic, and pulse pressure. On the right hand, ambulatory blood pressure. So you see both clinic and ambulatory blood pressure measurements, and you see a very significant difference and dose-dependent blood pressure lowering effect. If you increase the dosage, then you see an increased efficacy of blood pressure reductions up to 20 millimeter of mercury clinic systolic blood pressure and 16 millimeter mercury ambulatory systolic blood pressure. And it is a very safe drug in terms of side effects. It's more or less as a placebo. So on the one hand, it is very strong in lowering blood pressure. On the other hand, you don't see so many patients with hypotension. So it is a very stable antihypertensive drug. So you see the combined analysis showed the drug is dose-dependently lowering blood pressure from 100 milligrams per day up to 400 milligrams per day, as we have seen from also the results of the trial. And here you see the Chinese phase 3 trial. Actually, so many years ago, we did this study, tried to register the drug for the treatment of hypertension in China and Asian countries, probably because of the Paradigm and Paragon trials, and it was first approved for the use of heart failure. But if you look at this phase 3 trial in the Chinese population, again, it showed great blood pressure lowering effect. If you compare the results here with the results in European populations, actually, you see an even greater blood pressure lowering effect. That's also why we tried very hard in China and in Asia to bring this drug for the treatment of hypertension instead of the late use for heart failure. And we also did a study for combination therapies. So you see in those patients with amlodipine 5 milligrams monotherapy inadequately controlled hypertension, then we randomized those patients into the continuation of amlodipine 5 milligrams per day, or the addition of sacubitril valsartan 200 milligrams per day. So it means the combination of sacubitril valsartan plus amlodipine against amlodipine monotherapy. And here you see a very big blood pressure effect on the left hand, again, sitting systolic, diastolic, and pulse pressure. On the right hand, ambulatory blood pressure values. Here, if we look at ambulatory blood pressure reductions, you see a very big difference against monotherapy of amlodipine 5 milligrams per day. So if you look at the real values, around 14 millimeter systolic, 8 millimeter diastolic, and even close to 6 millimeter pulse pressure reductions. So if we look at 24-hour blood pressure lowering effects, you see very smoothly over 24 hours, especially during sleeping nighttime hours for both systolic and diastolic blood pressure. And again, it shows a very good tolerability and safety, even in those patients on combination therapy with amlodipine. So that's why when we updated the Chinese hypertension guidelines last year, we recommended sacubitril valsartan, which is a representative drug of ANI, as one of the primary agents for the treatment of hypertension. So here you see, in parallel with the 5 conventionally recommended antihypertensive drugs, angiotensin receptor blockers, ACE inhibitors, calcium channel blockers, beta blockers, and thiazide diuretics, you may also choose ANI, typically sacubitril valsartan, as a primary agent for the treatment of hypertension in China. So in the next part of my presentation, I would discuss in 2 different directions. First of all, resistant hypertension, then patients with comorbidities or already cardiovascular complications. So let's first look at the treatment of resistant hypertension. We may start with a case of resistant hypertension a few years ago. Actually, before the drug was approved for the treatment of hypertension, we got a special permission in our institution and hospital to use this drug for the treatment of resistant hypertension. So it's already a few years. This patient had a very severe hypertension for a long time. Then when we started sacubitril valsartan, of course, we used the high dosage of 400 milligrams per day. Then we totally changed the scenario from a very bad situation to a healthy situation. So already a few years, the patient even survived a lung cancer surgery, and she was in a very good condition with well-controlled blood pressure to a level even below 140/90 in such a difficult case. So if we look at the definitions of resistant hypertension, and it actually requires at least 3 classes of drugs at optimal dosages. And so then a few years later, you don't see much change, but it's written in a more specific way, including the use of various classes of drugs, calcium channel blockers, renin-angiotensin system inhibitors, and diuretics. So in many patients, actually, even you use these 3 classes of drugs, and blood pressure remains uncontrolled. So that's why we define resistant hypertension. We recommend the use of various additional classes of drugs, especially MRAs, mineralocorticoid receptor antagonists, and alpha or beta blockers. But we may also replace the drug with ANI or sacubitril/valsartan. But if we look at the situation in some countries, for instance, in the United States, in the ENHANCE, if you look at the use of diuretics, actually it was not so sufficient either for thiazides on the left hand, also for the MRAs on the right hand. So you recommend, but people don't use. One of the major reasons is hypokalemia in many patients who started, for instance, MRAs. If you look at the real-world data in the United States, actually, after starting using MRAs in the treatment of heart failure and resistant hypertension, the incidence of hypokalemia increased substantially in a few fold in the United States, even in the emergency. So that's also why we probably should consider a different approach. For instance, replacing one of the component drugs for the treatment of hypertension, then probably you don't really need MRAs for treating those patients with so-called resistant hypertension. So in this particular study, actually, if you add sacubitril/valsartan, then you can even reduce the incidence of hypokalemia when the patients started MRAs for the treatment of hypertension. And if you look at severe hypokalemia, there was a substantial reduction when you combine sacubitril/valsartan with MRAs. There was a very elegant analysis of the data in patients with resistant hypertension and heart failure with preserved ejection fraction. So here you see whenever you start sacubitril/valsartan, you can really prevent the primary clinical outcomes. So if you look at the curve, it's very clear in those patients, even with resistant hypertension, you can bring blood pressure to the controlled level. Then if you look at whether it's apparent or MRA-resistant hypertension, you see very similar results. If anything, the difference was even greater in those patients who started MRAs already for the treatment of hypertension. And if we look at the so-called refractory hypertension, so it means even more difficult to control their blood pressure. Here again, in this study published a few years ago, then you can really achieve the target of blood pressure control in those patients with resistant or here even refractory hypertension. So again, we look at another group of patients, resistant hypertension plus hemodialysis, and you see a very significant drop in blood pressure and other parameters, for instance, BNP. So here, actually, we have a very important finding. It means that the blood pressure lowering effect is, to a large extent, independent of its natriuretic effect. It has multiple mechanisms of blood pressure lowering. So then I will present to you a few important cases. Let's start with heart failure with preserved ejection fraction. Here we can see a patient who actually recently developed heart failure with preserved ejection fraction, even though he controlled his hypertension very well for more than 10 years with amlodipine 5 to 10 milligrams per day, but he still developed heart failure. So in this patient, if we may treat earlier with the right agent, for instance, sacubitril valsartan, probably we can prevent heart failure. But in this patient, we replaced amlodipine with sacubitril valsartan, and then blood pressure was very well controlled, and the symptoms also disappeared. So it means that if we will use the drug in any stage of cardiac disease, or early or late stage, you can really achieve blood pressure control and in the prevention of disease progression or even death. So here again, we can see the results from the elegant analysis in patients with resistant hypertension and heart failure with preserved ejection fraction. I think one of the most important reasons is blood pressure lowering effect, and probably to some extent also associated with its other mechanisms of action. So for those patients with heart failure with a preserved ejection fraction, and one of the very most important treatment target is lowering blood pressure. But in addition or over and above, you have to prevent the disease progression, especially cardiovascular event and mortality. Here you see the Paragon heart failure trial. You see a very clear-cut effect, although it was not statistically significant, but it's clinically relevant with 15% reduction in the risk of all-cause mortality and hospitalized heart failure. So one of the reasons is blood pressure. In fact, we have to re-emphasize this. Here you see blood pressure was well and much better controlled in the group of sacubitril valsartan against enalapril treatment in all levels of systolic blood pressure at baseline. Then if we look at early stages of cardiac disease, left ventricular hypertrophy, which is a very important structural abnormality. And here we can see a patient with controlled hypertension and left ventricular hypertrophy. So in this patient, we typically need drugs that inhibit the renin-angiotensin system. But if you use sacubitril valsartan, probably you can achieve an even better outcome than ACE inhibitors or angiotensin receptor blockers, because this drug is apparently more efficacious in treating hypertension and the structural changes of the left ventricle. So here we have very strong results from this randomized controlled trial that compared sacubitril valsartan 400 milligrams with olmesartan 40 milligrams per day. So they are all at optimal or the maximal dosages. Then if we first look at the changes in distensibility at 12 and 50 weeks, apparently sacubitril valsartan is more effective than olmesartan 40 milligrams per day at both follow-up visits, with a more significant difference at 12 weeks. That's because in olmesartan group, many or more patients need to add another drug of actually amlodipine. But if we again look at the sitting systolic blood pressure, central pulse pressure, and left ventricular mass index, particularly left ventricular mass index, you see a very sharp difference between the two different treatments. Sacubitril/valsartan was more effectively reduced the left ventricular mass index than olmesartan 40 milligrams per day in this very elegantly conducted study. And in this study, we can also see a 24-hour blood pressure lowering effect, but here we see two different measurements. One is the brachial artery on the upper part, and the other central aortic artery, which is on the lower part. So for both brachial and aortic blood pressure, sacubitril/valsartan more effectively reduced these blood pressure values. And if we look at another feature of the results, you see a very bigger or greater nighttime blood pressure lowering effect. So here it means that the drug is particularly effective in reducing nighttime blood pressure and controlling nighttime hypertension, which is more prevalent in the Asian populations, probably because of the higher dietary sodium intake and a higher prevalence of salt sensitivity. So then if we look at another group of patients with severe hypertension and CKD, so this is a very difficult to treat case of hypertension. She was already on dialysis for some years, had very high blood pressure, often reaching 200 milligrams systolic blood pressure with multiple drugs. Then she reached me before COVID, and her blood pressure was very well controlled, and even before it was approved for the treatment for hypertension, because she also had actually heart failure. And this patient died during COVID because of COVID control for 2 months without dialysis. But the patient had a very well-controlled blood pressure before the COVID control. So it was so unfortunate, and she passed away during the 2 months COVID control without dialysis. But this patient was a very particular case of difficult to treat hypertension with multiple cardiovascular and renal diseases. Again, we can look at the data from randomized controlled trials of sacubitril/valsartan against irbesartan. So here we first look at blood pressure. Sacubitril/valsartan was more effective than irbesartan at equivalent dosages, 400 milligrams against 300 milligrams. And if we look at the side effect, actually they had a very similar side effect profile, although sacubitril/valsartan was more effective in lowering blood pressure. So again, these studies prove the drug was particularly effective in those very difficult to treat patients. And finally, I would spend a couple of minutes discussing about patients with coronary heart disease. This is a case of controlled hypertension, increased blood pressure variability, and coronary artery disease. So when you have hypertension and increased blood pressure variability, and it is very dangerous for those patients with coronary artery disease, because you may have low perfusion, the risk of low perfusion if blood pressure is too low, and you would have the risk of high blood pressure if blood pressure is not controlled. So this patient actually had blood pressure quite well controlled to the mean level, but not a variability. So that's one typical case of patient with coronary artery disease. We replaced perindopril 8 milligrams per day with sacubitril valsartan 200 milligrams per day for a few weeks, and it totally changed the scenario. Not only blood pressure remained controlled, also blood pressure variability decreased substantially and without any symptoms. So the most important thing for treating those patients with coronary heart disease is to prevent coronary events, because patients with coronary heart disease have very high risk of mortality and cardiovascular events. So here again, if we look at the results of paradigm subgroup analysis that compared sacubitril valsartan with enalapril, typically on coronary outcomes, so you see the difference was 17% in favor of sacubitril valsartan. So here again, if you believe the results of this randomized controlled trial, then you have to replace some of the drugs with sacubitril valsartan for the control of hypertension and again for the prevention of cardiovascular events and mortality. So finally, the conclusion is very clear. The drug has been approved for the treatment of hypertension in China since 2021 and subsequently in many other countries in Asia and in Eastern Europe. So now we can use this drug. If we use this drug early and sufficiently, we can prevent most of the cardiovascular events, and we don't have to treat heart failure at the very late stage of cardiovascular disease. Thank you. Thank you very much.
Thank you, Professor Wang. And from your lecture, we can learn clearly that the RNA is also effective and safe in the treatment of hypertensive patients beyond the heart failure, and especially you focus on the treatment of resistant hypertension and hypertension with CKD and LVH and other complications. So, because this is the sponsor of the symposium, we do not accept any questions. So if you have any question, please contact personally. And once again, I would like to thank for your wonderful lecture. Thank you.
Thank you.
Whatever you want, whatever it is. In Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
I see your minute, please?
I know it sounds silly, dear, but do it for me, please.
Good afternoon, everyone. It's time to open this session. Welcome, everyone. It's my great pleasure to start our session, Obesity and Blood Pressure from Mechanism to Management at Hypertension Seoul 2025. My name is Seung-yeon Go from Catholic University of Korea. I am honored to serve as the chair for this session together with Professor Sang-ho Jo from Hallym University. We have 4 distinguished speakers. I will introduce the first 2 speakers, and Professor Jo will then continue as chair for the remaining 2 presentations. After listening to the 4 consecutive talks, we will proceed with a panel discussion and Q&A with audiences. Our first speaker is Professor Jin-kyung Oh. She graduated from Chungnam National University, and she is affiliated with Cardiovascular Center, Chungnam National University, Sejong Hospital. She will present on understanding the adipose kidney-brain axis in obesity-related hypertension. Professor, please.
Yes, thank you for the kind of introduction. It's a great honor to be here, and I'm Jin-kyung Oh from Chungnam National University. Today, I'm going to talk about the fascinating concept in obesity research, the adipose kidney-brain axis. This axis plays key roles in obesity-related hypertension, so I will explain how this system works and why it is so important in understanding and treating hypertension in obese patients. Before we get to the main topics, let's first take a look what obesity actually means. Obesity is a medical condition where excess body fat has accumulated to a level that starts to harm health. But in daily clinical practice, it's not easy to measure body fat directly, so that's why we usually rely on the body mass index as a practical surrogate. And according to the WHO criteria, obesity defined as a BMI of 30 or higher, but in Asian populations, including here in Korea, the cutoff is lowered, 25 or higher. The prevalence of obesity has been steadily increasing worldwide. The obesity rate are rising globally regarding the country, and today almost 1 in every 2 adults is living with overweight or obesity. So managing obesity-related disease is now considered a world major global health issues. And in Korea, we are seeing the same upward trend in obesity as in many other countries. In these figures, about 40% adults now have a BMI over 25, and when we get men, nearly 50% are classified as obese, while for women, the rate is about 28%. So the gender gap is gradually widening, and class 2 and 3 obesity has increased the most. In particular, morbid obesity has tripled over the past decade. And here we can see how all-cause mortality risk rises with increasing BMI. When BMI above 25, the risk start to climb, and above 30, it increases steeply. And on the right, BMI is strongly related to all-cause mortality, with more than 2/3 of these deaths are due to cardiovascular disease. And obesity also linked to wide range of health problems. One of the major concern is metabolic syndromes. Beyond the cardiovascular systems, obesity also contribute to other conditions such as type 2 diabetes, sleep apnea, osteoarthritis, and even mental health issues like depressions and anxiety. So in many ways, obesity can be seen as a central driver of poor health outcomes affecting both physical and mental well-being. So obesity is furthermore one of the most important and modifiable risk factor for cardiovascular disease. It increases the risk of high blood pressure and dyslipidemia and heart failure. It can also drive endocellular dysfunctions and atherosclerosis. So among these complications, today I will focus on hypertension, which is the main topic of my talk. And now the key question is, how is obesity related to hypertension? We all know that not every person with obesity has high blood pressures, but weight gain shifts the blood pressure curve to the right. So this is why obesity is considered a major contributor to hypertension. And some epidemiologic studies shows that as BMI increases, the incidence of hypertension also goes up, and more specifically, increased visceral fat associated with development of new hypertension. And human as well, with body weight increases, arterial pressure rise, heart rate goes up, and increased cardiac output. And in the kidney, we see higher GFR, greater renal blood flow, and more sodium reabsorption. And both insulin and leptin levels rise, but insulin sensitivity declines. So taken together, these hemodynamic, renal, and metabolic changes explain why obesity can lead to hypertension. So the next question is, what mechanisms are driving this link? There are 3 major main pathways that are typically discussed. First, increased sympathetic nervous system activity, and second, the activation of renin, angiotensin, aldosterone system, and third, the effect of visceral fat physically compressing the kidney. So these 3 mechanisms are key contributors to obesity-related hypertension. And in a healthy state, the fat tissue release adipocytokines that help regulate immune response and maintain metabolic homeostasis. However, in obesity, the fat cell becomes hypertrophied and attracting macrophage, and then they start to releasing more pro-inflammatory cytokines like TNF-alpha and interleukin-6. At the same time, they produce fewer beneficial cytokines like adiponectin. So among these cytokines, one of the most interesting is leptin. Leptin tells the brain how much energy is stored in our fat tissue. So when fat storage increases, leptin levels go up and tell the brain to reduce food intake and burn more energy to increase the energy expenditures. But fat storage decreases, leptin's level fall, and brain get the opposite message, to eat more and conserve energy. So it's a good example of how the adipose and brain axis work together, and this feedback between fat and brain helps energy homeostasis and keeps our body weight stable. And leptin functions directly in brain, especially in the hypothalamus. So excess leptin overstimulate the POMC neuron, and then they turn on the MC4 receptor in both the hypothalamus and brain stems. And leptin also increase the sensitivity of chemoreceptors, which means this pathway can lead to sympathetic overactivations. So leptin is not just the metabolic signals, it becomes a trigger of neurogenic hypertensions. And from the brain perspective, overactivations of the sympathetic nerve system plays the most direct role in driving blood pressure higher. The main reason is leptin, we have already discussed, but that is not the whole story. Obesity also linked to hypoxemia, which increase the sensitivity of chemoreceptors, and obesity also associated with early baroreceptor dysfunctions. It makes easier for blood pressure stay high once it start to rise. So leptin is a key player in causing sympathetic overactivity, but we should also keep in mind the crucial role in these receptors. And now it is important to note that the blood pressure raising effect of sympathetic activations are mainly mediated through the renal nerves. In these animal studies, obese dog with hypertension shows that renal denervations dramatically reduce sodium retentions and almost normalize their blood pressures. This result clearly shows how important the kidney are in raising blood pressures in obesity. And similar findings have been observed in obese humans. In patients with resistant hypertension, renal denervation consistently lowered obese blood pressures by about 20 millimeter mercury in systolic and 10 millimeter mercury diastolic. And with this effect resting up to 2 years and demonstrate most of the blood pressure lowering effect comes from removing renal efferent fibers, which transmit signal from brain to the kidney and plays the dominant role in obesity-related hypertension. So another important mechanism is physical effect of visceral fat pressing on the kidney. As visceral fat accumulate, it starts to compress the kidney, and the body mistakenly interprets this reduced blood volume, even though nothing have actually changed. So kidney compression has multiple downstream effects that raise blood pressure. First, excess renal fat pressing on the roof of hennae and basa recta of renal medulla. And this pressure reduces tubular flow and increases sodium reabsorptions. As a result, less sodium reach the macula densa and activate the tubulo-glomerular feedback response. So this in turn increased renal blood flow, raise GFR, and stimulate renin secretions. So altogether, these changes activate the RAS system, leading to more sodium retentions and higher blood pressure. But not all fat is the same when it comes to hypertension. In the Dallas Heart studies, subcutaneous fat showed little or no relationship with developing high blood pressures, but visceral fat was strongly associated with hypertension and turned out to be strongest predictor of new onset hypertension. So beyond the hormone and neural factors, there are mechanical components contributing to obesity-related hypertension. And the last major mechanism is the activation of renin, angiotensin, aldosterone systems. Normally, these systems helps maintain volume balance, but in obesity, enlarged adipocyte, increasing angiotensin 2 level, stimulate aldosterone secretions, and then aldosterone enhances more water and sodium retentions, mainly through mineralocorticoid receptor activation. So this hormonal pathway add another important layer to how obesity contributes to hypertension. And MR activation play a major role in sustaining hypertension. Traditionally, we think of aldosterone as the main factor of MR, but it is not the only one. Cortisol can also activate MR, and even non-hormonal factors like oxidative stress and hyperglycemias stimulated through other pathways. And when MR overactivated, it induced both the functional and structural change across the multiple organs, including visceral fat, heart, blood vessel, and the kidney. So when MR becomes overactivated, it causes certain fluid retentions, worsening insulin resistance, and abnormal adipocyte differentiation. It also drives inflammations, promote fibrosis, and increase vascular stiffness, damaging both the kidney and the heart. And kidney injury progresses, this damage feedback into the system, further activating RAS system even more, and creating vicious cycle of obesity-related hypertension. So to break this cycle, we could consider using mineralocorticoid receptor antagonist. And in addition, progressive kidney injury makes blood pressure more source sensitive. Both experimental and clinical studies consistently shows that kidney dysfunction is a key driver of source-sensitive hypertension. Such dysfunctions increase sodium reabsorption, reduce GFR, and over time, this leads to nephron loss or injury. As a result, blood pressure becomes more source sensitive, meaning that even a small amount of sodium can push blood pressure higher and keep it elevated. So in addition, progressive kidney disease, this is so the managing both salt intake and body weight is such a key strategy in obesity-related hypertension because this is TON trial, the trial of non-pharmacology intervention in the elderly, and it enrolled nearly 900 older adults with hypertension and tested that lifestyle modification alone could maintain blood pressure control after stopping antihypertensive medication. So patients were assigned to sodium restriction and weight loss or both, and then followed to see whether hypertension is returning. The results were very clear, especially in obese patients. Both sodium reductions and weight loss substantially reduced the hypertension coming back. And when the two strategies were combined, the effect was even more powerful. There was more than 50% reductions in the risk of hypertension returning compared to usual care. So in the so this trial gives us strong evidence that in obese and salt-sensitive hypertension, combining sodium reduction and weight loss is one of the most powerful non-pharmacologic strategies we have. And they provide a stronger and more durable benefit for long-term blood pressure control. So this is my summary. Obesity-related hypertension developed through multiple and interconnected mechanisms. Two major pathways are sympathetic nervous system overactivity and kidney-mediated mechanisms driven through RAS system. And from the brain's perspective, excess leptin and chemoreceptor activations push the sympathetic nervous system to overdrive, and in the kidney, fat compression, RAS system activation, and MR overactivity promote more sodium retention, fibrosis, and vascular stiffness. So these pathways do not function independently. They crosstalk and reinforce one another. So the key message is obesity-related hypertension is not driven by a single pathway, but rather they are complex interplay between the brain, kidney, and adipose tissues. Thank you for attention.
Thank you very much, Professor Oh, for your excellent presentation. We will now move on to the next speaker. I would like to introduce Professor Wonjin Kim. She graduates from Wonju College of Medicine, Yonsei Hospital, and she is Associated Professor in Endocrinology at Cha Gangnam Medical Center in Cha University. Her topic, the title of her topic is Blood Pressure Effects of GLP-1 and GIP dual and triple agonist weight loss therapies. Professor Kim, please.
Thank you for the kind introduction, Chairman. Today, my talk is about the GLP-1 and GIP dual and triple agonists for the blood pressure effect. It is an honor to present this topic, the hot trend medication, here in Hypertension Seoul 2025. This is my contents of talk today. The first is the Professor O already talked about the pathophysiologic mechanism, but I will briefly just mention it. And the next one is the blood pressure effect of the GLP-1 receptor agonist and the clinical evidence of the medications and its clinical impacts and the future directions. This slide summarizes the key mechanisms linked obesity and hypertension. The visceral obesity increases leptin and activates the sympathetic nervous system, which in turn stimulates the RAS system. These neurohormonal changes lead to enhanced renal sodium reabsorption and impaired pressure natriuresis, resulting in blood pressure elevation. Over time, glomerular hyperfiltration and chronic kidney disease can develop, creating a vicious cycle that further maintains hypertension. In short, obesity-related hypertension is driven not only by increased blood volume, but also by complex interactions among the sympathetic, renal, and metabolic pathways. This one shows the relationship between the weight loss and blood pressure reduction from large-scale observational and meta-analysis. On the left, the Framingham study, Fragment's cohort showed that greater weight loss and was associated with a lower risk of developing hypertension, particularly when weight reduction was sustained over time. However, the overall magnitude of risk reduction was modest, especially in those who lost less than 6 kilograms. On the right, the meta-analysis of 35 studies demonstrated an average reduction of 5 to 6 millimeter mercury of systolic blood pressure with lifestyle-induced weight loss. These results confirmed that weight reduction can lower blood pressure, but the effect size is limited and often difficult to maintain in real-world settings. So this highlights an unmet need for more effective and durable intervention, such as medications, leading us to the role of pharmacology weight loss therapies. This one shows illustrates how the incretin system has evolved. Here you can see the classical incretin pathways. GLP-1 acts primarily through appetite control, suppression, and insulin secretion, but it also provides cardiovascular and renal protection through improved endothelial function and sodium excretion. GIP enhances insulin secretion and lipid metabolism, while glucagon increases energy expenditure and promotes hepatic fat utilization. Together, these pathways link metabolic and hemodynamic control. Actually, we begin with the GLP-1 receptor monoagonists, such as the liraglutide, semaglutide, and then we move to the dual agonists like tirzepatide, and another one is cagrilintide. Now we have some studies reported about the triple agonists, such as retatrutide, which will be the next generation medication, aiming for the integrated benefit across glucose, weight, and the blood pressure. Now, let us look at the blood pressure effect observed with the GLP-1 receptor agonist monotherapy. On the left, this figure shows the result from the liraglutide trial, and where the systolic blood pressure decreased about 3 millimeter mercury at 24 weeks compared with placebo. This reduction was consistent across doses and occurred early after treatment period initiation. On the right, we can see the pooled data from the STEP and SUSTAIN trial with semaglutide, which demonstrate a similar trend, systolic blood pressure reduction of 4 to 5 millimeter mercury, and a modest decrease in diastolic blood pressure as well. These effects were observed even in participants without hypertension, suggesting that the mechanism extends beyond simple weight loss. Next one is the dual GLP-1 and GIP agonist, the tirzepatide. This slide shows about the data from the SURMOUNT-1 trial. On the top left, you can see the time course of systolic blood pressure. There was an early and sustained decrease of 7 to 9 millimeter mercury of systolic blood pressure across all tirzepatide doses. This reduction appears as early as 4 weeks and was maintained throughout the 72-week treatment period. On the bottom left, the bar graph shows the shift in blood pressure categories. At baseline, the majority of participants were in the elevated or stage 1 hypertension range. After 72 weeks of tirzepatide, over half of participants reached the normal blood pressure category, while the proportion with stage 2 hypertension markedly declined. On the right, the subgroup analysis demonstrates that the blood pressure lowering effect was consistent across age, sex, and BMI, and it was actually greater among participants not taking the antihypertensive medications, suggesting a direct hemodynamic benefit beyond drug interactions. This meta-analysis summarizes the blood pressure effect of tirzepatide across multiple studies. As shown here, tirzepatide led to dose-dependent reduction in systolic blood pressure with an overall mean decrease of 5 millimeter mercury and up to 6 millimeter mercury at dose of 15 milligram. Overall, tirzepatide produced a clinically meaningful blood pressure reduction comparable to that seen with some first-line antihypertensive therapies, while simultaneously achieving substantial weight loss and glycemic improvement. These findings highlight the dual agonist potential as an integrated cardiometabolic therapy rather than merely a weight control agent. Here we see the blood pressure result from the CagriSema, which is not the GLP-1 and GIP dual agonist, but it is a dual agonist of GLP-1 and the amylin analog. This is CagriSema. In the phase 2 studies, the combination of cagrilintide and semaglutide led to a systolic blood pressure reduction of 6.5 millimeter mercury. And in the phase 3 studies, CagriSema showed 10 millimeter mercury SBP reduction, which was greater than either monotherapy. These findings suggest that the dual agonism not only enhances weight loss, but also contributes to additional hemodynamic benefit, likely through combining effects on appetite, natriuresis, and vascular tone. Now, let's move on to the data from the triple agonist, the retatrutide. On the left, you can see the weight loss trajectory from two phase 2 trials, one in obesity and another in type 2 diabetes. Retatrutide demonstrated remarkable weight reduction of up to 24 to 26% in individuals with obesity and around 17 to 18% in patients with type 2 diabetes, clearly exceeding the effects seen with semaglutide and tirzepatide. On the right, we see the corresponding blood pressure changes. There were dose-dependent reduction in systolic blood pressure up to about 11.8 millimeter mercury and up to 5 millimeter mercury in diastolic pressure at 12 milligram of retatrutide dose. These effects were consistent across both obesity and diabetes cohorts and occurred without any specific antihypertensive therapy adjustment, suggesting a direct mechanism-based hemodynamic effects. Importantly, similar lipid-lowering effects have also been observed in the semaglutide trial, the SURMOUNT and SURPASS programs, reinforcing that the blood pressure benefit is likely a class effect, maybe, of incretin-based multiple agonists rather than isolated observation. This slide summarizes the mechanistic insights for blood pressure and metabolic improvements seen with GLP-1, GIP, and glucagon triple agonist. On the left, both GLP-1 and GIP pathways promote vasodilation and natriuresis and anti-inflammatory effects, contributing to lower blood pressure. They also reduce appetite and improve endothelial function. On the right, the glucagon component increases energy expenditure and lipolysis, further enhancing weight loss and metabolic flexibility. Together, these complementary actions explains the robust weight and blood pressure reductions observed with those medications. From a clinical perspective, these findings suggest that incretin-based therapy can be integrated into hypertension management, providing dual benefit on body weight and blood pressure. In practice, this means we can potentially reduce antihypertensive burden in some patients as metabolic health improves. However, a few points should be considered: a mild increase of heart rate and the cost problem and accessibility of these agents and careful patient selection, especially in those who are already on multiple antihypertensive medications. Overall, these agents represent a shift from traditional BP-centric care toward comprehensive cardiometabolic management. Looking ahead, several large-scale CV and hypertension outcome trials are ongoing. The SUMMIT trial with the tirzepatide is evaluating cardiovascular and hemodynamic outcomes in participants with obesity and heart failure with preserved ejection fraction. And the remodel program for retatrutide will provide further insight into long-term cardiometabolic and blood pressure effects with triple agonism. And the EXCEED hypertension trial, dedicated trial in hypertensive obesity population, we are waiting for the result. And additionally, the SELECT extension trial will continue to explore cardiovascular outcomes in non-diabetic obesity populations. Despite these advances, several knowledge gaps are remained, like the need for dedicated long-term blood pressure studies using ambulatory monitoring and evaluation of renal hemodynamics and ambulatory trajectory, and assessment of autonomic and heart rate changes with chronic uses, and the integration with antihypertension de-escalation strategies. Ultimately, future evidence will determine whether these incretin-based therapies can be used not just as weight loss agents, but as part of the comprehensive long-term cardiometabolic management strategies. So in summary, incretin-based therapies, including GLP-1, dual, and now triple agonists, show modest but clinically meaningful reductions in blood pressure across multiple trials. These effects go beyond weight loss alone, reflecting underlying vascular, renal, autonomic mechanisms that contribute to improve hemodynamics. As a result, these agents deliver a clear dual benefit, lowering both body weight and blood pressure while improving overall cardiometabolic health. From a clinical standpoint, when combining these drugs with antihypertensive therapy, we should keep in mind potential heart rate increase, cost, and careful patient selection. Future studies are needed to define their long-term renal and hemodynamic effects and how they can be integrated into comprehensive management strategies. Thank you for your attention.
Thank you, Professor Kim, for your informative talk. Now I'd like to hand over the chair to Professor Sang-ho, and he will moderate the remaining two talks. Thank you.
Yes, thank you. Next speaker is Haekyung Kim, He is now serves as a professor of endocrinology in Severance Hospital in Yonsei University. And she graduated from Yonsei University Wonju College of Medicine and received his master and PhD degree. His talk will be regarding the remission of hypertension after bariatric surgery. Please.
Thank you for the introduction, Professor. First of all, it's a great honor and privilege to present in the in 2025 Hypertension Seoul about the obesity and the blood pressure, focusing on the long-term hypertension remission after metabolic bariatric surgery. Today, I will be presenting with the following order. First, we'll discuss about the obesity and hypertension in short session with the prevalence and why we have to intervene with the metabolic bariatric surgery. And then we'll go over the detailed mechanism of the mechanism surgery and mechanism of the obesity hypertension and the metabolic surgery can overcome this obesity hypertension and see about the discuss about the clinical outcomes of the short to long-term hypertension and predictors for the long-term remission of the hypertension. First, actually, the first professor explained you about the WHO definition of the obesity, and obesity is actually defined by the excessive fat accumulation impairing health, and diagnosed with a BMI over 30 and Asian Pacific rule by 25. And adult obesity has doubled, and adolescent obesity has quadrupled over 40 years, and this because of the energy flipping point in the 1970s, because of the energy-dense food and the sedentary lifestyle. And over the past years, USA has obese population over 50%, and actually Korea is catching up with the number with the obese population of 38%. And actually the morbid obesity, class 3 obesity, has actually tripled over past decade. So then why it is well known that the obesity shortens life expectancy. Actually prospective studies, the prospective studies collaboration showed all-cause mortality 30% higher for every 5 increment of BMI above 25. So comparing to non-obese people, people with a BMI over 25 has decreased life expectancy by 2 years, BMI over 30 by 4 years, and BMI over 40 by 10 years. Then now we ask ourselves with the question, what is the main cause of the mortality in obese people? Global burden of disease study has shown the cardiovascular disease are the most common for high obesity-related disease and mortality accounting for 30 and 40% respectively. Despite the pharmacological advances have demonstrated some efficacy in achieving sustained weight loss of 5% to 10%, which can help reduce cardiovascular risk factors. However, these treatments have some less effect in achieving weight loss over 10% and show diminished results in morbid obesity patients who are at high risk for cardiovascular disease. As a result, bariatric surgery, also known as a metabolic surgery, is recommended for obese individuals at high risk to meet the selection criteria. Since 2025, game-changing medications have, including the tirzepatide and the semaglutide, have become valuable in Korea, but patients using these highly effective weight loss medications still remain at risk of relapse, making them potential candidates for metabolic surgery. The guidelines recommend the weight loss and consideration of a metabolic surgery for hypertensive patients with obesity. However, clinicians find it challenging to refer patients for surgery without solid evidence of the long-term benefits of metabolic surgery, including hypertension remission. The key question now is whether metabolic surgery truly provides durable long-term remission of hypertension. Now let's go over to the mechanisms and clinical evidence of the long-term hypertension remission after metabolic surgery. The key to treating the obesity-related hypertension lies in the understanding heterogeneity of its mechanisms. Actually, the first professor explained with the detailed mechanisms. The obesity hypertension involves increased sympathetic activity, overactivation of the RAS system, and leading to sodium reabsorption and venous return and the cardiac output increment. So all these processes also result in expanded extra fluid volume, causing the peripheral edema. So based on the understanding of the heterogeneity of obesity-related hypertension, the ESCC guidelines now recommend using low to ultra doses of double or triple combination therapy, including RAS inhibitors and CCBs and diuretics. These approaches aim to effectively reducing blood pressure while minimizing side effects and treatment failure. So let's look over how does metabolic surgery can overcome the blood pressure reduction. First, the types of bariatric surgery is matters. The Roux-en-Y, gastric bypass. Gastric bypass is a superior weight loss in the long term and potentially leading to more significant blood pressure compared to the sleeve gastrectomy. And also these surgeries increase the GLP-1 and peptide YY, and the restoration of the ghrelin actually causes diuresis and the vasodilation, also lower the sympathetic nervous activation. And also remedying the obstructive sleep apnea can also lead to hypertension remission, also with the regulation of the adipokines restoration, leptin lowering, and the adipotectin increasing improvement of insulin sensitivity, and mitigating adipocyte inflammation, and lowering of the arterial stiffness. All this mechanism can caused by the bariatric surgery leading to hypertension remission. Based on the understanding of the heterogeneity, but the hypertension remission definition is a little bit tricky in this condition, because there is a lack of standardization in defining hypertension remission after bariatric surgery. But the consensus shows that the complete remission is BP lower than 130/80 without medication, according to the ACC and AHA stage 1 hypertension guidelines. There was one retrospective study comparing this AHA and the ESC guidelines for hypertension remission after metabolic surgery, showed that there was no significant difference in the improvement of remission or of hypertension between the two guidelines. Therefore, either guidelines could be used to define hypertension remission, but further studies are needed to reach consensus on this important issue. Now, let's look over to the clinical evidences of hypertension remission and metabolic surgery. The first one is the Gateway trial, the first and only RCT for the metabolic surgery on the hypertension, the gastric bypass to treat obese patients with a steady hypertension. It is conducted in a single center in Brazil with a patient number of 100, with the primary outcomes of the 30% of the total number of antihypertensive medications, while maintaining less than 140/90. So in the results, as you see, gastric bypass population have achieved 80% of the first primary goal, compared to the medical therapy only 12%. And these achievements maintained throughout the 1 year. And next, they follow up for the 5 years to see the hypertension remission, as you see. And almost 50% of the population in the gastric bypass have a hypertension remission, compared to only 2% in the medical therapy, and lower antihypertensive medication, and 0% in the resistant hypertension. And after 5 years, there was no significant difference in the adverse events, including anemia or cholecystectomy or mortality. Next one is the KOBES trial, the Korean Obesity Surgical Treatment Study, which was a prospective multicenter study conducted in Korea, including 328 patients. They followed for the 2 years, and as you see, the systolic and diastolic BP dropped down steadily and remained until 2 years, and the remission rate was 60% in this study. And next one is a STAMPEDE trial. Actually, what happens what type 2 diabetes patients receive this bariatric surgery? It was conducted in a single center Cleveland clinic, including 150 patients with the remission. Actually, they did not really not show the remission of hypertension, but the reduction of antihypertensive agents by 1 year and 5 years, which was 50%. So in this case, we now know that this hypertension remission by the metabolic surgery can occur in the type 2 diabetes patients. And next one is the Varieta trial, which they observed the ambulatory blood pressure. This study was conducted in a single center in Spain on 62 patients with central 24-hour systolic BP changes. They were literally they reduced over the past 1 year, and then actually they conducted multivariate studies after adjusting age and sex and hypertensive status and the body weight change, the systolic, central, and the peripheral blood pressure was actually significantly lowered since the 3 months of the after metabolic surgery. Not only the blood pressure, but the augmentation index and the cardiac output was reduced in these patients. And there were a large number of retrospective studies done in the U.S. With 32,000 people with the remedy of the hypertension and the remission of other comorbidities. As you see, the hypertension remission was with 40% with the prominent results in the younger and less number of baseline drugs or diuretics. And next one is the retrospective one-year follow-up with the patients in Korea with using the insurance review system, and consisting of 3,800 patients. The hypertension remission in Korea was 61%, and also the reduction of antihypertensive medications was also almost 70%. And what happens after 5 years? So there were 7 years follow and 10 years follow-up. The most famous study was a LABS 2 study, the longitudinal assessment of bariatric surgery 2, conducted in the U.S., which was a longitudinal observation study consisting of 2,000 patients. They observed for the medication changes and the remission of the disorders. As you see, Ru and Y had a hypertension remission rate of 41% and the gastric band with 33%. And there was a retrospective observation study with a larger number of patients in the U.S. and with the compared to the non-surgical controls. And as you see, the year goes by, the remission rates actually increased up to 60%, but there were relapses after 5 years. Almost 50% of patients have relapses. So these studies actually show that we should be vigilant about the after the surgery, the hypertension remission relapse can occur after 5 years. There was a little study on after 10 years of observation or prospective studies. There was one study in Poland with almost 10,000 patients, and this study shows that actually, even though we observed those with hypertension remission 50% above in less than 5 years, but this study shows only 10% after 10 years of a bariatric surgery of the hypertension remission, but the 30% reduction of estimated 10 years cardiovascular risks. Meta-analysis showed that hypertension remission was observed in the 38% in the surgical group, and also the systolic BP lowering effect of 15, and the diastolic 6, which is a little bit more than the GLP-1 receptor agonist and the dual agonist. But still, we have to predict whether the long-term remission of hypertension after metabolic surgery can which candidates could be the better for the metabolic surgery. The patient should be young in age and a shorter hypertension duration less than 10 years, since the remission rates actually decreased by 15% at each hypertension year, and also fewer hypertensive medication and baseline, and lower initial systolic BP, and sustained weight loss during the first year, at least 20% of total weight loss, and absence of diabetes or sleep apnea. So early surgical intervention is recommended in the certain candidates in hypertensive patients to maximize remission outcomes and reduce recurrence rate. So after the surgery, the post-surgery management of hypertension in bariatric patients required a tailored approach to antihypertensive medications. ARBs and AC inhibitors are the first-line options in patients with certain conditions because they mitigate metabolic and cardiovascular risks without inducing fluid or electrolyte imbalances. Beta blockers should be reduced or avoided unless as a significant weight loss often leads to improved resting heart rates, diminishing their necessity. And the calcium channel blockers also are suitable for blood pressure control if RAS inhibitors are insufficient. But care must be taken to monitor the peripheral edema, especially during fluid shifts post-surgery. And the diuretics, including Those should be used with caution due to risk of dehydration from the reduced gastric capacity with the tapering advice postoperatively. So up to 30 to 50% of patients can discontinue antihypertensive medication within 12 months of surgery. However, we should be observe the hypertension relapses after the 5 years of surgery, as I introduced with the studies before. So this is my last message for the lecture. Metabolic bariatric surgery offers a unique opportunity for long-term hypertension control and partial remission, up to 60% within a year, but can be decreased over the years. And we should be vigilant about the relapses because they can happen in the 50% within the 5 to 10 years. Therefore, long-term RCTs beyond 10 years and the studies to understand relapse mechanisms should be conducted. The need for standardized remission conducted, and also there is a need for standardized remission definitions. Best outcomes are in young, less severe hypertension without progression of obesity-related comorbidities. So we should not withhold the bariatric surgery over a year if the patient do not reach target weight loss, especially before reaching age of 50. And weight maintenance by all means, so whatever diet, exercise, and GLP-1 receptor agonist, maintain at least 20% of a total weight loss is important to prevent from cardiovascular diseases. In summary, long-term hypertension remission requires a multidisciplinary long-term follow-up with a clinician's vigilance. Thank you for your attention.
Thank you, Dr. Kim, for your good lecture. Next speaker is Min-gyu Kong. He serves as associate professor in Suncheonhyang University Bucheon Hospital. Interestingly, he worked as a KOICA International Cooperation Doctor in Mongolian National First Hospital. And also, he visited UCLA David Griffin School of Medicine for rehabilitation training. His talk will be implementing lifestyle and digital programs for weight control and BP improvement. Please.
Yeah, thank you for chairperson. Yeah. Can I add something? Steps. Can you check the screen, please? Yeah. My topic is implementing lifestyle and digital programs for weight control and BP improvement. My name is Min-gyu Kong from Suncheonhyang University Bucheon Hospital. Yeah. This is my introduction. Obesity and hypertension are closely linked. The prevalence of hypertension is nearly twice as high in individuals with obesity compared with those without obesity. This gap is even more pronounced in younger adults, showing that early prevention is critical. Yeah. Obesity continues to rise in Korea and globally, and addressing lifestyle factors remains fundamental to blood pressure control. Hypertension management cornerstone is the lifestyle modification. In 2024, ESC guidelines suggest that programs for potassium intake increasing and physical activity and weight reduction and reduction salt and alcohol intake reduction and smoking cessation leads BP reduction and can lead CV risk reduction. Actually, the topic is very wide and broad, so I will focus on lifestyle program, focus on diet and digital programs. Ketogenic diet and intermittent fasting, called 간헐적 단식, are gaining attention as recent trends. The first one is DASH diet. DASH diet is the actually textbook of diet for hypertension. It means the dietary approaches to stop hypertension. It emphasizes fruits and vegetables, whole grains, low-fat dairy, lean protein sources, nuts, reduced sodium, and avoiding sweat. It remains one of the most consistently effective dietary interventions for lowering blood pressure. The paper published on NEJM landmark trial showed that both sodium reduction and the DASH diet independently reduced the blood pressure, and the combination with salt reduction produced the greatest BP reduction. As you can see the right result figure, the effect of DASH diet and sodium reduction on systolic blood pressure and diastolic blood pressure was significant even over a short intervention period. This meta-analysis of randomized trials confirms that DASH constantly lowers blood pressure across population regardless of presence of hypertension, antihypertensive medication use, or baseline blood pressure. In subgroup analysis, importantly, individuals with higher sodium intake and younger age showed even greater BP reduction. This highlights the importance of early lifestyle intervention. Recently, the ketogenic diet has gained popularity. It is a very low carbohydrate, high fat diet designed to induce ketosis, shifting metabolism from glucose to fat utilization. However, clinical studies have not demonstrated clear blood pressure lowering effects. In this meta-analysis of RCTs of ketogenic diet, as you can see the right figure, it shows no significant effect on systolic blood pressure. Another recent study of ketogenic diet efficacy analyzed the hypertension risk according to dietary ketogenic ratio. The dietary ketogenic ratio reflects the likelihood of inducing ketosis. Higher ratios reflect the stricter ketogenic dietary patterns. Interestingly, in this study, United States population data suggests that a higher DKR may be associated with increased hypertension risk in middle-age group and elderly group. In those trials, why might ketogenic diet fail to reduce blood pressure or even increase it? Possible mechanisms include electrolyte imbalance leading to sodium retention, reduced nitric oxide due to impaired endothelial nitric oxide synthase function, inflammation induced by high fat intake, and overall poor long-term adherence. These factors may counteract potential metabolic benefits. This is another new dietary trend, time-restricted eating, called 간헐적 단식, intermittent fasting. Right clock figure is in time-restricted eating pattern is eating window usually intervene 8 hours, for example, 8 a.m. to 4 p.m., and has gained global attention as a simple and practical dietary approach. It focuses on limiting eating windows to improve metabolic health. So time-restricted eating pattern can lead energy intake reduction and also reduction in body weight and reduction in body fat and abdominal obesity and reduction in fasting glucose and then lipid profile and also blood pressure. Recent high-quality trials published in New England Journal of Medicine and JAMA Internal Medicine have shown mixed results. The trial published on New England Journal of Medicine showed insignificant weight reduction effect of time-restricted eating intervention. However, right figure, another trial of early time-restricted eating demonstrated significant reduction weight loss. Actually, between two studies, there is a big difference of eating window hours gap. This small-sized, short-term controlled study shows some metabolic benefits, including systolic and diastolic blood pressure, significant reduction over 12 weeks. A more recent meta-analysis indicates the time-restricted eating can significantly reduce systolic blood pressure and body weight and glucose level. While not as consistent as DASH, time-restricted eating may be an effective alternative for some patients. Now let's move to digital health interventions, which are increasingly used for lifestyle modification and blood pressure control. These include mobile apps, wearable devices, reminders, and digital coaching systems. If you search for blood pressure on the Google Play Store or App Store, you will find a huge number of apps for hypertension or blood pressure measurement. Digital programs can support behavior change, track measurement, and provide personalized feedback. This study compared a mobile coaching app to a simple BP tracking app in 333 patients with uncontrolled hypertension over 6 months. The digital coaching arm showed actually numerically greater reduction in blood pressure in consistent result in subgroup analysis. However, it does not show statistical significances. In another random control trial of 390 untreated hypertensive patients, app-based lifestyle modification with interactions between patients and doctors significantly improved systolic blood pressure compared to standard care over 12 weeks in Japanese trial. In 24-hour systolic blood pressure by ambulatory BP monitoring, the difference was 2.4 millimmercury between two groups, and all of other parameters also reduced much larger reduction in intervention group compared to control group. Digital intervention can be particularly effective for early hypertension, we can think. This study further reinforces the potential of digital therapeutics in real-world blood pressure management, especially when combined with lifestyle advice and frequent feedback. Digital programs based on apps can provide various supported lifestyle interventions, including body weight control, salt intake, healthy diet, exercise, and etc. Active bidirectional interaction between patients and doctors can share the goal of target blood pressure and lifestyle improvement. It can lead better control of blood pressure and better patients' clinical outcomes. However, digital programs also have limitations. First, engagement declines sharply after several months in previous trials. Second, digital divide affects older adults and those with low digital literacy. Third, data accuracy remains an issue. Many wearable and smartphone-based blood pressure measurements are not validated. Fourth, many applications are not integrated with EMR systems, which limits clinical usefulness. Fifth, regulatory classification and reimbursement remain unclear in many countries, including Korea also. Finally, random control trial efficacy does not always translate into real-world effectiveness, especially in diverse patient groups. This is my summary. Lifestyle modification remains fundamental for weight and blood pressure management. Among dietary patterns, the DASH diet has the strongest evidence. Time-restricted eating pattern may be beneficial, but ketogenic diets require caution in management of hypertension. Digital programs are promising, but still face engagement, equity, and integration challenges. A combined lifestyle and digital approach may offer the most balanced and scalable solution. Thank you for your attention.
Thank you, Dr. Gong. Now we have 4 discussants. Dr. Kim Kyung-an from Catholic University, and Dr. Kim Hae-jin from Aju University, and Dr. Seom-ye from Soonchunhyang University. We have little time, about 7 minutes. So, any question or comment, Dr. Seom?
Yeah, thank you for your prominent first speakers, and thank you for learning a lot about obesity and hypertension. I have one question about Professor Jin Kyung-oh. You extensively explained that obesity-related hypertension is related in adipose tissue and kidney, including the renin-angiotensin system, and brain, including leptin, also the brain inflammation. I have a question about the real clinical practice. Which antihypertensive medication do you choose if you are the obese patient with the body mass index in greater than equal to 27 as high and the real outpatient doctor? Is it different any antihypertensive medication according to the BMI?
Thank you for the good questions. Actually, not our patient with obesity developed hypertension. I think it really depends on obesity extensions and patient's metabolic profile. So most importantly, visceral fat is a central role in obesity-related hypertension. So because it activates both the RAS and sympathetic nerve system and sodium retention pathway. So in medication, regarding the pharmacology therapy, most guidelines recommend RAS blockade and calcium channel blocker as first-line agent because it reduces both the sympathetic tone and salt retentions. So particularly in obese patient with elderly patient, they showed greater salt sensitivity. I think thiazide-like diuretics or calcium channel blockers more effective to control blood pressures because they have more salt sensitive, but when patient with insulin resistance at modest weight gain, I think RAS blockade and calcium channel are more effective to them because RAS blockade improve insulin sensitivity and protect renal protections, I think.
Professor Hae-kyung Kim. Yeah, thank you for the excellent presentation. So I would like to ask the differences between, according to the type of the bariatric surgeries. So is the neurohormonal mechanisms of the blood pressure reduction different according to the type of metabolic bariatric surgery? And is the mechanism of hypertension relapse after remission different depending on the type of metabolic bariatric surgery?
Thank you for very important questions. And first of all, the type of bariatric surgeries and the measurement of the GLP-1 and the other GI hormones actually were not really studies were a little bit lacking in those areas, but still the Roux-en-Y bypass is more superior with the weight loss and compared to the sleeve gastrectomy. The sleeve gastrectomy is actually most popular surgical procedures throughout the world, even though the Roux-en-Y gastric bypass has a superior outcomes in the cardiovasculars and the hypertension remission and other related comorbidities. But depending on the types of surgery and the neuronal hormones should be a little bit more studied in the further researches. But probably with the advances, more superiority of the weight loss in the Roux-en-Y gastric bypass, and probably they have more restoration of the incretin hormones compared to other, perhaps other procedures. Thank you.
Dr. Kim? Dr. Kim Hye-kyung? Do you have any data regarding the comparison between this bariatric surgery versus nowadays anti-obesity drugs head-to-head? I admit that the cost effectiveness is superior to bariatric surgery and the sustainability is superior, but any data regarding the actual BP reduction, weight reduction and blood pressure reduction and CVD outcome?
Yes, that is another very important and actually what we are looking for in the future studies, because there is only like a legitimate RCT for the medical surgery versus a bariatric surgery with a gateway trial, but recent advances in the dual and the triple agonist of the GLP-1s have advantages over weight loss 25%, almost 30% in some cases. But of course, the metabolic surgeries have those weight loss advantages, but there is a lack of comparing these two procedures and these two medication and procedures in the prospective manner. But probably the surgeons expect more. Actually, the synergistic effects of the GLP-1 receptor agonist use in the bariatrics, the patients who receive the bariatric surgery. So not only the comparing the surgical outcomes and comparing to the medical, but the add-on effect of the GLP-1 agonist on the patients who underwent the surgical surgeries could have more synergistic effects and the maintenance of the weight loss. That is more a key issue that the surgeons actually are concerned about. So probably next in the future studies, we should have prospective studies comparing this medical and surgical in the advance, but probably have more researches on that should be validated in the near future. Thank you.
So you are in favor of bariatric surgery, especially in the very high BMI patient. I mean that we cardiologists and other doctors also think that the role of surgery is limited and because of triple agonist.
Yes.
I think.
That is very really like a big hurdle for patient and also for clinicians, because the surgery, the patients actually have like resistance also for the medications. Then how long can we maintain the medications to achieve those weight goal? Actually, in the endocrinology perspective, we actually ask patients to maintain the medication at least a year to get to the goal achievement. And also after that, what happens? Even though they did not, if those patients after a year did not reach any weight management or have more severe hypertension or cardiovascular disease, then we have to consider about the metabolic surgeries. That's why we have to choose the appropriate candidates. And from my perspective as an endocrinologist, perhaps we could try with the medication first, and then maybe consider about the metabolic surgery after that, after they did not get to, they failed to achieve those goals.
Thank you. Any comment?
Thank you for the very informative lectures. Actually, I was going to ask a question similar to what Chairman Joe asked, but since it's already answered, I would like to ask a question to Professor Wonjin Kim. It's a very basic question, but I do not have much experience with GLP-1 receptor agonists. So previous data shows that there is weight loss with, blood pressure decrease with weight loss. And the GLP-1 receptors, while they showed blood pressure decreases, they also had weight loss. So what is the evidence behind the proposed independent action of GLP-1 receptor agonists on blood pressure independent of weight loss? Is there data regarding that?
Actually, you mean the mechanism of the blood pressure reduction with the GLP-1 receptor agonist, right?
Yes.
Actually, I already mentioned about the mechanism, and it is not that clear yet, but the action of controlling the cardiovascular system and the renal system will be one mechanism of the blood pressure reduction. And mainly, actually, the weight loss will be the most powerful thing that reduces the blood pressure and the glucose or other metabolic factors. So I think the main mechanism is, first one is the controlling the appetite and the weight loss, and then the secondarily the control the cardiovascular system and the renal system will be the mechanism of that one.
So is there some data regarding intermediaries such as angiotensin or aldosterone levels in patients receiving GLP-1 receptor agonists?
As my knowledge, I have no idea of that, but I will search more about that.
Okay,
Thank you.
Yes, Dr. Kim.
Dr. Won-Jin Kim, can I ask one more question? Thank you for your very nice lecture. So, as one of doctor to manage hypertension, the GLP-1 agonist actually is not medication for hypertension, but it's BP lowering effect. Very interesting for using. I want to use for that in hypertension field. I want to ask one question is there any other direct evidence to reduce the target organ damage by using GLP-1 agonist especially in cardiovascular system?
Direct mechanism or studies are not known, but some GLP-1 monoagonists like semaglutide have the CV outcome trial, but others are still on their programs to prove the cardiovascular outcomes. So they actually discuss about that. The mechanism will be the one things that I already mentioned about that. So they are presuming that the mechanism will be the GLP-1's receptors have the many organs have the receptors of the GLP-1, so that it can happen to all the organs, so we can make the cardiovascular protection and other cardiometabolic health improvement. Maybe.
So of course, we also know that this agent is already using the congestive heart failure, and officially we can describe for the patient right now. Is there any other chance to increase the usage in a cardiovascular patient in later?
I think when I preparing this lecture, that I was a little bit surprised about the blood pressure lowering effect of the GLP-1 and other dual and triple agonists. So actually the medication of antihypertensive things happen from the lowering the blood pressure from 5 to maximally a 20, or if you combine those medications together, it may lower the blood pressure up to 20 or more. But the medications they introduced today, the retatrutide or the others, may decrease the blood pressure more like that. So I think someday, maybe in the future, we can use the GLP-1 and the combinations. Maybe we can use it as a antihypertensive medication, but still the problem is the cost and this is the injection type. So if that problem will be solved, maybe we can use it as usual for the antihypertensive medication. Thank you.
I remember some data regarding the LVH, left ventricular mass reduction with the GLP-1 receptor agonist, and some other animal data also show the favoring direct effect to target organ with the GLP agonist. Any comment or question from audience and panel? Okay, I think that wonderful lectures and wonderful discussions, and I've learned much also. Thank you for your attention. I close this section.
Whatever you want, whatever it is. In Seoul, everything. Absolutely.
임신 중 올바른 혈압 관리가 산모와 태아에게 얼마나 중요한지 아시나요? 혈압이 비정상적으로 높아지는 고혈압은 단백뇨 부종 등의 증상이 동반되며 산모에게 있어 조산 및 저체중아 출산까지 이어질 수 있습니다. 그래서 평소에 산모의 꾸준한 혈압 관리가 필요한데요. 체계적인 맨몸 운동은 혈압을 조절하는 데 큰 도움이 됩니다. 가벼운 산책이나 임산부 요가 같은 과하지 않은 운동은 혈액순환을 촉진하여 혈압을 낮추는 데 기여합니다. 음식 섭취 시에는 혈압을 높이고 체내 수분을 잡아두는 나트륨의 섭취를 줄여야 하고 시금치, 바나나와 같은 체내의 나트륨 배출을 도와주는 고칼륨 식이섬유를 섭취해야 하며 스트레스는 감정 기복이 심해지는 임신 기간에 쉽게 쌓일 수 있는데 그로 인해 혈압 또한 오르기 쉽기 때문에 명상이나 심호흡을 통해 심리적 안정을 유지해야 합니다. 규칙적인 혈압 체크와 함께 올바른 혈압 관리 실천으로 나와 아기의 건강한 미래를 준비하세요.
나는 아직 세상을 모르지만 엄마의 소리를 들으며 하루를 시작해요. 오늘 엄마의 소리는 일정했어요. 나도 편안하고 따뜻해요. 엄마 혈압 건강하대요. 그 말 듣고 기분이 좋았어요. 어제는 소리가 평소 같지 않았어요. 조금 다르게 들렸어요. 그래도 다행이에요. 엄마가 그냥 넘기지 않고 혈압을 확인해줬어요. 엄마의 하루는 나에게 기록이 돼요. 소리만으로도 알 수 있어요. 나는 그 하루들 위해서 자라요. 엄마가 건강해야 나도 건강해요. 엄마, 우리 매일매일 혈압 확인해봐요.
임신 중 건강관리 어디서부터 시작해야 할까요? 그 첫걸음은 바로 혈압관리입니다. 산모의 몸도 아기의 몸도 함께 지켜주는 소중한 혈압, 우리 함께 지켜봐요. 임신 중 혈압, 왜 중요할까요? 혈압이 잘 조절되지 않으면 산모의 건강은 물론 태아의 성장에도 영향을 줄 수 있어요. 그래서 산모는 혈압을 꾸준히 체크하고 관리하는 것이 꼭 필요합니다. 정확한 혈압 측정을 위해서는 몇 가지 준비가 필요해요. 우선 조용하고 편안한 장소에서 화장실을 다녀온 뒤 운동하지 않은 상태에서 측정해주세요. 팔에는 심장 높이에 맞춰 커프를 감고 혈압이 측정될 때까지 말하거나 움직이지 않아야 합니다. 정기적인 체크만으로도 위험을 예방하고 아기의 건강한 성장과 나의 안정적인 출산을 도울 수 있어요. 임신 중 혈압 관리, 두 생명을 지키는 첫걸음입니다.
Okay, welcome to the cutting edge hypertension research session. My name is Seonghwa Park from Yonsei University. My co-chair will be Professor Andrzej Janusewicz from Poland. My co-chair will introduce the first two speakers, and then I will introduce the next two speakers. So, Professor Janusewicz.
Okay. Thank you very much. And good afternoon, and it is a great honor to chair the session together with you. And I would like to announce the first speaker, which is Professor Wang from China. Does the timing of blood pressure medication really matter? The floor is yours.
Okay, thank you, Mr. Chairman. It's a pleasure for me to give a presentation on the timing of blood pressure medication. It is not really an issue, certainly not a big issue, but many people were forced to involve in the discussion of this problem. I don't say it's an issue, it's not even a topic. But I was invited to write a commentary and published in the International Journal of Cardiology, Cardiovascular Risk and Prevention by Daniel Levy after the London European Society of Cardiology meeting. And so I would just present to you the guideline recommendations on this timing of antihypertensive drug intake, and then go over the recent trials on this question. So let's first look at the Chinese guidelines. It's very clear our new updated guidelines, Chinese Hypertension League 2024, clearly recommend to take the antihypertensive drugs in the morning. And very recently published American guidelines again, and they recommend morning dosing and once daily. So the two levels of recommendations. The first recommend you only take the drug once daily, so it improves adherence, and you take the drug preferably in the morning. So very simple but very clear recommendations. Again, if we look at European Society of Cardiology 2024 guidelines, very similar recommendations with a little bit different different words. So you should take medication at the most convenient time of day. Of course, for most of people, you should take the drug in the morning because it's the most convenient time of day for many or most people. And ISH was very concerned with this issue or question, and they published this consensus document a couple of years ago. Again, the recommendation is very clear. You should take long-acting antihypertensive drugs once in the morning. So here they added another wording like long-acting drugs. So of course, if you take the drug once only or once daily, then you need to take long-acting drugs. Actually, in China, we promoted the transition from short-acting or intermediate-acting drugs to long-acting drugs about 20 years ago when I returned from Europe to China, because in those years, many hypertensive patients still took short-acting or intermediate-acting antihypertensive drugs. Over the years, most of hypertensive patients in China, they take long-acting drugs, usually only once, but still, many physicians recommend the use of drugs at multiple times of day, and sometimes even for those long-acting drugs. So that's something we still have to overcome in the next years. But apparently, the international consensus is very clear. You should take long-acting drugs once in the morning. And in the past years, actually, we also published several China or Asian consensus on here nocturnal hypertension, but actually a few years ago also on morning blood pressure or morning hypertension. We always recommend to take the drugs in the morning with long-acting agents. You only need to take the drug once daily. So in this document, even in those patients with nocturnal hypertension, we did not really recommend use of the drugs at bedtime. We still recommend taking long-acting antihypertensive drugs in the morning, not really necessary in the evening. So the major problem for taking the drug at bedtime or at the other evening hours is low adherence. If you try to do it, but you always fail to take the drug eventually. So even in this nocturnal hypertension management consensus document, we still recommend to use the drugs in the morning once daily instead of taking the drug in the evening or at bedtime. So why it happened? Why this became an issue? Mainly because of this HYJA chronotherapy trial. It was a trial, but nobody knows what really happened with the trial. And it was a huge study with a very important and very difficult task. For instance, the used ambient blood pressure monitoring to follow the treatment effect. You see 48-hour ambient blood pressure monitoring was performed at entry, and each, if possible, follow-up clinic visit at least once a year. It must be very difficult to achieve this measurement because 48-hour is very difficult, and if you want to do repeated ambient blood pressure monitoring, it is extremely difficult. But you see, if you look at the results, it was quite astonishing, and you will see a very significant difference between taking the drug in the morning and the evening. Evening dosing produced a huge benefit. And then if you look at the blood pressure difference, it was actually quite small. There was only a very small difference in nighttime or asleep systolic blood pressure. To be precise, it was only 3.3 millimeters of mercury systolic blood pressure, all at the low level. So we define nocturnal hypertension as 120 millimeters of mercury or higher. Here, whenever you have the level below, it means many or most of those patients had controlled nighttime hypertension in both groups, either weekend or bedtime taking, bedtime dosing. So it means that if any clinical outcome benefit, not really from blood pressure difference, because there was only a very small blood pressure difference that could not explain the observed difference between the two different dosing strategies. That's one of the reasons why this time trial was conducted in the UK in a decentralized design. A decentralized trial actually was quite cost saving, so you don't need to pay too much to the study sites or the study investigators. The coordinated center worked together with the patients directly with the digital technology. Here, they again also did a very big study, even bigger than the HYDRA trial in the UK. More than 20,000 patients randomized into 2 different dosing strategies, either all drugs in the morning or all drugs in the evening. And they didn't see any significant difference. So to be exactly describing, there was only a 5% difference, statistically non-significant. So if you look at the curve, and the 2 curves crossed each other over this long period of time. And they also measured blood pressure at home in a subgroup of patients. So it means it collected also blood pressure measurement data in a subgroup of patients. On the left hand, you see morning blood pressure. They say at home self blood pressure measurement in the morning. On the right hand, you see blood pressure measured in the evening. If you measure blood pressure in the morning, and morning dosing actually had slightly higher blood pressure, and then if you measure in the evening, morning dosing actually produced a greater blood pressure reductions. So on average, if you average morning and evening blood pressure, you would see more or less the same blood pressure level in the 2 dosing strategy groups. So the time trial results were in a very sharp contrast with the findings of the HYDRA chronotherapy trial. That's why another or the 3rd trial was conducted in Canada. Again, it's bedtime versus morning dosing with regard to clinical outcome results. So here you see the primary outcome results over a long period of follow-up. So the hazard ratio was more or less the same as in the time trial, 0.96. So it's about the same, 0.95. So these 2 trials actually produced a very similar, or you may also say exactly the same results in the comparison between morning and evening dosing. So if there is anything, it must be very small, marginal, or only in a small group of patients that typically require bedtime dosing for the control of hypertension in a certain period of time in the evening or in the very early morning, as we have seen from the time subgroup analysis on home blood pressure levels. So they also did a subgroup analysis in so many subgroups according to baseline characteristics, gender, age, frailty, and many others. They didn't see much significant difference between these various subgroups. If anything, and they saw some borderline significant p-values, 0.05 for diabetes. So in those patients with diabetes, it seems there are some outcome benefits, but statistically, again, not significant because of small number of patients and events. So they also did secondary endpoints analysis. You see there is no difference whatsoever between the 2 dosing strategies with regard to various cardiovascular endpoints. And in this trial, they also did a frail trial, so even in those patients with frailty and old, then you did not see any significant difference between the two groups. Of course, the sample size was small and without sufficient power. And Spanish registry produced very similar results, even though it was observational, but they did not observe any difference. In a recent meta-analysis actually conducted from a group in Korea here, and they showed some differences in blood pressure, in fact, but and they found that many of those trials had a low or very low strengths. They didn't use the word of quality, but they used the word strength. Nevertheless, and this meta-analysis suggested that probably some trials of low strength or quality produced such results that favored the benefit of nighttime dosing. So it is very clear if you look at the guideline recommendations, all the results of trials in broad sense, then you don't have to take the drug at bedtime or in the evening. You should choose the very convenient time to take the drug and to have higher medication adherence. Thank you. Thank you very much.
Professor Wang, thank you very much for your excellent talk and for covering such an important topic. The discussion will be at the end of our session. Thank you very much again. And now I would like to ask Professor Cesar Romero from Atlanta, United States. And Cesar will be very grateful to cover the topic, the kidney's bidirectional role in hypertension and the cardiorenal metabolic syndrome. Cesar, the floor is yours.
Thank you, Mr. Chairman. Thank you to the Korean Society of Hypertension for the opportunity to present here and have this wonderful moment this couple of days. So my talk will be more focusing on kidney today and try to understand how the kidney modulate all the cardiovascular risk. We want to try to see how the kidney induces cardiovascular disease, how the cardiovascular risk factor ignite a vicious cycle, the damage with the kidney, and how we can address this issue to try to prevent the burden of cardiovascular disease. I have no conflict to declare. And basically to start, I want to let you know or emphasize that renal disease drives cardiovascular mortality. You can see in this graph a young adult with cardiovascular disease has like a 1,000 times more risk than people without cardiovascular disease. And this risk is equivalent to a CKD patient with 80 years old. So you can see the magnitude of the CKD on cardiovascular disease. And you can see in this one, as low as you are going with your GFR, your cardiovascular risk increase. So we want to try to understand what happened. Children are good to understand because they are so pure without not many contribution. But you can see here that in the comparison in children with or without CKD, you can see the high prevalence of cardiovascular risk factor. That's 20% of hypertension, 32% of obesity, 62% of hypercholesterolemia. So kidney is involved not only in hypertension, but also in other cardiovascular risk factors. And you can see, you know this, the interaction between the kidney and the heart through the cardiorenal syndrome, type 1 and 2, and 3 and 4, and also how the classical risk factor affect the kidney and affect the heart. But I will show you that also the kidney can induce all these risk factors. For instance, we can initiate a vicious circle of progression of chronic kidney disease and progression of cardiovascular disease. And this is very well exampled in the new proposes cardiovascular renal metabolic syndrome for the American heart, when you can see here that the kidney is a key component of the stage 2 of this syndrome, but also having non-metabolic etiology of CKD equivalent to enter to this stage. And even more, when you have an advanced CKD, you automatically are inside of stage 3, meaning that the kidney by itself is driving cardiovascular disease. The mechanisms here are complex, but you can see sympathetic overactivity, activation-like program that can lead to water conservation, metabolism deregulation, muscle catabolism. All these things can induce the activation of the cardiovascular risk factor. And peptidase deregulation, we all know that people with CKD have a high activity of the renal angiotensin system. Another peptidase system, as I will show you now here. We described a couple of years ago a total new antifibrotic peptidase system in the kidney, which also integrate the angiotensin converting enzyme. And this peptide is a tetrapeptide, 4-peptide, ACE-DKP. It's a potent anti-inflammatory, antifibrotic, and antiproliferative peptide. And as you can see here, is produced in the distal nephron, and you can inhibit with some inhibitor, but more important, if you use ACE inhibitor, we can increase the level in the kidney. And as you can see here, when we inhibit this peptidergic system in the kidney fibrosis increases dramatically in the kidney, and with the use of the external infusion of the peptide, we prevent this problem. And even more, this peptidergic system have impact systemically. We can see here in another work we did in animals, myocardial infarction, the presence of this system decreased cardiac rupture, mortality, and you can see how the kidney is interacting with the heart. In here, we demonstrate that the obesity increases inflammation in the kidney, and the salt double or triple the inflammation in the kidney, and this peptidergic system can decrease that inflammation. And finally here, in this last step, more translational, in African American people in Detroit, when we were working, we measure the level of ACE-DKP in patients using ACE inhibitor, and we found that this peptide was increased, and several markers of anti-inflammatory disease were also increased. So you can see how the kidney can modulate and induce all the cardiovascular risk factor. And better is know that this risk factor can also affect the kidney. And let me show you some example of this. This progression of cardiovascular disease is mainly produced by three mechanisms: hyperfiltration, inflammation, and renal fibrosis. Everything that induces this will induce acceleration of CKD. And why is that? Because when we have this mechanism, we're going to have nephron loss, and then the remaining nephron, we have a compensatory single nephron hyperfiltration, and that leads to barotrauma, which eventually will generate new nephron loss, and we are in a circle. So here I can show you obesity, how in this rat we have a glomerular matrix expansion because the hyperfiltration, you can see here, is significantly in comparison with the limb. The salt increase more the hyperfiltration. And again, we were able to decrease that with our peptidergic system. And when we do microperfusion and micropuncture study in rats, you can see the basal glomerular pressure in the limb was around 10 millimeters of mercury less than the obese rat, meaning that these rats have high glomerular filtration, they are hyperfiltrating, and that induces glomerular damage. In hypertension, you already know this, induced renal damage. You can see here in mice that we infuse with angiotensin II, we can provoke hyperfiltration and albuminuria. But what I want to show you here, when we knock out this peptidergic system, we dramatically increase the proteinuria, meaning there is not only the blood pressure, but also all the system inside the kidney that are preventing, in this case, hyperfiltration, but also inflammation, as you can see here, measured macrophage inside the kidney. Another not very well-studied topic is hyperuricemia, where we know it's the kidney can be a cause of hyperuricemia, but also hyperuricemia can induce damage in the kidney. And in this paper, what we check is the activation of the innate immunity by hyperuricemia, you can see the inflammasome was activated, that was preventing when we use halopurinol, and we found that that increased renal fibrosis in animal. All these cardiovascular risk factors are inducing and perpetuating the CKD and the damage. So how we can tackle this? Sorry. How we can tackle this? Basically, we need to think in tackling the hyperfiltration, inflammation, and renal fibrosis. Doing that, we will be able to, sorry, it should be, tackling that, should be able to block this vicious circle. And right now, the new evidence, it's allowing us to do that by 3 pillars. One is the ACE, or the RAS inhibitors used that we have been using for the last 30 years with very lot of evidence. Now the new drug, the SGLT2 inhibitor, and finally we started to have more evidence that anti-aldosterone drugs also can have an independent effect on CKD progression. So these 3 drugs will act in the same mechanism but in different parts: hyperfiltration, inflammation, and renal fibrosis. And you can see, you already know, ACE inhibitor decrease hyperfiltration by decreasing the efferent arterial tone, and that decreases the intraglomerular pressure. But also it had independent effect, and I put this paper because this is independent of blood pressure, on inflammation in the kidney. You can see here when you use an ACE inhibitor, and also when we use our ACE-DKP peptide, we can decrease the inflammation and fibrosis. And this is independent of blood pressure. So ACE inhibitors are acting in decreasing hyperfiltration, inflammation, and fibrosis. Dapagliflozin, as a standard of SGLT2 inhibitor, also have wonderful effect on this. And you can see how the use of dapagliflozin in the DAPA-CKD trial decreased the rate of progression of CKD. And as you can see here, there is a quick or abrupt decrease in GFR at the very beginning, and this is mainly driven by the hemodynamics changes induced for this drug, which are decreasing the hyperfiltration. And that also is expressed in the presence of decrease of albuminuria, as you can see here, in patients with diabetes or without diabetes. Something. How should we take this out? Perfect. So here, this is a complex explanation from Walker Vannon in California. But basically, I want to show you here that SGLT2 inhibitor can be tackling all these things. As you can see, decreased inflammation, albuminuria, glomerular pressure, GFR, and also have an uricosuric effect. For that reason, and for many others, these drugs have been or start to be a gold standard in treatment of CKD patients. And finally, we have evidence of finerenone with the Fidelio study decrease the progression of CKD. You can see here a composite outcome of mortality associated to renal cause and also progression of CKD was almost 20% decrease with finerenone, and also the GFR increase was less with this. And the same effect was found with the urinary albumin to creatinine ratio. You can see here the effect. And obviously, this can be driven by a blood pressure effect, but also from some independent blood pressure effect, as I will show you here. This is a work that we did many years ago using microperfusion, and we were trying to see how much afferent arterial dilation we can get with aldosterone, and we can prevent this. And you can see when we infuse the animal with aldosterone, we were able to increase the vasodilation of the afferent arteriole. And this is an in vitro process, so it's independent of systemic blood pressure. And when we block with eplerenone, in this case, we were able to reduce the afferent arterial dilation. And here there are more data coming. This is also for animal study that finerenone also decreased clinical fibrosis, glomerular injury. So overall, these drugs are acting in these 3 mechanisms I show you in different stages, so we can prevent the CKD progression. So in summary, hopefully you can bring home this concept of the kidney acting in a bilateral way, just inducing this risk factor, but this risk factor also inducing more CKD progression, and this is involved with the cardiovascular disease progression, and we can tackle this just using the novel tool that we have, which is the use of ACE inhibitor, SGLT2, and anti-aldosterone. So with this, let me take my conclusion. It's important to screen and treat the CKD to decrease cardiovascular burden. In addition to lifestyle and high-intensity treatment for individual risk factor, customized treatment to target hyperfiltration, inflammation, and fibrosis are needed. And we propose to use, even in hypertensive patients with CKD, these three pillars of ACE inhibitor, SGLT2, and anti-aldosterone are fundamental to break the bidirectional role of the kidney in cardiovascular disease. So with this, I will invite you for next year to our meeting at the International Society of Hypertension in Dubai. Hopefully we can see you all together there. Happy to take any question after the end of the session. Thank you so much.
Thank you, Professor Romero, for the wonderful talk. The next speaker is Professor Gianfranco Prati from Italy, who doesn't really need any introduction. So the title of his talk is Blood Pressure Variability, New Paradigm in the Management of Hypertensive Patients.
Thank you for the introduction. That's quite a hot topic. There is a lot of discussion on this issue. By the way, these are my disclosures. Let me start with some basic physiology. Well, this is blood pressure. As you can see, it's not a number. It's a series of waves. So variability is an intrinsic feature of the cardiovascular system that we cannot deny. We started years ago doing research in this field, and we summarized in this paper, where some friends also present here were contributing, tried to summarize what we know today on the blood pressure variability, and we tried to classify these phenomena into different types, depending on the time window where you are quantifying blood pressure variability. And we can see we have the within beat variability, that the pulse pressure, basically. Within the cardiac cycle, you may have the very short variability beat by beat, which requires continuous recordings. Then you have the short term, which is the reading to reading variability that you can measure during the 24 hour, including the difference between day and night and hour to hour. You might focus on the mid-term variability, which is the day by day, that based on home blood pressure recordings. And finally, you can also consider the long-term variability, which includes the visit to visit and the seasonal changes. There are many papers, as you know, showing that all these components, when they are enhanced, might contribute to cardiovascular risk. Well, the story started many years ago. We are back in the Paleolithic of medicine, if you want. We started in the 80s with our intra-arterial recordings, and that was probably the first paper ever showing that in humans we have consistent blood pressure variability. It's a bit-by-bit recording over 24 hours. In 24 hours you have something like 104,000 blood pressure values, then all can be recorded and analyzed in this way. And you clearly see all the fast changes and the changes between wake and sleep during the night or at the siesta time. So this is the situation where we are working with. And we found that there is a correlation between the mean blood pressure levels and the level of variability. Here you find three groups with increasing mean pressure level, and going from the group with the lowest to the highest 24-hour blood pressure, you also have an increase in the blood pressure variability measured by the standard deviation, which is not evident if you are calculating in percent with the coefficient of variation. That's aging effect. Comparing younger with older individuals, you see always an increase in variability, both in absolute terms and in percent. So we have factors affecting variability, and this is telling us something very practical. When you compare a normotensive and hypertensive individual, of course you face a difference in mean blood pressure levels, that's obvious, but you also have to face, as you have seen in these slides, a difference in the amplitude of blood pressure fluctuations. So the research question we started addressing at those times was whether cardiovascular risk is associated only with a change in the mean blood pressure level, the classic concept of hypertension, or whether there is also a contribution of the different level of blood pressure variability. And many studies try to quantify this phenomenon. And basically, as you know, we have several pieces of evidence showing that increased variability might contribute to cardiovascular damage independently from the impact of mean blood pressure levels. Again, that was probably the first study showing that this is the case in humans. Again, this was done with the intra-arterial monitoring in 108 hypertensive patients classified in quintiles of mean blood pressure levels. And for each quintile, you have subgroups, the yellow and the red, respectively with the lower or higher blood pressure variability. The lower panel shows the organ damage quantified by a score. So of course there is an increase in organ damage with the increase in mean blood pressure, which again is just the impact of hypertension. But for each blood pressure mean level, you find that those with a higher variability also had greater organ damage, which means that blood pressure variability contributes independently to organ damage on top of the mean blood pressure impact. Many studies were confirming this, that a WICAP study focusing on the brain damage, the white matter lesion of the incidence of brain infarct. And there is a progressive increase going from those with low mean pressure and low variability to those with low mean pressure but only high variability, and vice versa, those with an increase in mean value but a low variability. And the worst situation is when you have an increase in both mean blood pressure and variability. This is a nice study by Paolo Palatini in young hypertensive. Again, you find that independently for the mean blood pressure, those with a higher variability had a higher incidence of stroke, coronary events, and cardiovascular events in the follow-up, again emphasizing the importance of the independent contribution of blood pressure variability. The Spanish registry, that more than 59,000 patients having ABPM in daily practice, also analyzed the impact of blood pressure variability, and they found again by quantifying blood pressure variability over the 24 hours in different ways, separately for the day and the night time, or with the weighted standard deviation of the 24 hours, or the average real variability, which is the reading to reading variability. And in all cases, they found an increased prediction of total and cardiovascular mortality in those with an increased blood pressure variability independently from the index that we were using for the quantification. But then studies focus on the home day-by-day variability. That's a Hoazama study. And they found that also in this case, those with the highest day-by-day variability had the greater incidence of cardiovascular mortality. And finally, data on the visit-to-visit variability, the long term. That's the classic paper by Peter Rothwell that was retrospectively analyzed in the UK TIA and the Ascot BPLA study, and they showed that an increased visit-to-visit variability is associated with a higher risk of stroke and coronary events. Altogether, this was summarized in a nice meta-analysis by Stevens and McManus, and for the different types of variability, they confirmed that there is an association with mortality. This is the case for the short-term variability over the 24 hours, the mid-term home day-by-day variability, and the long-term visit-to-visit variability, both for mortality and stroke. So we have solid evidence supporting this association. The next question is, if an increased variability is a risk factor, what should we do then? Should this be a target for treatment? In other words, should we target not only mean pressure, but also blood pressure fluctuations? Well, in theory, if our aim is to protect our patients with treatment, then of course we want to reduce the blood pressure-related cardiovascular risk. And this might imply the need to reduce, of course, the mean pressure level, that's very solid, but also maybe to reduce blood pressure variability. Unfortunately, we don't have yet intervention trial providing this evidence. That's why the guidelines are still a bit uncertain, but we have some evidence anyway. If you compare a reduction in a blood pressure profile, for example, this is a classic profile in hypertension, the ideal situation would be using long-lasting drugs, smoothing out the profile over the 24 hours. What we often do, however, is using short-lasting drugs, and we have this kind of behavior with an excessive fall at peak time and an escape at trough. So with this kind of treatment, you are increasing variability, not reducing it. That could be a problem. We developed some years ago the smoothness index, very simple statistical index quantifying how smooth is the blood pressure reduction by treatment. And you clearly see, as compared to placebo, that use of long-lasting drugs such as amlodipine or telmisartan is increasing the smoothness index at the level of 1, which indicates some protection. If you combine, as we do now with combination treatment, long-lasting drugs, typically again amlodipine and telmisartan, the smoothness index is much greater. So a very simple approach could be using combination of long-lasting drugs to buffer variability. And this can be quantified in different ways, for example, calculating the time in therapeutic range, which means the time you spend with blood pressure control over 24 hours or even on a visit-to-visit basis. And this was shown recently also by Professor Cario using home blood pressure, that if you have a time on treatment range greater than 67% of the time, you might have protection against cardiovascular events, which is enforcing the concept that a stable control of blood pressure, reducing variability, may provide cardiovascular protection. The last question is there any special drug that might be more effective in buffering blood pressure variability? Well, we have some evidence on the long-lasting calcium channel blockers. That's the excellent study carried out in France by Dr. Chang. They were comparing placebo, candesartan, indapamide, and amlodipine on the effects on blood pressure variability on the daytime, the nighttime, the 24-hour. And clearly you see that amlodipine was the best reducing blood pressure variability, with some effect also of the diuretic, the indapamide. So we have some indication here. Well, this is a meta-analysis we carried out in collaboration with George Stergiou in Greece, analyzing the ASCOT, the CAMELOT, and the HOLET studies and comparing people treated with amlodipine or with other drugs. And you find that those having a randomization to amlodipine had a reduction in blood pressure variability and also a clear reduction in the primary endpoint, mortality and stroke. Again, supporting the concept that reducing variability might be useful in a clinical setting. Although again, that's a meta-analysis, not an intervention trial. So we still need more evidence in this direction. And finally, there was recently the publication of the long-term effects of the ASCOT trial to demonstrate a kind of legacy effect after 20 years of follow-up. And what they found in this study was that people after 20 years had a lower events rate when they still had a reduction in blood pressure variability, and this was more evident than the impact of the reduction in mean blood pressure levels. And this was obtained for the different endpoints and was due to the subgroup treated with amlodipine at that time. So the conclusion was that systolic blood pressure variability visit to visit was a strong predictor of outcome, even in those with controlled mean blood pressure, and those having an amlodipine-based treatment over the long-term follow-up had a much better outcome than those based on atenolol, which was driven by a reduction in systolic blood pressure variability. We prepared an editorial on this, try to push a little bit the concept. In other words, blood pressure variability probably is now something we should consider in daily practice. It's not only something for addicted, but should be something clinicians might well consider. This is evidence enough to support the concept that we have to pay attention to fluctuations and not only to mean blood pressure levels. And just to conclude, as my take-home message is certainly variability is an intrinsic feature of the blood pressure. That's a physiology, nothing new, but it's something to consider in daily practice over different time windows. We have evidence that there is an association between increased blood pressure variability in the different time windows and the occurrence of organ damage, cardiovascular events, and mortality independently from the average blood pressure levels. Of course, we need more evidence, and what is still missing, there's a difficult study to run, that's why we still don't have enough evidence here, is the demonstration that if you reduce blood pressure variability by treatment, you improve outcome. There are some indirect data in animals, in small groups of patients, but we don't have big trials because they are quite expensive. And it's difficult to run them in our times. But nevertheless, I think we might agree that while waiting for these studies, we have enough evidence at the moment to consider blood pressure variability not only in research, but also in a clinical setting. Because we have data enough showing that if you use long-lasting drugs, drug combination, you can smooth out the blood pressure profile. And this has been shown to correlate with a lower level of cardiovascular damage. But of course, to achieve this, we need accurate blood pressure monitoring. That's a mandatory input. And probably here there is space for the cuffless in the future that might help us controlling better this situation. So final conclusion could be then, based on the available evidence, we should consider maybe both average blood pressure and variability. They are interconnected. Of course, we need more research to be more precise in this direction. Thank you again for the attention. This is Milan in the nighttime. You can see also Milan in the daytime. There's a lot of architectural variability here, and we are working on this as well. Thank you for your attention.
Thank you, Professor Parati, for your beautiful talk on blood pressure variability. Let me introduce the next speaker. It's Professor Andrzej Januszewicz from Poland. He's a distinguished professor from Poland. He's currently working at the National Institute of Cardiology in Poland. And he's currently the vice president of the European Society of Hypertension and will be the next president of ESH starting from next year. So the title of his talk will be Malignant Hypertension as a Multi-Organ Damage, What We Learned from the Recent Studies. Please.
Good afternoon, Professor Parks. Thank you very much for your so kind introduction. And again, thank you very much for so kind invitation to Seoul for the first time, and it's a great experience for me. And as mentioned, I will cover the topic of malignant hypertension and also will raise several questions what we learned from clinical studies. I divided my talk into a few consecutive parts, and let me start from the modern definition of malignant hypertension, which is recognized as a very old clinical entity. There is one problem involved, and please note that all current guidelines, particularly of European Society of Hypertension, European Society of Hypertension, they are providing a very unclear and not precise definition of malignant hypertension, just summarizing that is a hypertensive emergency associated with severe blood pressure elevation, with vascular damage, retinopathy, and only American guidelines are clearly saying that malignant hypertension is associated with multi-organ damage. Also, I went through all updated Korean guidelines for Korean Society of Hypertension, and please note that also in your guidelines malignant hypertension is not pinpointed, and is only mentioned that we should evaluate kidney function in hypertensive patients with severe hypertension and also perform fundoscopy in patients with diabetes and/or severe hypertension. That was the reason that in 2024, together with our colleagues, Professor Franz Messerli, Van den Born, Professor Reinhold Kreuz, our past president, and also with our French colleagues, we prepared a position paper published in JACC, and we clearly propose a new definition of malignant hypertension as a hypertensive emergency associated with microvascular damage and multi-organ damage. Let me now switch to pathophysiology of malignant hypertension, and the first report is coming from the United States from Professor John Lara Group, and together with my mentor, Professor Włodzimierz Januszewicz from Warsaw, Poland, they first described in 1960 that patients with malignant hypertension were characterized by a very high increase in aldosterone plasma level. This was then confirmed by Van den Born in multiple studies, and Van den Born clearly associated the activation of renin-angiotensin system with increased plasma renin activity and also with cardiovascular damage. So taken together, pathophysiology of malignant hypertension is very complex, is multifactorial, and is involving thrombotic microangiopathy, inflammation, and several immunological factors. There is one problem involved, that we don't know the triggering factor of malignant hypertension, and we may also conclude that it's a kind of vicious circle of pathophysiology involving several and multifactorial factors. Sorry, it's not working. I need your help because it's not working, and it's working again. Now, I would like to switch to the prevalence of malignant hypertension, and please note that first of all, malignant hypertension is more common in male than in women, and also please note that the mean age of recognition of malignant hypertension is 47 years, both in females and in males. And we may assume in Europe that the prevalence of malignant hypertension are 2 new cases per 100,000 individuals per year, and also please note that the prevalence and increased prevalence of malignant hypertension in Europe is definitely associated with migration, and the prevalence is 4 times higher in patients who are migrating from Africa or some parts of Asia. So migration has a very important role in the pathogenesis and development of malignant hypertension. The next question which should be raised is if malignant hypertension is a vanishing clinical entity, and the answer is definitely not. And please note that over 4 decades, the prevalence of malignant hypertension is relatively stable across Europe and also across the United States, but in the past few years, over the period of 5 years, we observed the increase in the prevalence of malignant hypertension on both continents, both in Europe and in the United States. Let me now define malignant hypertension and raise the concept of a new concept of multi-organ damage, and let me present Dr. Romain Boulenstraud, who was awarded by European Society of Hypertension 5 years ago with a scientific award of our society. And Dr. Romain Boulenstraud founded and started so-called HAMA registry, which is now developed in France and is including 36 clinical centers. And HAMA study registered so far more than 600 patients with malignant hypertension. I was very fortunate to be invited by Dr. Romain Boulenstraud to this French registry. So over the past year, we entered HAMA registry together with my colleagues in our Department of Hypertension in Warsaw, Poland. And please know that until now, over the past few months, we included almost 30 patients fulfilling a very strict criteria of multi-organ damage, being present in the brain, eye, fundus, heart, and in the kidney. And let me very briefly present the organ damage, and let me start from brain. And we know that the very high values seen in patients with malignant hypertension may cause a damage of blood-brain barrier, leading to vasogenic edema and to the development of so-called posterior reversible encephalopath syndrome seen in some patients with malignant hypertension. The main clinical signs and symptoms manifestations include encephalopathy, headaches, seizures, or visual loss and visual disturbances, and PRES is mostly leading to the focal intracerebral edema. Fortunately, this very dangerous clinical entity is reversible both radiographically and clinically, and has fortunately favorable diagnosis. A HAMA study clearly showed that patients with malignant hypertension, if subjected to magnetic resonance, are characterized by multiple cerebral injuries seen in almost 78% of patients, even in patients with malignant hypertension who are completely neurologically asymptomatic. Let me now switch to the second target organ damage, to eye fundus and to the microcirculation, and please note that our European Society of Hypertension guidelines, they are clearly recommending to perform fundoscopy in those patients who have severe hypertension and are suspected to develop malignant hypertension. Also, please note that we have several clinical evidences that advanced retinopathy has a predictive value for all-cause mortality in patients with malignant hypertension. We should also remember that this most severe form of hypertension may lead and may result in acute loss of vision, and we also know that prompt antihypertensive treatment may restore vision in those patients. Let me now switch to the kidney, and we know that kidney and glomeruli and arterioles are characterized by ischemic wrinklings of the glomerulus and also by fibroid necrosis of small arterioles, and this is leading to the kidney damage seen based on the HAMA registry in almost 50% of patients with malignant hypertension. And finally, heart. We know that heart is also involved in malignant hypertension. Our colleagues from Great Britain clearly demonstrated that most patients, up to 80%, are characterized by LVH and also by systolic dysfunction and left atria dilatation. As mentioned before, most of the patients with malignant hypertension are characterized by left ventricular hypertrophy, and also, based on our recent study, which is performed in our National Institute of Cardiology and is based on MRI imaging of the heart, we may say that malignant hypertension is causing profound structural changes in left ventricle characterized by edema and fibrosis. And finally, for the remaining part of my talk, I would like to focus on the treatment, which of course depends on the etiology of malignant hypertension. We know from the HAMA study that more than 60% of patients are developing malignant hypertension as a cause of non-adherence and not treated hypertension or neglected in treatment hypertension, and the remaining part, ranging from 10 to 30, 40%, are developing malignant hypertension because of secondary hypertension. The most common is AG nephropathy, followed by renovascular hypertension, and sometimes by primary aldosteronism. Also, in the treatment of malignant hypertension of acute phase, we should take into consideration central nervous system involvement and adjust target blood pressure based on coexisting conditions. And also we should treat newly diagnosed malignant hypertension as an emergency requiring intensive care unit care and IV drugs during the first 24-48 hours after admission. However, we should remember that early use of ACE inhibitors and also sartans is particularly relevant and indicated in patients with malignant hypertension to prevent organ damage and mostly to prevent renal damage. We should also remember that use of ACE inhibitors should be started at the lowest doses, followed by progressive up titration and addition of other antihypertensive drugs. And finally, is my last point, the follow-up of patients with malignant hypertension. Please note that in the epoch of complete pharmacological nihilism in the treatment of hypertension in 40s and 50s of the 20th century, the mortality related to malignant hypertension was exceeding 90% and was ranging between 90 and 95%. Now, with the development of pharmacological treatment of hypertension, these numbers are reversed, and survival rate in patients with malignant hypertension is ranging from 90 up to 98%. However, we should remember that patients, even successfully treated for malignant hypertension, they are very prone to develop progressive renal function decline, and 30% of patients are requiring dialysis in the 5-year follow-up. So we should remember that short and long-term follow-up of patients with very careful blood pressure monitoring is crucial for the future of patients with malignant hypertension. Mr. Chairman, ladies and gentlemen, I would like to thank for your very welcome hospitality, for your invitation, and thank you very much for your attention. And also, I would like to invite all of you to our ESH meeting, which will be held for the first time in Poland, in beautiful Gdańsk in 2026, in the last week of 2026, together with Professor Krzysztof Narkiewicz from Gdańsk. We are co-presidents of this meeting, and again, thank you very much for your warm hospitality extended over me and my wife, and you are very welcome to our meeting next year in May. Thank you very much for your attention.
Thank you, Professor Janusewicz, for the beautiful talk. So we'll start the panel discussion. We have 3 excellent panelists, Professor Ji-Yoon Lee from Korea University, Professor Young-woo Jang from Gachon University, and In-jung Cho from Ewha Women's University. Can you please start the discussion?
Thank you for the wonderful lecture. I was very happy to hear these lectures from the leading experts. And I have a question to Professor Romero. As a nephrologist, I was wondering, how do you monitor the out-of-office BP monitoring of CKD patients? Because as you mentioned in the lecture, the patients with CKD has a sympathetic overactivity, which is related to masked hypertension, and CKD patients are prone to have masked hypertension. So do you do some ambulatory BP monitoring, or how do you educate them to monitor their own BP?
Well, let me tell you first that in the United States, ABPM is not very popular. I mean, most of the time you don't get reimbursement, so it's not quite common to do it. In Latin America, we used to do a lot that. In non-dialysis patient, it's very important to look at, remember that CKD is also cause of resistant hypertension, so it's very important to have ambulatory monitoring blood pressure measurements. And home blood pressure also is a very good tool to detect this, to get our patient control. And of course, patient on dialysis is another chapter. You need to look for an in-between dialysis day to do a BPM to have a true value of the blood pressure measurement. And some centers, especially in Europe, sometimes they use 48 hours ABPM to have a better picture of the reality of the patient.
I have a question to Dr. Wang. Great inspiring talk about the dosing regimen. So now I understand that there's no superiority of the nighttime dosing or evening dosing compared with the conventional morning dosing. My question is, I saw a recently published Oman trial from the Chinese group, which compared evening dosing and morning dosing in patients with nocturnal hypertension, and I think they reported that the evening dosing had better blood pressure control. So I was wondering what's your thoughts about those dosing regimens in nocturnal hypertension?
It's possible, as I said, probably the difference is very marginal, and only in a small fraction of patients. For instance, those patients with nocturnal hypertension or early morning hypertension, evening dosing or bedtime dosing can improve blood pressure control over sleeping or early morning hours. That's, I think, something we should investigate in the future, not in the overall population, but possibly in a small fraction of patients.
I see. Then following up on your comments regarding the Hydra trial, you mentioned that there was not a huge difference in blood pressure, although the evening group had better outcomes. Then what do you think was from that trial the driving force of the improved benefit from the evening dose?
Actually, nobody knows what happened to the patients because that group published some studies many years ago with also some concerns from scientific community. I think this study again raised a very big issue of clinical trial quality. So if you do a very big trial with low quality, you may produce misleading results. For instance, some of those trials included in the meta-analysis, they clearly graded those studies with low or very low strength. So they don't use the word quality, but certainly low strength means low quality. So that's, I think, a problem of randomized controlled trials. Actually, in the current clinical research, many questions are not necessarily investigated in randomized controlled trials. And then for this research question, actually, in the overall population, you actually don't have to investigate the question, but in a small group of patients, for instance, with nocturnal hypertension, early morning hypertension, probably it's worth investigation for the nighttime dosing versus morning dosing. Thank you.
Thank you for the great lectures. I have a question for Professor Parati. You show that BP variability is an important factor and affect cardiovascular outcomes, but there's not an efficient way to reduce the BP variability, and you only show that long-term drug might be effective. But how about, do you think about nighttime dosing if a patient have nighttime blood hypertension, and if by nighttime dosing, if we can recover the circadian rhythm of BP, how do you think about it to reduce BP variability?
Oh, thank you. That's a very, very good question. Of course, in 15 minutes you cannot say everything, but the nocturnal behavior of blood pressure is something important and different. The day-night change, the reduction in the night, is considered a kind of protective type of variability, because this is reflecting a reduction in the sympathetic nervous system modulation and in many other mechanisms. So that's why when calculate the 24-hour variability, we are proposing the weighted standard deviation, which is calculating the reading to reading variability excluding the day-night change, because that's a different story. And that's the complexity of physiology, basically. So considering the night, of course, we have to try to preserve the dipping at night, which is a good sign of a well-maintained control of the cardiovascular system. However, if you consider some studies, for example, the study again from Paolo Palatini that was focusing on variability during the night, so reading to reading during the night. Also in this case, if you have an increase, there is an increase in damage and outcome. The administration of drugs in the evening, we go back to what Professor Wang was saying, might help in case of specific situations. If you have a kind of patient, like typical example, Parkinson's disease. These people have daytime hypotension and nocturnal hypertension, and the problem is only confined when they are lying supine in the night. So in such a case, it might be useful to administer a short-acting drug only in the evening, but a specific situation. In all the other cases, if you're using long-lasting drugs, they cover the 24-hour well enough, and there is no major difference between giving the pill in the morning or in the evening. Although, as you mentioned, so the Oman study was showing some better result in the night, but clinically speaking, the difference not been shown to carry any difference in outcome. So we need definitely to stick to the outcome-based evidence.
Any other questions or comments from the floor?
I have a question to Dr. Janušević. As you mentioned, the incidence of malignant hypertension is rising in Europe and the US. Should there be a reason for that? Maybe is it the diet or the elevating BMI, or can we explain that?
Yes, I think that as I mentioned in my talk, the principal reason to observe such an increase in the prevalence of malignant hypertension is the effect of migration. I gave evidences that the prevalence of malignant hypertension is almost 4 times higher in migrants in Europe coming from mostly Africa, North Africa, South Africa, and this is the main reason, because all these visitors, all these people coming to Europe are under worse medical treatment, the non-adherence is very high, etc., etc. So I think it's one of the most important reasons. And the second important reason is that, as I gave evidences, 60% of patients who developed acute phase of malignant hypertension, they have untreated or not regularly treated essential hypertension, and this it's a prevalence, the rising prevalence of malignant hypertension is also reflecting the problem of rising prevalence of non-adherence within hypertensive patients. I think these are 2 major factors for that.
Professor Janušević, one question is, there are some patients, untreated patients, who do not go on to have malignant hypertension, and some people go on to have malignant hypertension. So what do you think is the trigger? So are there any clinical parameters or biomarkers that could identify those who are at risk for progressing to malignant hypertension?
It's an excellent question. And again, as mentioned in my talk, the trigger for development of malignant hypertension is not known until now. This is one of the goals, aims of the HAMA study, HAMA registry ongoing, as mentioned, in France, that will be trying with our French colleagues, also in Poland, to identify, having a lot of data, clinical data on covering the large group of patients with malignant hypertension, will try to identify one single factor that being responsible and triggering the development of malignant hypertension. Until now, this factor is unknown. Together with Professor Tomasz Guzik from Poland, once we performed a study aimed to identify immunological factors in patients with malignant hypertension. This study was done 8 years ago on a relatively small group of patients, and again, we were unable to identify one single immunological factor being responsible for the development of malignant hypertension, because this is the most plausible mechanism in this form of severe hypertension.
Thank you. Any other comments? If not, we have to have a ceremony before we end this session. It's giving out the plaque of appreciation to all our invited speakers.
Yeah.
So,
As Professor Bach said, we have a plaque presentation ceremony for invited faculties who contributed to the success of Hypertension Seoul 2025. And Professor Park will present the plaque. And Andrei Yanushevich. In deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2025, in conjunction with the 63rd Scientific Meeting of the KSH, November 8, 2025. Okay, next person please, Cesar Andres Romero. In deepest appreciation for your dedication and contributions to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2025, in conjunction with the 63rd Scientific Meeting of the KSH, November 8, 2025. Okay, last person is Ji-Gang Wang. In deepest appreciation for your dedication and contributions to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2025, in conjunction with the 63rd Scientific Meeting of the KSH, November 8, 2025.
okay, for those of you who are who wonder why we're not giving the plaque to Professor Parati, he already received his, so. Okay, so we'd like to thank all the 4 distinguished speakers for their great talks and the 3 panels for their great discussions. So I will end this session at this moment. Thank you very much.
시간이 됐지만 아직 룸 D가 종료되지가 않았다고 합니다. 그래서 잠시 기다려서 D가 마치는 대로 바로 클로징 세레머니 시작하도록 하겠습니다. 예, 안녕하십니까. 대한고혈압학회 총무이사 김광일입니다. 하이퍼텐션 서울 2025 제63회 추계학술대회에 참석해 주신 모든 분들께 감사드리며 특별히 끝까지 이 자리 빛내주고 계신 여러 선생님들께 다시 한번 감사의 말씀드립니다. 지금부터 추계학술대회 보고 및 폐회식이 있겠습니다. 대한고혈압학회 신진호 이사장님의 인사 말씀이 있으시겠습니다. 또 박수로 환영 부탁드리겠습니다.
이렇게 유종의 미를 거두기 위해서 끝까지 함께해 주신 여러 선생님들 화이팅 감사드리고요. 꼭 럭키 드로우에서 좋은 성과가 있기를 기대하겠습니다. 감사합니다.
예, 감사합니다. 그러면 추계학술대회에 그 보고 드리도록 하겠습니다. 예, 추계학술대회는 저희가 이번에 처음으로 이틀 반, 예, 그래서 목요일부터 토요일까지 진행을 하였습니다. 오프라인으로 진행하였고 지금 등록자가 제가 지금 통계가 잘못됐나 해서 다시 한번 확인했는데 처음으로 저희가 800명이 넘었습니다. 그래서 808분이 현장에서 등록을 해주셨습니다. 예, 감사합니다. 좋은 프로그램을 만들어 주신 학술이사님 그리고 여러 상임이사님들께 다시 한번 감사의 말씀드리고 또 끝까지 자리해 주신 선생님들께 다시 한번 감사의 말씀드리겠습니다. 저희 학회가 잘 진행될 수 있도록 이렇게 많은 메인 후원사 및 부스로 참여해 주신 여러 회사들의 후원이 있었기에 성공적으로 학회를 할 수 있었던 것 같습니다. 후원해 주신 여러 후원사 여러분들께 다시 한번 감사의 말씀 드리겠습니다. 예, 다음 슬라이드 주십시오. 예. 오늘 오전에 평의원회가 있었습니다. 그래서 대한고혈압학회에서 결정됐던 주요 사항에 대해서 보고 드리도록 하겠습니다. 다음 슬라이드 주십시오. 예, 신임 임원이 되겠습니다. 그래서 차기 회장은 전남의대 김수환 교수님께서 내년부터 맡아주시기로 하셨고요. 제가 부족하지만 내년부터 2년간 대한고혈압학회 차기 이사장으로 열심히 노력해 보도록 하겠습니다. 감사합니다. 예, 내년부터 이제 2년 동안 그 고혈압학회를 위해서 수고를 해주실 25분의 신임 임원진이 되겠습니다. 그동안 고혈압학회에서 많은 능력을 보여주셨던 분들과 또 새롭게 이사진으로 참여를 해주실 분들이 많습니다. 그래서 많은 기대와 또 여러분의 성원과 지지 다시 한번 부탁드리겠습니다. 다음 슬라이드 주십시오. 본 학회가 이제 여러 방에서 나뉘어서 이렇게 진행이 되다 보니까 꼭 듣고 싶은 강의인데 다른 방에서의 역할이 있어서 이제 못 들으신 분들이 많으실 것 같습니다. 그래서 온디맨드 VOD 서비스가 준비가 돼서 준비가 되는 대로 저희가 다시 한번 공지하도록 하겠습니다. 굉장히 좋았던 강의들 다시 한번 꼭 들으실 수 있는 기회 가지시기 바라겠습니다. 감사합니다. 다음 그 학회 일정에 대해서 소개해 드리도록 하겠습니다. 춘계학술대회는 2026년 5월 22일부터 23일까지 광주 김대중 컨벤션 센터에서 개최 예정이고요. 하이퍼텐션 서울 2016은 내년도 11월 5일부터 11월 7일까지 이곳 콘라드 호텔에서 개최될 예정입니다. 내년에도 좋은 프로그램으로 많은 분들의 그런 관심과 성원 받을 수 있도록 노력하도록 하겠습니다. 다음 슬라이드 주십시오. 대한고혈압학회 서울개원이 및 전공의 연수 강좌가 12월 21일 이곳 콘라드 호텔 5층 파크 볼륨에서 개최될 예정이고 여러 선생님들이 특히 전공의 선생님들이 궁금해할 내용으로 강의를 준비하였습니다. 그래서 많은 분들의 관심과 참여 부탁드리겠습니다. 다음 슬라이드 주십시오. 고혈압학회에서는 이제 젊은 연구자들을 위해서 저희가 윈터 스쿨을 준비를 했고 1박 2일 동안 고혈압과 관련된 그런 주요 강의들을 아주 집중적으로 참여하셨던 분들이 이렇게 몰아넣고 지식을 쏟아부어주는 그런 시간이었다라고 하는데 참석해 하셨던 분들이 굉장히 만족도가 좋은 에듀케이션 프로그램이 되겠습니다. 고혈압에 관해서 기초부터 시작해서 임상까지 1박 2일의 아주 단기간의 속성 코스로 완성시켜드리는 코스고 매년 저희가 정해진 그 숫자의 선발을 통해서 이루어지고 이 그 교육에 참여하신 분 중에 일부는 또 유럽의 ESH 서머스쿨에도 갈 수 있는 기회를 드리고 있기 때문에 많은 관심 부탁드리겠습니다. 다음 슬라이드 주십시오. 예, 여러 가지 학회 기간 중에 있었던 내용들에 대해서 수상하는 시간을 갖도록 하겠습니다. 먼저 첫 번째로는 학술 연구비 당선자입니다. 원래는 이제 공고만 했었는데 올해부터는 실제 저희 폐회식에서 수상하도록 하겠습니다. 예, 학회의 그 연구비 이 전달은 이사장님께서 전달해 주시겠습니다. 호명된 교수님께서는 앞으로 나와 주시기 바라고 한 분씩 사진 촬영 후에 단체 사진 촬영이 있으니 무대 옆쪽에서 대기 부탁드리겠습니다. 연세의대 강희택 교수님. 예. (2025) 학술연구비 지급 결정서 성명 강희택 소속 연세의대 연구과제명 인공지능 기반 고혈압 발생 및 심혈관 사건 사망 예측 모델 개발 및 도구화 연구비 1천만 원 연구기간 2026년부터 1년간이 되겠습니다. 귀하의 연구과제가 2025년 대한고혈압학회 학술연구과제로 선정되어 본 증서와 연구비를 수여합니다. 연구 결과를 클리니컬 하이퍼텐션에 투고하여야 합니다. 네, 하여야 합니다라고 되어 있습니다. 예, 축하드립니다. 다음은 연세의대 김민관 교수님인데 사정상 정인영 교수님께서 대신 와주셨습니다. 학술연구비 지급결정서 성명 김민관 소속 연세의대 연구과제명 고혈압 발생에서 유전 인자와 생활습관의 역할 비교 이하 내용은 같습니다. 다음은 고신의대 김봉준 교수님이십니다. 학술연구비 지급결정서 성명 김봉준 소속 고신의대 연구과제명 혈액투석 환자에서 혈압 변동성에 따른 무심실 스트레스 변화의 비교 이하 내용은 같습니다. 축하드립니다. 다음은 한양의대 김현진 교수님. 학술연구비 지급결정서 성명 김현진 소속 한양의대 연구과제명 웨어러블 반지형 혈압계와 24시간 활동혈압 측정 검사를 이용한 고혈압 표현형 평가 및 불일치 환자군의 임상적 요인 분석 이하 내용은 같습니다. 축하드립니다. 다음은 서울의대 이용준 교수님. 학술연구비 지급결정서 이용준 소속 서울의대 연구과제명 급성기 뇌경색 중 대혈관 죽상경화증 기전에서 초기 혈압과 조기 신경학적 악화의 상관관계 이하 내용 같습니다. 단체 사진 촬영이 있겠습니다. 예, 모두 축하드리고 기획했던 연구 잘 수행해 주시고 좋은 결과를 클리니컬 하이퍼텐션에 투고해 주시면 더욱더 감사하겠습니다. 다음으로는 학회지 시상이 있겠습니다. 학회지 시상도 신진호 이사장님께서 진행해 주시겠습니다. 우수 심사위원상부터 시상하도록 하겠습니다. 연세의대 신동호 교수님. 우수심사위원상 성명 신동호 소속 연세의대 상기인은 2025년도 클리니컬 하이퍼텐션의 우수심사위원으로 선정되었기에 이 상장과 상금을 수여합니다. 2025년 11월 8일 대한고혈압학회 이사장 신진호 축하드립니다. 다음은 한양의대 신정훈 교수님이십니다. 우수 심사위원상 성명 신정훈 소속 한양의대 이하 내용은 같습니다. 축하드립니다. 다음은 학술상이 되겠습니다. 학술상은 클리니컬 하이퍼텐션에 게재된 논문 중에 가장 많은 인용을 받은 논문이 되겠습니다. 수상자는 서울의대 김학영 교수님이십니다. 학술상 성명 김학영 소속 서울의대 상기인의 논문은 2025년도 클리니컬 하이퍼텐션지에 게재된 논문 중 우수 논문으로 선정되었기에 이 상장과 상금을 수여합니다. 2025년 11월 8일 대한고혈압학회 이사장 신진호. 다음으로는 추계 학술 대회 기간 중에 있었던 일반 연재의 시상이 있겠습니다. 전달은 이사장님께서 진행해 주시겠습니다. 먼저 영 인베스티게이터 어워드입니다. 수상자는 서울의대 강지혜 선생님, 그다음에 하버드 유니버시티 조소미 선생님이십니다. 영 인베스티게이터 어워드 네임 강지혜. Title: Genetic Predisposition, Recalibrate Blood Pressure Threshold for Cardiovascular Disease Risk. On behalf of the organizing committee of the 63rd Scientific Meeting of Korean Society of Hypertension, we grant this award with great pleasure to you for Young Investigator Award, November 8, 2025. The President 진호 신. 축하드립니다. 두 번째 수상자는 조소미 선생님이십니다. Young Investigator Award, name 소미조, affiliation Harvard University. Title: Blood Pressure Polygenic Score, Predict Long-Term Blood Pressure Control and Treatment-Resistant Hypertension. 이하 내용 같습니다. 축하드립니다. 다음은 클리니컬 리서치 어워드 수상 있겠습니다. 수상자는 2명입니다. 서울의대 김학영 교수님, 그다음에 서울시립대학교 재세영 교수님이십니다. Clinical Research Road 성명 김학령 소속 서울의대 연구 제목 The Variability of Pulse Wave Velocity and the Long-Term Cardiovascular Outcome, a Prospective Observational Study. 상기인의 논문은 Hypertension Seoul 2025에 대한고혈압학회 추계국제학술대회에서 발표한 클리니컬 리서치 어워드에서 우수한 연구과제로 선정되었기에 이 상장과 상금을 수여합니다. 2025년 11월 8일 대한고혈압학회 이사장 신진호. 김학령 선생님 오늘 큰 턱 한번 내야 될 것 같습니다. 제세영 교수님. 클리니컬 리서치 어워드 성명 제세영 소속 서울시립대학교 연구 제목 Comparative Prognostic Value of Absolute and Fitness Adjusted Exercise Systolic Blood Pressure Metric for All Cause and Cardiovascular Mortality. 이하 내용은 같습니다. 축하드립니다. 다음으로 우수 발표자와 베스트 포스터 프레젠테이션은 슬라이드로 발표하도록 하겠습니다. 우수 발표자 8분, 그 다음에 베스트 포스트 프레젠테이션 6분은 모두 축하드리고 나중에 따로 연락드리도록 하겠습니다. 예. 이제부터 여러분들이 기대하시던 경품 추첨 럭키드로우가 있겠습니다. 추첨에 앞서서 공지사항을 먼저 안내드립니다. 대리 수령은 불가합니다. 현장에 계시지 않으면 기회를 잃으시고요. 재추첨을 하도록 하겠습니다. 당첨자께서는 교환권을 지참하셔서 폐식 종료 후에 룸 A 뒤쪽에 보면 저쪽에 상품 수령하는 곳이 있으니 경품과 교환해 주시면 되겠습니다. 먼저 4등 상품이 있겠습니다. 4등 상품은 스타벅스 상품권입니다. 학술 이사님께서 진행해 주시겠습니다. 학술 이사님 무대 앞으로 자리해 주셔서 추첨 진행 부탁드리겠습니다. 그리고 호명되신 분들은 앞으로 나와 주시면 감사하겠습니다. 4분 뽑아 주시면 되겠습니다. 마이크가
넘버 OR50 피한티니
예, 아쉽습니다. 다음으로 넘어가겠습니다.
넘버 OR
한 명 더
49 파자
예, 축하드립니다.
정혜문 선생님.
예. 정 선생님 너무 아쉬워하시는 것 같은데요.
카톨릭의대 장은아 선생님. 안 계십니다. 저기 예, 계십니다.
축하드립니다.
최성훈 선생님.
오. 예, 모두 축하드립니다. 3등과 2등 추첨은 이사장님께서 진행해 주시겠습니다. 이사장님 무대 앞으로 자리해 주시면 감사하겠습니다. 3등 상품은 신세계 상품권입니다.
0665 우리나라 분이시네요. 황경국 교수님.
황경국 교수님 축하드립니다.
이분도 우리나라 분이시네요. 전경현 연세대 선생님, 연세대 교수님.
바로 딱 두 분이 나왔습니다. 축하드립니다. 예, 다음 2등 상품은 네스프레소 버추어 플러스 커피 머신이 되겠습니다.
OR 0025 토하리
축하드립니다. 네, 축하드립니다. 예, 대망의 1등 상품만 남았습니다. 1등 추첨은 정진욱 회장님께서 해주시겠습니다. 1등 상품은 LG 프라엘 멀티코. 예, 굉장히 K뷰티에 많은 분들이 좋아하시는 상품이라고 해서 1등으로 저희가 준비를 했습니다. 저는 잘 모르겠지만 굉장히
31번 카톨릭 의대 김경안 선생님.
오, 축하드립니다. 네, 당첨되신 분들 다시 한번 축하드리고요. 교환권 분실하지 않도록 주의하시고 종료 후에 경품으로 교환해 주시기 바라겠습니다. 마지막으로 대한고혈압학회 정진욱 회장님의 인사 말씀 및 추계학술대 폐 선언이 있겠습니다. 네, 회장님 부탁드리겠습니다.
항상 럭키드로가 끝나면 항상 후회와 왜 나는 안 됐을까 이런 생각을 하실 텐데 여하튼 이런 럭키드로우 시간 때문에 기쁘게 끝까지 기다릴 수 있었던 것 같습니다. 아무튼 끝까지 남아서 학회에 남아 계셔서 발표해 주시고 참석해 주시고 럭키드로우까지 참석해 주신 여러 선생님들께 깊이 감사드리며 이번 모든 일정 이제 다 마쳤으니까 건강한 모습으로 다음 학회에서 뵙기를 고대해 보겠습니다. As a chairperson of the Korean Society of Hypertension, I would like to thank you all as we close this meeting. As we conclude the program, I hope this conference has provided valuable inspiration for your clinical practice and research. Let us continue working together, and I'm looking forward to see you again at our next meeting in good health. Thank you.
네, 감사합니다. 이상으로 추계학술대 및 하이퍼텐션 서울 2025를 마치도록 하겠습니다. 끝까지 참석해 주신 여러 선생님들께 다시 한번 감사의 말씀드립니다. 감사합니다.